Dr. Antav, are you there? Dr. Antav? Anyway, good morning to all of you. Good morning to our esteemed international faculty. Today we have the giants of endoscopy with us. May I please request Dr. Yumjinwa to come in front. Dr. Siok Bongjung, Dr. Lufti Gatham, please come in front, sir. Dr. Somanshur, please come in front. And rest of all the faculty also come in front, please. The sofas are all for you all. Please come, sir. Dr. Bong, please come here. Come in front, please. Please honor us. Abhishek, come, sir. Please sit here, sir. Please be comfortable here, wherever you'd like. Atmaranjan, आगे आ जाना बेटा, पीछे क्यों? We have the delegates joining us now. So let us start with the basic lectures today on monoportal and monoportal technique. Hello. In the morning was a demonstration as to how monoportal is done. So that was the part, what we have tried and what I explained yesterday is that on a daily basis, we are trying to teach you one new technique. So the mornings are reserved to see the technique, then attend the basic talks of the technique, then decide which technique you wish to pursue in life, make informed choices. That has been the very key concept of this Congress, and that's why we're starting so early, rather than the usual 9:30, 10 o'clock time. So we are going to start with Dr. Siddharth Verma taking some basic lectures, then the rest of the team that are taking the basic lectures, so that you understand exactly how this procedure is done. You may be a specialist in UBV, you may be a specialist in transforaminal, but you may not know much about monoportal. This is your chance to catch up on that. So there's a chance for all-round development of endoscopy. Okay, thank you so much for your kindness and love, and we start day 2.
Thank you, sir. So good morning, all of you. And we'll begin with the very basic talk on the instruments, bit on anesthesia and the OT setup. So this is about the PSLD that is becoming more popular in the last few years. And the instruments, the major difference in the instruments is that this was the innovation of creation of a wider scope, which is known as a stenoscope. So the difference was it was slightly wider than the transforaminal one, and with an 8.4 millimeter outer diameter and 5.7 millimeter working channel. Now even bigger stenoscopes are available, and some people prefer that. The working length is usually 120 millimeter, and there is a 12-degree angle optical lens endoscope, and now many systems are available and with slight variations, and you can choose any one of them. Then there is a drill system. There is a lot of importance attached to the drill because of the bony work which you need to do, which is much more if you are coming from, especially from transforaminal endoscopy as I did. But those doing UB will find a similar bony work. Then Kerrison punches, the whole procedure probably is based on the use of Kerrison punches or drills, depending on what you prefer. And then of course, you check with the hook to bake adhesions, prevent tears. So the instrument set is, this is a instrument set which, probably, this is what I use, but this is not an endorsed talk. So you can see it is quite simpler as compared to the transforaminal instrument set. So basically there is only a simple dilator, or you can take the entry with this, then you have a working cannula, then you have an endoscope, then you have various Kerrisons of various sizes, and you have this probe, and then or a retractor you can call it, and then you have this hook. So you don't need much of instrument sets. Only thing is they are not cheap, they are expensive as compared to the UB set. However, they are much simpler as compared to the transforaminal inventory, where you have a lot of complicated instruments. So these are the basic instruments. Now the other important decision which you will need to make is to buy a drill, an RF, and possibly an irrigation pump. So irrigation pump is not that important. I know many of us still use the gravity method, which is good enough. Only sometimes in cases where you cannot control, you are seeing too much of ooze, you may need to kind of increase the pressure, and in those cases, it may be beneficial. So focus more on having a good RF first, and then later on maybe you can have a better drill or something, and then you can go with the irrigation pump. For those who don't know, even without a drill you can do this, but only the problem is that it is going to take a lot of time, and it's not very good for beginners because drill will thin out the bone and make it very easy for you to punch later on. Uh, so this is for once you start. Ideal is that if you can buy everything together, that would be great. So I personally will recommend to have a good RF. Here you are working much closer to the neural structures than you will in a transforaminal endoscopy. So you need a good RF, and the control should be very fine. And of course, the probes can be varied. For the muscle work, you'll need a stronger current, but for the neural work, you'll need a weaker current. So you can use either two probes, or you can use one probe but then control the current. Otherwise, you can have complications. So for the anesthesia, uh, many of us prefer with GA. I will recommend the beginners can start with GA because your time taken will be more, and patient may get uncomfortable towards the end of the procedure, or maybe in the middle. So later on you can switch to epidural anesthesia when your time kind of reduces. Anything below one hour, 1.5 hour is good enough. And some people have done it in spinal also. You give a little higher spinal, and then by the time it recedes, it gives you enough time. You can tell your anesthetist to add some additive to prolong the effect, and this can be a good option as well. So another thing which I want to emphasize is the position. Here position is important because you want the laminas to open up, especially for the upper lamina. L5S1 will be quite easy, as you can do it in, but then anything above that, especially in a tight spine where you have a lot of stenosis, you will need to maybe give some flexion. So this is the setup which I saw in Korea, and they were using this. Although it's not essential, but this is one of the setups. And you can use a Wilson's frame, adjust the table height because you need to be on top. The main action will be your punch action, and if you are not having enough height, you will face difficulties and encounter. You'll become a patient yourself as you get volumes. So try to avoid that. There is no other special equipment which is required. Uh, if you are doing in regional especially, you need to be careful, use proper knee pads. However, when I came and started for my first case, this is all I could manage, and even this patient was good, but then I realized the importance and brought a Wilson frame thereafter. I think this covers the basic instrumentation. You can just go, there are a lot of literature also available on various types, and you can just go and read about it. Thank you very much. I think there's no questions about this. You can start with the next talk.
Good morning, everyone. So this is a very basic understanding for the port placement of in internal minor endoscopy. So why it's important? I think this could be best answered by somebody who has placed it wrongly and struggled during the initial phases of the surgery. So it's very important to dock your port correctly because proper targeting to get hold on the extruded disc or your disc fragment is very important. If you put your port correctly, you would require very minimal you know resection of the bone or the ligamentum flavum to just land on the extruded fragment. Docking at the right place also helps in decompression properly in stenosis. And of course, it gives a smaller footprint on the spine so that the spinal integrity is maintained. You must understand the interlaminar window and the discal window, they do not coincide. If you see the figure on the right side, it's more like the lady picking up something from the upper shelf. So when you enter the interlaminar window, it would be more like that. So something like which is jutting out from the inferior end plate, or it's a down migrated disc, then you need not to do a elaborate laminotomy or something. You can get hold on the disc fragment easily without cutting much of the bone. But in case you have to place something like a cage inside, you need to be in front of the disc. So that requires a good amount of, you need to coincide the discal window with the interlaminar window. So you need to burr the inferior margin of the lamina to get a proper access to the disc. So you have, lordotic curvature. So if we could, do squaring of the end plates, so we get a proper margins of the disc. And if you could see that this much of the bone we need to sacrifice in case we need access directly to the disc. So that is the main key factor which we have to decide. And this also might not be required in case the disc is inferiorly migrated. So you need not to go up. You can catch hold of the disc directly doing minimal resection. So the disc could be at different points. It could be at the inferiorly migrated or central. Depending on where you have to target, you decide your course. So if you see at the spinal laminar junction, if I put it, the dilator directly, you would coincide with the discal window. So that's what I was intending to tell you, that the discal window and the interlaminar window do not coincide. You need to resect the inferior margin of the lamina to get into the disc. So for the port incision for the disc, extruded fragment or something, you need to mark the entry point as per the surgical pre-planning. It's very important that you read the MRI correctly, you understand where you have to go, and everything should be, the mapping should be done before you take the patient in. Use a spinal needle to infiltrate. It serves two purposes. One, it reduces the bleeding from the muscles, because while doing interlaminar, you bypass the muscles. You go directly land dock onto the bone. So in between, many a times it bleeds, it oozes, and that oozing or the bleeding is the worst enemy during endoscopy. A slightest bleed, it disrupts the vision. And all the more it's a second purpose that you need to again reconfirm the level you are working on. Don't focus on the L4, 5, the number game. Is you count the last mobile fragment, mobile disk or whatever, from counting should be matching with the MRI film. Then you make a stab, you cut up to the fascia and introduce the dilator and confirm in AP and lateral where you are docking. Introduce a working sleeve with the bevel first facing laterally. So the tongue of the bevel, it goes up to the docking, up to the bone, and then you reverse it facing the ligamentum flavum. And after that, you introduce the endoscope. It's just a small, this thing, like you say, it's an inferiorly migrated disc. So in this case, how we dock? We have gone to the facetal-laminar junction, more towards the inferior end. So the dilator has been introduced, and we see it in the lateral view. And then we introduce our working sleeve. Same for the decompression surgery, we need to decide why we require the decompression. What is the purpose? If it's only the posterior decompression, you may go into the middle of the interlaminar window, and so that you could address both the sides. If it's more of a lateral decompression, you dock more towards the facetal pillar, facetal laminar junction. If it's unilateral, more towards one side. If you have to address both the side, you go a little towards the midline. Anterior decompression, you have to address the disc as well. Then you need to be at the, as we did for the disc, because you need to create a discal window. You have to coincide the discal window with the interlaminar window. Laminar burring is done to expose the flaval margin. In stenosis, is more of a bony resection which we need to do. Elaborate decompression should be done. So we expose the margins of the flavum superiorly and inferiorly from the lamina. Lateral decompression is done up to you up to the lateral margin of the disc, lateral margin of the ligamentum flavum. You see that, and after that you start cutting and get good amount of decompression there. Contralateral decompression with burring, you need to go from the, you need to burr the root of the spinous process so that you get access to the contralateral side. Flavectomy is done to expose the contralateral root. You need to be very sure that the roots on either sides are free by mobilizing them. So this is a stenoscope. So like you need to burr the.
What is 30 seconds to go?
Yeah.
Please wrap up fast.
Okay. So this is the same thing. So this is how you hold the scope. You get a hang of it. This is the same case, and it's oriented the same way. So this is the inferior articular process. We are going more towards the inferior side. So you need to palpate if you are, the bony landmarks. And till the ligamentum flavum is intact, you can burr conveniently without any issues. So you use Garrison punches to expose the flavum more. And Garrison punch is used for the flavum
Do it fast.
removal as well.
Yeah.
Yeah, it's almost done. And the disc fragment is teased out. And it's taken out. You check the annular rent after for any loose fragment, and you come out. So this is the basic of removing the disc, because for the beginner it's more important that we go for just discal pathologies first, and then go for the stenosis thing. Happy targeting. Thank you so much.
Thank you, Dr. Madhujit. We don't have time for a discussion. Now we will ask to Dr. Sumit Sonavane for his lecture, OT setup for monoportal. Good morning all, I'm Dr. Sumit and I'm taking you a step back from the previous lecture. So this is the OT setup required for the monoportal surgery, especially the transforaminal. Uh, Basically the OT setup for transforaminal and PSLT, that is interlaminar, would be more or less the same. So if you go by this saying, it's very important to plan all the imagings and the OT setup before we go for the surgery. So before you plan for the surgery for the patient, counsel the patient properly about the necessity of the surgery and how the surgery will go on, and discuss about the type of anesthesia. These surgeries can be done in local, spinal, epidural or general anesthesias. So depending on the surgeon and patient choice, you can choose accordingly. Uh, uh, Discuss the pros and cons with of the surgery with the patient, recovery protocol and complications, explain them properly to the patient, get all the imagings, blood parameters done. If you feel, get EMG, NCV done, and if it's a quad iguana syndrome, get a preoperative pre and post-void urine residue on USG, and if it's a chronic cod iguana, still get a pre and post void urine residue, because there might be some retention. 100 cc in male and 60 cc in female should be considered significant retention. Get proper consents done. On the morning, day before the surgery, give laxative so for the proper abdominal preparation, and there will be less of the gaseous shadows in the intraoperative imaging. Antihypertensive, thyroid medications and insulins as required should be given before the surgery. Give appropriate antibiotics 1 hour before the surgery. Confirm the autoclaving of the instruments, and all the other instruments are like our C-arm and video trolley are functioning properly. Well, I usually use this WHO safety checklist to improve the safety of the patient. You can use bolsters or these specially available pillows. Bolsters can be kept vertical or horizontal depending on the surgeon's preference. This is the schematic view of the OT setup. If you are performing surgery from the right side, so surgeon and assistant will be standing on the right side. The instrument trolley will be on the right side. Your C-arm and your video trolley will be on the opposite side. And you can, if it's a left-sided surgery, it's the other way around. We use this surgery under, we use saline medium for this surgery. So keeping the saline bottle height 100 centimeter above the patient will give appropriate pressure. If you have luxury to use the saline pump, you can use it, and pressure should be around 40 millimeter of Hg. If it's a higher pressure and if there is an incidental durotomy, it's known that the saline enters the dural space, and it might increase the intradural pressure. Use these commercially available drapes which can collect the saline, and the floor will not get wet, or you can use the suction floor suctions. This is a C-arm guided surgery. So to minimize the radiation, ask the staff who can be away to be 3 meters away from the C-arm, and you can keep the generator tube down so that the radiation scatter is down from the table. Check the instruments properly and ask your scrub nurse to arrange them properly. Thank you.
Thank you, Dr. Sumit. We go to next lecture by Dr. Naruzman Khan, basic step skin to disc for endoscopic surgery. So the end of the session, we will discuss for 2-minute discussion time.
Good morning, everyone. Thank you, organizing committee again. My talk is today basic steps of interlaminar discectomy, IELD. This talk is for beginners, not for the masters. IELD was introduced 10 years earlier than IELD. So TELD is innovated before 10 years of IELD. In 2006, interlaminar approach was described by Rutten and Choi to treat lumbar disc herniation and spinal canal stenosis. The evolution of the interlaminar endoscopic spine surgeries are based on a progression of 3-generation endoscopic system. You know, from the interlaminar discectomy to PSLD, that is the posterior decompression, unilateral approach bilateral decompression. The instrument requires for this approach endoscopic curve, interlaminar endoscope, blunt dissector, micropunch, grasping forceps, caisson, bipolar coagulation, and bar with serum. Indication all types of central and paracentral discs at L5S1 and L45 level, paracentral disc L34 and L12, L34 to L12 level, paracentral soft disc, central calcified disc of above levels when planned for posterior decompression only, highly migrated disc, central canal stenosis as well as lateral canal stenosis. Preoperative preparation, we need MRI to locate the herniation properly because it is a targeted surgery. CT scan to see the calcification because in presence of calcification we need the planning, different planning. X-ray is definitely required and ultrasonogram is very important and other investigation as required. Anesthesia usually in this approach, local epidural or general anesthesia we can do, but I prefer single shot epidural analgesia though sometimes I use epidural catheter for multiple level decompression. And this is the positioning of the patient. Patient is placed on prone position on a Wilson frame or with pelvic and thoracic roll. Usually I preoperatively mark over the skin by a AP view and a lateral view. And after that, patient is properly painted and draping done. Patient position and equipment setting, a lot of faculties describe these things. And after proper painting and draping, 7 to 10 millimeter skin incision according to scope diameter in combined skin incision in combined with thoracolumbar fascia is made. You can see the skin incision is given previously marked line by 11 scalpel, then a straight artery forceps inserted through the incision to split the muscle carefully not to penetrate the ligamentum flavum. A dilator is then inserted through the incision gently to advance until it touches the lamina, just side of the spinous process. Then a bevel type working sheath is inserted along the dilator. And finally, the endoscope is introduced through the working sleeve. We are landed on the upper lamina, lower border of upper lamina. In case of L5S1 level, we need to land over the ligamentum flavum because there is wide interlaminar window, so there is no need of any bony resection there. After entering inside the label, I take a lateral shoot. A single X-ray shoot is required Then I go for soft tissue cleaning to identify the structures. So I have to identify the lamina, upper lamina and the ligamentum flavum as well as the lateral side, the facet joint. In case of L5S1, placing the working sleeve over the ligamentum flavum, previously I said, cutting the ligamentum flavum by a punch forceps to make a opening at the ligamentum flavum carefully. Through the opening of the lateral part of the ligamentum flavum, then Carrison punch is introduced and excise the ligamentum flavum laterally at the lateral recess only for discectomy. But I have to confirm the where is my disc is there. Either it is in the axilla or in the lateral shoulder. So it is a targeted phlebotomy. When it is a shoulder disc, then I will land the sheet on the disc, retracting the disc by 180-degree rotating my working sleeve, retracting the root and the dural sheet medially. But for axillary approach, I keep the working sleeve over the top of the axilla and remove the disc over the top technique. This is the example I landed over the ligamentum flavum in case of L5S1.
Last second, just wrap up faster.
My talk was on basics from skin to disc, so I think I reached at the disc.
Yeah, you reached the disc.
But in case of 4-5 and above, I need to drill the lower part of the lamina, then phlebectomy and treat accordingly. But in postoperative courses, I ambulate the patient as early as possible and discharge on the next day. And there is my follow-up protocol 1, 3, 6 and 12 months. I need not any advice to give the patient lumbar support. Gentle exercise I advise, and returning to work for 3 months, physical work, but light job patient can do after 1 month. Thank you all.
So next speaker will be Dr. Santosh Tripathi. He has a talk on portals for cervical and thoracic spine. So Dr. Tripathi. Next speaker, Dr. Srikant. Just be ready with your talk. We don't waste the time.
So I'll be speaking on the cervical and thoracic approaches. So as we are moving from toward the minimally invasive things, so endoscopy is going to play a very important role even for cervical and thoracic spine. So the most common indications for spine and thoracic endoscopy is basically herniation and stenosis. And if we talk about the approaches, so it could be anterior approach as well as posterior approach, and the approach depends upon the pathology, whether you can assess the pathology from the anterior side or the posterior side. So anything which is in the midline, which is can be approached from the anterior, so it's an easy approach. But any pathology which is paracentral or the foraminal can be approached safely from the posterior side. So here we can see. Sorry, it's not moving. So if we talk about the anterior approach, then anti-cervical endoscopic discectomy is the approach, and we can approach from easily from C4 to up to the C7 anteriorly, and approach is basically for the central disc, soft disc actually, not for the hard calcified disc, and the needle placement is very, very important because in this case we usually approach from the right side and mostly contralateral. So this is just to address the foraminal disc and the central disc. And the important thing here is the placement of the needle actually. So before putting in the needle, actually we need to identify the plane and separate the tracheoesophageal complex from the carotid artery. And so sometimes it could be difficult, particularly in if the neck is thick and the pathology is low or high, but still it is manageable and can be done in the C4 to, you can say up to the C6, C7 level. And the important thing is the palpation and the placement of the needle initially with the guiding tube. So we need to identify the level of the disc, as well as the important thing here is to place the needle in the middle of the disc actually, in the AP and the lateral view. So here we can see in the next picture, so the position, it has to be in the midline, in the AP view, as well as in the line in the lateral view. So this is the important concept in the anterior approach. And if we talk about the indications of the anterior approach, then any radicular symptoms caused by the soft disc herniation, and usually one disc level, can be addressed easily with the anterior approach. And but there are certain problems with the anterior approach, like restricted mobility, and sometimes it's very difficult to palpate the anterior spine levels, particularly in the thick neck muscles and thick neck. So if we talk about the variations and uses of the anterior approach, then it can be, there are certain variations of the anterior approach. The most simplest one is the anterior cervical percutaneous cervical discectomy and the anterior endoscopic cervical discectomy. And beside this, approach can be used for the full endoscopic ACDF, where you need to take out the whole disc and can place the endoscopic guided cage. And particularly for the cases where the disc is central and calcified, and it's above the level of disc or below the level of disc, that you cannot do it easily with the like AECD. So you need to make a hole in the body of the vertebra. That's known as the transcorporeal AECD. And beside this, if the disc is migrated and it's a thick, hard, calcified osteophyte compressing the cord, then you can do the partial corpectomy with the endoscope. So these are the advanced indication actually. And beside this, with the transcervical retropharyngeal approach, you can address the higher pathologies. So this is the picture of the transcorporeal one, where we can create the channel through the vertebral body with the help of the trephine, and can address the disc osteophyte complexes. And these are the advanced indications for the anterior approach. That is known as the this is for the retropharyngeal pathologies, particularly for the C1, C2 pathology, like the bacillar invaginations, as well as for rheumatoid penis. So if we talk about the posterior approaches, so the most common approach is for the basically for the foraminotomy and the posterior discs, paracentral disc. And here we need to identify the level first in the AP and lateral view. And the entry has to be on the medial pedicular line or the mid pedicular line. First, we need to draw the spinal line, and 1 centimeter, almost 1 centimeter lateral to is the mid pedicular or the medial pedicular line. We need to land up initially with the needle and check the levels. And the safest placement in the ideal trajectory is between the facet line and the disc line here. So this is the ideal area, and one has to be parallel to the disc actually. So because there is a restricted mobility of the spinal nerves, and you have to be careful about that. So actually, while we do the lumbar, the inclination is from caudal to cranial, but here it's from rostral to caudal actually. And important thing here is, while making an incision, is to feel the bone initially, just the lateral mass, not to enter into the spinal canal, and frequent AP and lateral views has to be taken for the safe entry and for the safe landing. And once you are there, this is the placement of the cannula and the placement of the obturator and the placement of the scope. And the most important thing is just after entering is the identification of the landmarks. Before starting any kind of drilling, you have to be very clear about the anatomy. You need to find out particularly if there's a C6, C7 lamina interspace, then first have to find the cranial lamina, caudal lamina, and the facet joint. Only then you start using the Carrison or your drill. And the important thing is to find out the V point. This is the caudal lamina, cranial lamina, this is the V point actually. And after doing the drilling, there's a spontaneous separation of the ligamentum flavum from an attachment. And now you can see the root. Clearly, it's the pedicular side, caudal pedicle, and this is the cranial side. But the important thing is not to go too anteriorly and laterally.
30 seconds to go.
Pardon?
30 seconds to
Okay,
go.
sure. So most of the pathologies can be addressed with the posteriorly, like paracentral disc, as well as foraminal stenosis. You can do it on the multiple levels. And if we talk about thoracic approaches in brief, so it's almost like the same. It's the interlaminar approach as well as the posterior lateral approach. And for thoracic approach, for transfemoral approach, entry has to be a little closer to the midline, not more than 5 or 6 centimeter lateral to it, because otherwise you will injure the trajectory has to be between the facet as well and the pedicle. And toward the disc side, because if you go too laterally, then you can injure the lungs, and if you go too medially, then you can injure the dura. So it has to be very precise, and particularly you need to pre-plan it with the help of a CT scan. And once you are there, and you can check the entry on the oblique view as well. So this has to be the entry of the needle between the head of the pedicle and the rib head actually. So this is the safest part for the needle entry into the transforaminal thoracic approach. And with this help of the approach, you can do a lot of bony work and can do the osteotomy of the IAP, SAP, and create a box-like osteotomy, and can do even approach the ventral disc as well as the osteophytes, and even can do the calcified things.
We're running out of time.
Yeah, just okay. So this is the last slide. This is for the interlaminar approach. The approach is same as the lumbar one. So dock on the medial pedicular line, and you can do the over the top decompression bilaterally, and do the boring work with the help of the drill. And this is the retropedular approach, but it's an advanced thing, and not many people are using it. And for the ideal decompression thoracic spine, you have to go from pedicle to pedicle, so at least you can see the dura and the nerve root. Thank you.
Yeah, thank you, Dr. Santosh. Now the next talk of Dr. Srikant Daibate from basic step foraminal decompression by monopolar technique L1 to L4 level. So multi-level decompression.
Good morning all. Without wasting time, I'll just start my presentation. The presentation is about the lumbar foraminal stenosis decompression from L1 to L5 level, the decompression for the different levels. Little bit of theoretical discussion. So as we all know that the foramen is bonded superiorly by the pedicle, inferiorly by the inferior pedicle, anteriorly by the vertebral bodies and disc, and posteriorly by the superior articular process, inferior articular process, and ligamentum flavum. So as we go down from the superior lumbar superior levels to the inferior levels, we know that the lumbar foramen decrease in the size both horizontally as well as the vertical diameters. So the foraminal stenosis is most common at the lower lumbar levels like L3, L4, 4, 5, and 5S1, and it is very uncommon at upper level. The cause we already know, the upper level they are less mobile, the dynamic forces are very less, and at the lower levels the dynamic forces and degenerative forces they are very high. So the foraminal stenosis, the causes of foraminal stenosis, they are high at lower level. So this is the least classification. We are not going to detail of classification. So this classification depends on the perineural fat obliteration and morphological changes in the nerve root. So what are the basic causes of foraminal stenosis? the foraminal disc, end plate osteophytes, and on the concave side of the degenerative scoliosis because of the narrowing of the foramen. These three causes, the incidence of these causes or incidence of lumbar foraminal stenosis in L1, L2 is most commonly caused by the soft disc or the end plate osteophyte. The other causes, they are more common in the lower lumbar level, like the SAP impingement in collapsed disc, hypertrophic SAP, thickened ligamentum flavum, then the thickened foraminal ligament, and the spondylolisthesis, which causes pseudodisc and the foraminal stenosis. So if you see the first image, in this case, the foraminal stenosis is purely caused by the disc. In the second image, it is caused by the disc as well as the flavum. In the third image, you can see the tip of the SAP, which is impinging on the nerve root and causing the foraminal stenosis. In fourth image, it is the disc and flavum, then the disc, flavum, and SAP. In lower level, as far as the lower lumbar levels are concerned, the foraminal stenosis is always multifactorial. But at the higher lumbar level, like L1, L2, the foraminal stenosis is mostly caused by the disc. So for the upper level, like L1, L2, as we know that the lumbar foramen is wider in this case, and the degenerative forces are very small, very less, and the cause of the foraminal stenosis is disc. So usually in the upper levels like L1, L2, and L1, L2, and 2, 3, the foraminoplasty is not necessary. So what is foraminoplasty? Foraminoplasty is the widening of the foramen by resecting the SAP. At the upper level, it is not necessary, but if you consider the lower levels from 3 to 5, foraminoplasty is always necessary for the foraminal decompression, unless the foramen is wider. So there are two ways by which the foraminoplasty can be done. First, with the use of the trephine or reamers under the fluoroscopic guidance, but this is comparatively a blind procedure with the higher complication. And there is a second way, we can do the foraminal SAP resection in a full endoscopic view with the high speed burr, with the high power burst. So next step is anesthesia. So it is again, there is a surgeon preference. A lot of people, they do in local anesthesia, but you can do it in epidural as well as the general anesthesia. As far as position is concerned, the patient is prone. As far as the lower levels are concerned, obliteration of lumbar lordosis helps. But for the upper level, it is not necessary to obliterate lumbar lordosis because the foramen is already wider at that level and the forces of lordosis are not there. So the skin marking, which has already been discussed in a lot of presentation, we take a midline skin, midline marking. Then this second is the inferior end plate, and third is the disc inclination line. So as far as the foraminoplasty is concerned, our target is not the center of the disc, our target is the lower part of the foramen. So we usually mark the lower end plate, not the center of the disc. So this is the most important step as far as the transforaminal surgery is concerned. Spend your time, spend your half hour in needle placement, but this is the most crucial step. If you miss this step, you will be in hell. So first of all, if you see at the upper two images, the retroperitoneal organs, they are in very close proximity to our needle trajectory. So in such cases, if you are dealing with the upper foraminal stenosis, I would always recommend to read the MRI or CT scan carefully before surgery and plan your entry point accordingly. So this is the entry point at the L1, L2 level. Approximately the safe distance would be around 5 to 8 centimeter and the angle would be around 45 to 55 degree. If you go below the 45 degree of flat entry, there is higher chances of entering inside the retroperitoneum. Again, you have little bit of liberty at L3, L4 and L4, L5. You can go little bit laterally. This I do in my private practice when I plan any transforaminal surgery. I ask my radiologist to give larger FOV, that is the field of vision, where the entire body comes into the MRI picture, where you can calculate your distances pre-operatively, and which significantly reduces the chances and the apprehension during surgery. So next step is the, after you mark your needle entry point, next step is to introduce your needle. See, in conventional transforaminal surgery, our entry point or needle target point is the medial pedicular line. But as far as the transforaminal surgery is concerned, you do not want to go inside. In most of the cases where the pure foraminal stenosis is there, you do not want to go inside the disc or inside the epidural space. So the target point is from the mid-pedicular line to lateral pedicular line. The tip of the needle is targeted towards the lower part of the foramen at the SAP transverse process junction or the SAP pedicle junction. Next step is the putting the dilator inside, then the working sleeve, and then the scope. So as soon as you enter inside, the endoscopic picture will be like this. You will be encountered with the soft tissue over the SAP. Try to remove the entire soft tissue over the SAP. You can RF it. See, the more again, the one important stage is take your time to remove the soft tissue and take your time to identify the structure. As far as the foraminoplasty is concerned, the most important landmark is the SAP pedicle junction. Identify the junction because your work is going to start from the base of the superior articular process. So in many cases of pure foraminal stenosis, you need not to go inside the disc or inside the epidural space. So this is how you can remove the soft tissue or the SAP.
Last 30 seconds.
Yeah. So the next step is the resection of the SCP. So while doing the SCP resection, always remember your starting point should be the base of the SCP. Start drilling the SCP from the base towards the tip, not from the tip towards the base. So this is the video. The tip is being resected from base to tip. So these are the steps which are common in all the foraminoplasty cases. Now the things changes according to the pathology. If it is a disc, you can go inside and remove the disc fragment. If it is a tip of the SCP which is impinging on the root, you can go inside, remove the tip, remove the ligamentum from that side. The rest things will be same. So there should be always the end point of the surgery. In foraminoplasty, the end point will be seeing the axillary flat, visualizing the root from proximal to the lateral exit zone and the pulsation of the no root, which is the indirect sign of the decompression. Thank you very much.
Thank you, Dr. Srikant. The next talk by Dr. Harshvardhan Rao-Rane for monoportal fusion basic steps. So last talk of first session.
So, good morning, everyone. So, I'll be talking about the full endoscopic interbody fusion, the key surgical steps. So, we all know the Saeed Usman et al. First documented the full endoscopic interbody fusion. That was primarily through the classical transforaminal approach, what today is called as a transcambine approach. And first, he documented the interbody fusion in 2012. We started working on the interbody fusion mainly through the posterolateral approach, and first we published the paper in 2019 about the feasibility. Later we continued with the complex type of interbody fusion where the disc basis collapse or grade 1 or grade 2 spondylolisthesis, where the posterolateral interbody fusion can be achieved through the full endoscopic approach. And later the more review articles and the meta-analysis also is on the way, comparing between the transcambine and posterolateral approach for the full endoscopic interbody fusion. So till now the documented interbody fusions through the endoscopic approach are the two approaches. One is classical transcambine approach or transforaminal approach, and another is a posterolateral approach, which is mainly used for the uniportal as well as biportal. So I'll start with the case. She's a 59-year female staff nurse. She was having a low back pain with a left side radiculopathy since 6 months, and it was aggravated on 15 days. There is a significant back and leg pain. We can see here the L4, L5 the instability as well as the modic changes, and she's having some coronal imbalance. So the patient is positioned in I prefer to do it in a general anesthesia. The local infiltration of 2% lignocaine plus adrenaline is infiltrated directly over the facet joint to get a clear picture or clear vision endoscopic. So the classically in our paper, first we described the docking. So the first video is of my mentor, Professor Houston Kim, where he preferred to dock on the spinal laminar junction. They called it as a Wu point, but it is just like a spinal laminar junction where the biportal people also dock and start the surgery. As I am using a smaller scope, I prefer to dock over the classical, the caudal tip of the inferior articular process, also called as a V point. And then I isolated the inferior articular process from spinal lamina junction to the caudal tip from the interlamina window, so that it can be later on resected en bloc or in a piecemeal. So the next step is a inferior articular process resection. Again, the first video is of Professor Hewson Kim. He liked to resect the inferior articular process en bloc. So they will start the drilling the inferior articular process from SAP to the lateral, the uppermost point of a superior articular process. So what he will do is, with the help of a drill, he create a throw from the spinolaminar junction up to the tip of the superior articular process until the ligamentum flavum is seen. And once the inferior articular facet is completely dissected, with the help of working bevel only, he will remove the IAP en bloc. I prefer to use the osteotome, and I start do osteotomy from the caudal tip, and then I with this is an endoscopic 3 mm osteotome, and with the help of a 3 mm osteotome, I start taking out the IAP piecemeal, so that I will reach up to the same point as mentioned before. So in the same setup, the stenosis decompression is achieved if required. The contralateral decompression can be achieved through the same setup. So we can see this is a left facetectomy already done. The IAP resection is already done. This is a remnant of pus, which is drilled out. The contralateral or the base of spinous process is also seen, and with the help of a Kerrison punch, we can resect the remnant of overhanging parts. And as well as the central decompression can be achieved at the same setup. So once the IAP is resected, the SAP is resected with the help of a Kerrison punch, or if we want faster, we can resect the SAP in the with the help of a osteotome, endoscopic osteotome. So the SAP again the same resected from the lateral to medial, and we can see the foraminal ligamentum flavum, which is in continuation with the interlaminar windows foraminal ligament. So once the IAP and SAP is resected, the ligamentum flavum is elevated, preferably from the caudal side. So we can see the lamina and the what we call as a suprapedicular ridge. So through there, the ligamentum flavum is a flimsy, and it is elevated and can be resected piecemeal or en bloc. Once the ligamentum flavum is resected, you will see the disc. The disc is dissected with a forceps, and I use the same osteotome which I used for a IAP to prepare the end plates. The end plates are prepared with the help of a osteotome. Once the end plate is nicely prepared, I will see the stop irrigation test to see the subchondral bleed. Once I'll see the subchondral bleed, I will place the two long root retractor which are already available in the even with the pedicle screw system, and one for the traversing route and one for the exiting route. I will make sure that the root retractor will be on the ventral side of the dura, so that it is protecting the traversing as well as the exiting route. Also, the root retractor will guide your cage through the soft tissue, so that the cage will be placed into the interbody space. So this we can see the nice height is achieved. The coronal correction is also nicely achieved. So the advantage of the posterior lateral approach, we can say over the transcambine approach, is the autologous bone graft can be harvested through the same approach. It is relatively versatile approach. The working cannula is not fixed in the foramen, so that we can do a end plate preparation better than a transcambine approach. We claimed in our paper that almost 80% of end plate can be prepared with this technique, And of course, the fusion rates are also better with this technique. Thank you.
Thank you, Dr. Harshvardhan. With this lecture, we conclude the first session. We have 1 minute for question answer. So anybody have a question can ask. Meanwhile, ask Dr. Harshad Parekh and Dr. Santosh Tripathi to chair the session. And I'll ask Dr. O.P. Singh to take the first lecture of UB in lumbar canal stenosis in my learning curve. Dr. Harshad is not there. Instead of Dr. Harshad, Dr. Sambhav, can you just chair the session?
Good morning, everybody. I'm discussing about my learnings from UB in lumbar canal stenosis. As you know already that lumbar canal stenosis may be because of various reasons: hypertrophic ligamentum flavum, facet arthropathy, spondylolisthesis, short pedicle syndrome, synovial cyst, osteophytes, various reasons. Portals is already discussed by various speakers. I'm not going into detail. It is just for same 2 to 3 centimeter distant, 2 ports are made, and one is made at the junction of medial pedicular line and distal transverse pedicular line. My first case, I started UB in 2020 and the COVID era, and it was my first ever case. I choice was the wrong case. It was L4-5 stenosis with hypertrophic ligamentum flavum. And I followed all the principles, all the learning from different conferences and different masters. And started my case. It took 4 hours and bleeding troubled a lot. But anatomy was cleared and it boosted my confidence. And this was 56-year-old male and with neurological claudication. This is the preoperative MRI of the same patient. They were severe lumbar canal stenosis L4 and L5. After decompression, in MRI L4-5, there is total decompression. My second case was a 72-year-old male with severe neurological claudication. On MRI, there were 2 levels of lumbar canal stenosis, L3-4 and L4-5, severe lumbar canal stenosis. IAP was lax on the right side, and it was pinching on the traversing route. And this was done via, in the same setting, via 3 incisions. This is the operative video of the same case. Ligamentum flavum was then removed and blocked. And UB in lumbar canal stenosis surgery is an excellent technique because of clear and magnified view. It helps a lot, and one must have a preoperative mental mapping about what has to be decompressed, and it had to be planned earlier before going for surgery. Craniocaudal and lateral dimensions of the decompression must be clear and matched in MRI also. Thoracolumbar fascia is a tough structure and cut it obliquely. I found it better to cut it obliquely than to cut it in cruciate manner or linear manner, because once you detach it from the spinous process, there are much easier to manipulate instruments, and outflow is very good. That helps a lot in surgery. Superficial layer of ligamentum flavum should be removed first to get sufficient working space. Inner layer of ligamentum flavum must be left until the last when all the bone work is done, because after that there are chances of injury to dura and vessels. Blunt dissections, end dissectors are very helpful in these settings, and they help to avoid, because dura is already thinned and it is prone to tear. So blunt dissectors are very helpful in dissecting the dura from the ligamentum flavum and avoid any tear. En bloc removal of ligamentum flavum is preferred because it has less chance of manipulation, and coercion is the most important instrument causing dural tear. We use foot plate of coercion to dissect, swept between the dura and the ligamentum flavum to dissect and then cut the ligamentum flavum. Bleeding is a great obstacle for beginners, and it has to be controlled and learned how to control it. One of the most important thing is better saline outflow. If the saline outflow is good, then you can do safely in clear operative field, and keep the blood pressure around 100 millimeter of mercury, and normal LFT and coagulation profile. You can also use a smooth end of the RF as a dissector. It helps very much. Few more videos. This was the case of L45 lumbar canal stenosis, and there was serious stenosis, facet joint hypertrophy, and it was operated via UB, and the same procedure, drilling at the spinal lamina junction and going contralaterally. After the drilling of base of the spinous process to gain contralateral access, ligamentum flavum was, this is the drilling of base of spinous process. This is again how to separate the superficial layer of ligamentum flavum from the junctional area via a curette or blunt dissector. How to use the back end of RF as a dissector atraumatically. Thank you.
Hello. Thank you.
Thank
you. We're not taking questions, right? No questions. The next, I would like to invite Dr. Mehul Modi, who will be giving us a talk on UBE pearls and pitfalls of recent global trend.
Good morning, everyone. I'm Dr. Mehul Modi. I'm from Surat, and today I'll be talking about advantages and disadvantages of UBE. So this is a basic presentation about advantages, disadvantages, and technique of UBE. So what exactly is UBE? So it's a unilateral. It's done from one side. It's of course biportal, and it's an endoscopic spine procedure. Now, why UBE? Why UBE is so much in focus right now? So the reason is it has an enhanced endoscopic surgical view, better than a microscopic view. It has a familial surgical anatomy. The surgeon is very well oriented with the approach, with the course, and with the anatomy of the surgery. And during the surgery, we can have an extended range of movement, Most importantly, it is very versatile technique because it can be used in a number of indications. And most importantly, with this technique, you can have a very good visualization of contralateral, sublaminar, and foraminal areas. So there are certain basic principles of starting UBE. The most important being triangulation, because if the triangulation is not proper, you cannot do a proper UBE surgery. So after triangulation, it's creation of potential cavities, and then it is inflow and outflow of saline. So these are the three basic principles on which a good UBE surgery can be performed. So when starting the surgery, of course, level needs to be confirmed, midline should be confirmed, spinolaminar junction needs to be confirmed, and mid-pedicular line needs to be marked. After that, the subpedicular line needs to be drawn. It has to be level above and below on which the surgery needs to be performed. Most important thing in surgery is creation or the marking of the entry point of portals. And in the entry point, the distance between the two portals is very, very important. It has to be around 3 to 3.5 centimeter. With this distance, you can get a perfect angulation, which will help you in your entire surgery. Now, if the angulation is not proper, if the distance between the two entry points is not good, if it is larger than what is being expected, then it will lead to an open triangulation. Now, what will happen with open triangulation is the two instruments will keep on dangling. You will keep on searching the instruments throughout your surgery. So you should not have an open triangulation. And what if the instruments are very close to each other? So in that scenario, you will have a closed triangulation in which the instruments will continuously touch each other, and you will have difficulty in the surgery. So for a good UBE surgery, you need to have a perfect triangulation with a distance between the two entry ports of approximately 3 centimeters. Now this has already been covered for when the entry site is confirmed, you need to put an incision. It can be horizontal or vertical. Cut the fascia in the direction of the instrument in which you are going to pass, and then pass the dilators, fill spinolaminar junction, and create space with blunt dissection. Now, as far as the ergonomics of this surgery is concerned, I would want my assistant to be beside me. The screen needs to be on the left side, front, and the CM monitor needs to be on the right side. I also want my saline to be exactly opposite to me, because constantly I need to monitor the inflow of the saline. Now, saline management is very, very important in this procedure, because the entire surgery is going to be done in the saline medium. So if the saline management is not done properly, as we did in our, when you start the procedures, this saline management, if not done properly, you might have a slippery fall. You might have to work submerged inside saline, which can lead to equipment damage, and the patient might land into hypothermia. So to prevent that, you need to have a proper waterproof draping. This waterproof draping can have a good saline management, and for saline inflow, we feel gravity is enough. At a 6 feet height, saline will have a good flow, but for proper controlled flow, you need to have a pressure system. Pressure needs to be around 30 to 40 with a pressure flow of around 0.5 liter per minute. For saline outflow, it needs to be checked regularly, and you need to check the proper outflow of saline. These are the UBE sheets. We usually don't use it. And for drilling, once your port is set, you can start drilling, start from the spinolaminar junction, drill the ipsilateral side, and usually go to the contralateral side. Now, the strategy for this entire endoscopic procedure has to be a clear view. For that, you need to have a good bleeding control, and for that, you need a plasma RF. So plasma RF does a wonderful job. It not only does the hemostasis for tissues, but also for bone bleeding. So you need to have a plasma RF in your armamentarium for starting UBE surgeries. As you can see, you can have a wonderful view of the structures. Here we are putting a cage, and you see that you can easily see that retraction is not required. Once the procedure is over, you need to have a complete hemostasis. If you have any doubt with the hemostasis, you can always put a drain. Now these are the two incisions, small incisions, from which the entire procedure of discectomy and decompression can be done. Overall complications are as in any open surgery or any other mode of surgery for spine, but the complications specific to this procedure, retroperitoneal and mediastinal fluid collection, and patient might encounter headache and neck pain. Now, when to convert to open surgery, when there are big dural tears or root injuries or any kind of incomplete decompression you are considering. Now, the disadvantages of this procedure is that it has a very long learning curve. This technique is technically challenging, and in the initial phases, you can have an incomplete surgeries in the beginning. To shorten this curve, we would advise to start the surgery with simple lumbar disc surgeries, start from left-sided surgeries, use 0-degree endoscope initially in 2 or 3 cases for better orientation, and always attend training and mentorship programs. We also advise you to do the surgeries with a colleague or a friend of yours so that you can have a better orientation. These are the wide UBE applications you can use in almost all the degenerative conditions of spine, from disc to stenosis to OPLL. In all these conditions, UBE can be used. Now, this was a wonderful paper from South Korea, which denotes that the endoscopic spine surgery evaluation, and they came to the conclusion that spine surgeons can be divided into 3 generations. The first generation surgeons are those who are doing discectomy, second generation who are doing decompression, and the third generation who are doing endofusion. So as the generation of surgeon increases, his surgery time decreases, complication decreases, patient hospital stay and patient compliance increases. Endoscopic spine surgery, our journey, we started with open surgeries, gradually shifted to minimal invasive, then transforaminal, and gradually we started doing UBE surgeries. We had a good experience with transforaminal, but now we are doing UBEs also. And for us, UBE stands for user-friendly, broadly expected, fastly growing surgery at present, and it is an excellent technique with very good results. Thank you.
Thank you, Dr. Modi. Now we would like to invite Dr. Narendra Bhagwat for his talk on troubleshooting in transforaminal surgery. Dr. Bhagwat? I think Dr. Bhagwat is around. I think then we'll conclude this session and we'll move on to the next session. We'd like to invite our chairperson for the next session, Dr. Masato Tanaka and Dr. Abhishek Kashyap, to please join us on the stage. And the first talk is by Dr. Tanay Prabhu on para-UB for up-migrated disc, a novel technique.
So very good morning to chairpersons, seniors, and my dear colleagues. I would at the onset thank the World Congress as well as Dr. Pestanji sir and Dr. Antao sir for giving me this opportunity to speak in front of you all. And I'll be speaking of this topic on para-UB for up-migrated disc, a novel technique, and acknowledgements to Dr. Pestonji sir for providing all the videos and helping in the presentation. So why do we do para-UB? It is a very easy technique. It is a direct access to the Camben's triangle. There is no laminotomy of phlegmectomy, and dura and sometimes even the nerve root need not be visualized. And there's significant minimal blood loss, which is seen in this, just like in the UB, which has been just discussed by the previous speaker. The importance of portal, as mentioned earlier, is very important, and you have to see it, the C-arm images in the AP view as well as in the lateral view, and you have to triangulate it very well and reach the isthmic point, and that is called the landing zone. On the lateral view, you can confirm your level and the position on the facet lateral edge, which can be easily seen on the left side. And this is where the entry on the AP view you can see at the lower end of the pedicle. Once you reach there, again confirm your level and descend along the pillar of the pedicular inferior edge, and then you can reach that zone and you can easily do your working areas with the help of the burr and your Carricin punches. Just to show the same thing in the bone model, this is the landing point, the yellow zone, where a right-handed surgeon, the scopic portal as well as the working portal can be very well seen in the front view, that is, and in the corner you can see how you can enter the facetal area, and you have to enter into the foraminal zone where the working area is there for the discs. So this is a bony model which you must take into consideration when you're doing this para-UBE technique. This is a few videos which we'll just quickly run through. This is one of them is the up migration of the L2, L3 when you have you cut the superior articular process, that is SAP, and gradually remove the disc fragments slowly with the help of your punch as well as the root probe, which are the two instruments always lie parallel to the root, and gradually remove all the fragments which are at the up migrated disc of L2, L3. There are few fragments which are seen. You have to see that you coagulate also well. Use the blue coagulation chamber at a lower level, not at a higher level as in case of the yellow coagulation. And you can remove the disc fragment completely. Make sure that you completely remove all the fragments and the root is completely free in the end. The next one is the images for the subligamentous migration. So not only we are seeing that these images are there with removal of the disc fragments, it can be subligamentous. So you must be careful and gradually remove these fragments once you remove the SAP. And in the picture you can see very well with the help of osteotome it has been removed, and now the fragments are gradually being removed with the help of even the Carricin as well as the disc punch and the root probe, which is a very important tool which helps in removing all the loose fragments as well as some hidden fragments which are down. So all the fragments are being gradually and carefully removed till you have a complete good decompression of the nerve root. So this is another place where it is being very well used by the para-UBE technique. You can further use the same thing along with that you said in the first video, the removal of the disc is seen at the L2, L3. The next one we showed it is subligamentous, and this is where you can also remove the disc fragment and you can further add it to a fusion. So you can see how the cage is being inserted here well, and the root is completely free. So it is such a versatile thing that you can use even at the lower levels, and now gradually you're progressing it to the even the higher levels, that is the L2, L3, L1, L2 also. This is where the picture you can see on your left side. This is the area which is the up migrated disc at the L3, L4 level. And in the end on the C-arm picture, you can see very well that you must see that completely with the help of root probe in the lateral view as well as in the AP view, that you have reached the level well and you have cleared all the areas and you have got a good decompression in the end, and all the disc fragments are removed. Finally, I would like to end with the last video of a L3, L4 up migration. So in line, use the RF and burn it at a lower level. See that the tissues are coagulated well. Always along and in line with the root, so you don't injure or have any problem with the root. And with the help of the probe, now we are slowly removing the fragments. This is the L3, L4 up migration of the disc. And slowly all these fragments are being carefully teased out and removed, and you get, even in the end, a good decompression of all your traversing as well as the exiting nerve root. So all the fragments are carefully being taken out with the help of your disc forceps. There's so many fragments, so that you have to be careful. You don't leave anything in the end. And you can see now the little bit bleeding, and the pulsatility of the dura as well as the root will be seen right in the end. It's almost the last part where the last fragment is also seen, and now you can clearly see how the root has been completely freed. Yeah, that is the last part. So in the end, these patients are doing really well. Initially, of course, they have some surgical site pain, but the post-op pain gradually reduces significantly within few days. In a week's time, it is less than 25, and within 6 months, they go back to all their routine activities and daily living, and they have an excellent outcome. So I would like to highlight and tell that this is a very good technique. I would like all you youngsters as well as seniors I'm sure must be doing it. Can be done at the lower level, and also now gradually we are doing the indications for the higher level, and it's a very good technique to adapt. Thank you so much for a patient hearing. Thank you, sir.
We have the next talk by Dr. Pangwu. It's going to be a virtual talk. So we're going to switch to get the ball rolling. Do you have any preference of using a 0-degree versus a 30-degree scope?
The 30-degree scope is being used, sir. Okay. We're using that.
And do you sometimes, when you are doing on the right side disc, because you're for a right-handed surgeon, your angle of the instrumentation is down, so you switch the ports, or
So usually, if you're saying the opposite side?
no, you're a right-handed
Yeah,
surgeon,
yeah.
I believe.
Yeah.
So if you have an up-migrate disc in the right side,
Yeah.
should you switch the ports?
Switch, yes, sir. Yes, sir. Thank you, sir.
So we have Dr. Pang Wu. He's going to be on a virtual talk. Malcolm. Any other questions for the speakers? Yeah. Okay, we would request Dr. Harshvardhan to be present with this talk. He'll be speaking about role of full endoscopic transfemoral approach in infected spondylodiscitis, when, where, and how.
Okay. Uh, so, the spondylodiscitis is also a very common scenario we will face in our day-to-day clinical practice. So I will be talking about the role of full endoscopic transforaminal approach while doing a spondylodiscitis. So, ये move नहीं हो रहा. यहाँ पे नहीं हो रहा. So, while dealing with the spondylodiscitis, first thing what we need to know is discitis, the primary pathogen or the infection is situated in the disc space. While the word comes, the spondylosis is the inflammation of an adjacent vertebra. It can be reactive or infective. So most common route will be the hematogenous, the exogenous from the local source, or iatrogenic post-surgical. Most common pathogen found worldwide as well as in India is the Mycobacterium tuberculosis. As well as the nowadays the on increasing note is staph aureus, particularly in immunocompromised patient, diabetes mellitus as well as E. coli. So while dealing with the spondylodiscitis, the main goal of a treatment will be the first is the identify the pathogen, the eliminate the focus of infection, the restore the spinal functionality or the stability, and the reduce the pain. So coming to the role of the actual talk, that role of a transforaminal approach, how it's going to help it. So I will be explaining it in the three questions. First is a why. So the role of a, if we'll see in the diagnosis, the pathological detection rate in the CT guided biopsy is only 19 to 30%. While it increases significantly in the surgical biopsy up to 68 to 93%. But it has a significant toll that because of the surgery or the open surgery, it is also associated with a significant morbidity. So if we'll go to the literature with a full endoscopic disc debridement, it has a higher biopsy rate, which is almost a 90%. Why it is more as compared to the CT guided biopsy? Because the working channel of almost 3.5 to 4.1 is a much large working space. We can take a adequate soft tissue or the disc or the whatever the granulation tissue from the disc space, and that's why the biopsy success rate is higher in the case of a transforaminal endoscopy. So principally the biopsy should be taken from the disc space, not from the CT guided pedicle, transpedicle biopsy or the bone biopsy. The adjacent end plates or the paraspinal soft tissue because it has a higher culture rate. Then the role of a treatment, the debridement irrigation fluid primarily wash out the major bacterial flora from the disc space. When it is mixed with a antibiotic, it improves the outcome. There is no literature available in here, but I preferably use the gentamicin in the irrigation fluid. The selective debridement of a granulation tissue under direct endoscopic vision, it not only eliminates the infected tissue as well as helps to preserve the normal healthy disc. Hence, it preserves the motion segment. The curettage of the bone end plates to enhance the blood flow at the site of infection makes the infiltration of antibiotic to the infected area more efficient. So the same transforaminal endoscopy can also work as a drug delivery system. In selected cases, I prefer to put a stimulant when I withdraw the scope, keeping the working cannula intact. I prefer to push a stimulant. So this also works very nicely with the transforaminal endoscopy. We can see the infection control rate in instrumented patient is lower, while in the primary spondylodiscitis, it is nearly 86%. But we have to consider this resurgical rate, 21%, is also significant in the transforaminal endoscopic debridement. And we have to explain the patient about the chances of a resurgery or possibility of a resurgery or fusion in the future. So the role of instrumentation lies mainly in the instability where the segmental kyphosis or vertebral body collapse is more than 50% or the transition is there. But still it can be manageable with a MIS or mini open technique. So it can be done in the lumbar spondylodiscitis, the thoracic spondylodiscitis, the spot spine in the India, it is very common, as well as it can be used to drain the epidural abscess. So I'll start with the first case. This is a 60 male veterinary doctor having low back pain with the right side radiculopathy since 2 months, not responded to any treatment. And he was having a recent genitourinary infection as well as catheterization history in 4 months back. He was significant back pain as well as a right leg pain. We can see there is a high shadow, the T2 shadow. But if we'll see, the selective disc is involved. Only the right side disc is involved in the spondylodiscitis while the left side disc is still the healthy tissue. So that's why I planned the transforaminal endoscopy through the inside out technique. I completely targeted the my scope into the right hemi disc, and I took out the biopsy, and then I did a selective debridement of that disc base. The most important thing what we have to do is once the scope is inserted, we should not start irrigation immediately. First, we have to take a dry biopsy because there is a chance that the saline or whatever the irrigation fluid will wash out the pathogen. So first thing what we have to take is a dry biopsy, and then once the irrigation is started, we can do a selected biopsy. The infected granulation tissue can be removed with a forceps, and I prefer to use the bone hook or some probe to just scratch the end plates to increase the vascularity of that end plate. The organism isolated in this case was a E. coli. I prefer to use a 6-week IV antibiotic, better to involve the infectious disease consultant. Mobilization can be started immediately on first or second week, and this is a 3 months post-op where we can say the lordosis is still maintained, but the disc spaces is slightly collapsed, but the patient is clinically stable. This is the second case where 48 male having a low back pain in the with left side radiculopathy. He was ankylosing spondylosis and chronically steroid and immunomodulator intake was there. He was having significant back pain as well as a leg pain. So here also we can see the selective involvement of a disc base in the spondylodiscitis, where I chose to do a outside in technique where I docked only in the foramen, and then I gradually went inside the disc space and I removed selectively the infected and unhealthy granulation tissue, and the organism isolated was a Staph aureus. So in conclusion, the surgical biopsy and IV antibiotic is still the gold standard of a treatment. What full endoscopic transforaminal approach can achieve or help is by obtaining the soft tissue or the biopsy, which gives a higher cultural rate. Still, it is a minimal invasive. Hence, it has a minimal post-op pain. It preserves the motion segment. Instrumentation should be considered if the patient is having a instability in future. Thank you.
Thank you. Do we have the virtual talk ready? Okay, so we have Dr. Pang Wu. He's going to be presenting cervical endoscopic surgery for cervical myelopathy.
Thank you. Hi everyone over there in Mumbai, India. It's sad for me that I cannot attend this year's Endoscopic Spine Foundation India meeting because of my national service where I'm on standby. Today my topic is on cervical endoscopic surgery for cervical myelopathy. This is my conflict of interest. Some of them are relevant for this topic. I think two spinal endoscopic benefit in complicated cases, and certainly cervical myelopathy is one of the complicated cases in spinal surgery. We analyze critically, and often in cervical myelopathy that presents with a significant drop in MJOA, they will be in a grade 3, a grade 3 area where there's a signal intensity over the spinal cord on T2. And we also analyze critically whether left or right side there's any radicular symptoms. Why do we do endoscopic surgery? There are common known risks in anterior cervical spinal surgery such as dysphagia, dysphonia, and hematomas leading to airway compromise, implant-related complications, and one of them being not really labeled as complication is that of adjacent segment degeneration, on top of screw loosening, plate and cage related problem, as well as for disc replacement, the unknown period when the disc replacement may wear out and eventually need to be replaced. For open posterior cervical surgery, there are known common risks of chronic and persistent neck pain, wound issues, cause of implant-related issues. And why not do tubular cervical surgery? I think for foraminotomy, tubular surgery and endoscopy can be applied to the patient, but for myelopathy and over-the-top decompression with ULBD, doing tubular surgery where you need to wind the tube in open cervical spine is really risky. Stressful for the surgeon and probably stressful for the patient. What if there is bleeding? Can't really see very well in tubular surgery. For the endoscopy that can be applied for myelopathy, you can do ACDF through the biportal assisted manner. But for today's purposes, we'll be discussing really uniportal or biportal method. And today, due to limited time, we're talking about biportal. Mainly on that of the either ULBD, unilateral laminotomy with bilateral decompression, or really the more commonly practiced laminectomy. And for foraminotomy, we focus on this as to the lateral to the cord. But for myelopathy, we'll be looking at whether cervical stenosis is out of, in my practice, less than 3 levels, and with no significant kyphosis. Majority of the compression come from posterior. And in some cases of anterior, where corpectomy or anterior surgery will be challenging or contraindicated. How to decide whether to do UBE by ULBD or laminectomy? For this, I thank my fellow Rohit, who spent precious time with me in Singapore. We published a paper on this, published in NASH journal, when we discussed what are the strategies and management of spinal cord compression. And as you can see from this diagram, that we can do either a laminotomy, bilateral decompression, or laminectomy, where it's like the figure E, where we make 2 trough and remove the lamina, sparing the spinous process. And I also thank my mentor who has taught me the uniportal techniques, but for today's time, we do not have time to discuss too much on uniportal. Needless to say, both uniportal and biportal have very good results. For this case example, I would like to thank my current fellow. He's also called Dr. Wu Chunsui from China. He's a deputy chief in Nantong Orthopedic near Shanghai. This patient is a 64-year-old. He has instability, walking on the phone for 1 year, worse in the past 3 months. His Hoffman's positive, unsteady gait, power 5. However, in all 4 limbs, a taxi driver. He requires neck movement in driving taxi, and he insists that he will continue driving. And as you can see, that this patient has very severe spinal stenosis due to OPLL, as well as that of thickened ligament at the back, leading to a severe spinal stenosis with myelomalacia. As you can see from the diagram here, there's a thick OPLL from the back of C3. As you can see, in this type of more serious cases, we tend to use Mayfield clamp rather than horseshoe. Of course, controversial, which one is better. By standard, Mayfield clamp is quite easy to apply, and the patient has not much problem with the pins, so I use Mayfield clamp. This is the marking of the spine. We have the viewing port at C2 and the working port at C4, so through 2 ports we can do a C2 to 4, actually on top of 5 decompression. This is a video showing the water that we use. You can see that use very little flow. And you can see the bag is actually at the level of the cervical spine. And that's sufficient for the water in decompression. So first, we create a working space. We use radio frequency, and then subsequently check the location. And then we find the V point by doing radio frequency and some drilling. Subsequently, we do the ipsilateral laminotomy. After we do sufficient ipsilateral laminotomy, there will be bleeding points, and using a small tube radio frequency will be really helpful. Be very cautious in the laminotomy. Although we do the ipsilateral laminotomy, do not reach the flavum, nor do you drill till you actually see the spinal cord at this point of time. Just make it thin, create working space. The working space actually involves the ipsilateral side and the contralateral side. Along the way, you will have threaded tissue on your drill, and you can ask your assistant or your nurse to clean it up. Now, after drilling, there will be sufficient space in the ipsilateral side. And then we work on the contralaterals, on the laminotomy, again creating space. For this particular case, we do all the way to end of the C4, so it's the entire C3 and C4 laminectomy. After that, we check the location, whether we are at the midline. Of course, you also can see the midline cleft. Then we proceed on to the contralateral side, keeping the ipsilateral side lamina still very much intact, just drilling it in. So do spend a lot of effort and time to carefully drill for the lamina to be lateral enough. Keep the flavum intact, drill the lamina thin. If it is an old ossified yellow ligament, you drill the yellow ligament as well. Once that is thin on both sides, actually we will remove the flavum ipsilaterally and then contralaterally without in an atraumatic fashion. To open up the lamina, you can use a nerve hook or that of gentle kerosene. I tend to use a nerve hook first, create some space, let the saline enters gently to the cord. Be very much lateral to the cord before you actually put in your kerosene. Don't be putting your kerosene right in the middle of the cord. And then you can gradually, using this type of hook, to remove flavum as well as that of the bone, if there's any residual ones. There's bound to be some bleeding. Be patient. Bear in mind, my saline flow is really low. The bag is at the level of the bed. So if that bleeding happens and it's copious, can stop and use a flow seal or any hemostatic agent of your choice. But keep the scope in so that you will be oriented always. And then we mark the top and the bottom level of the decompression, confirm the levels. And this is the results of the patient. Sorry, it comes laterally, but you can see that the wounds are, well, the wounds are pretty clean. And the next day, the patient is able to ambulate independently. So it comes out laterally. So the drain, you can see, is very minimal. It's just about 50 mils. Overall, we can do decompression for short OPLL, OYL. And we can do, we keep the water pressure low, drill the lamina tube in to remove the lamina. And then last, to remove the flavum to decrease bleeding. Finally, we like to emphasize that there's a steep learning curve in endoscopic spine surgery. We need to be familiar with handling of endoscopic drill, especially in doing cervical cases, as we need to drill the bone very thin. Fluid pressure really maintain low as possible. Just be visualizing well. Try to do most of the cervical surgery in less than 1 hour, because prolonged water pressure on the cord is not a good thing. Of course, if you were to do multiple levels, then remove the ligamentum flavum last, so that you will expose the cord to water of the normal saline to a limited period of time. Try have no contact with spinal cord, use small equipment like horizon 1 or forceps, and we have proper hemostasis and be clear on what you see all the time. With that and careful choice of patient, you will get good results. If possible, we would seek collaboration with our partners. Most of you and all of you are endoscopic experts. Please submit your paper to consider to submit your paper to Medicina Journal, where Professor Hyo-Sung Kim and myself is the guest editor. The deadline is August this year. Thank you very much.
Thank you, PH. So one question from me. Can you hear me?
Yes, I can hear you.
Okay, can you hear me?
Yes, I can hear. Can you hear me?
Thank you for your wonderful presentation. So one question. So this must be an excellent technique. However, I believe this is a steep learning curve. And could you tell me the surgical time for 3-level decompression of this technique?
Typically, 3 level would be 2 hours. The exposure of dura to saline time is less than 20 minutes, 30 minutes. The key is we drill lamina very thin, sometimes even thinner than that of the ligamentum flavor. It's basically paper thin. So much so that we can just use a nerve hook to break the lamina. So once the lamina is use a nerve hook to break, then no kerosene and just use that and hook out the lamina that's paper thin. Then we remove the flavum and we remove them on block, the entire 3 lamina together with the flavum. So the exposure of saline to these are very compromised parts, so the exposure to saline must not be too long.
Thank you.
Do we have any other more questions for Dr. Pang? Thank you, Dr. Pang. We move ahead with the session. Now I invite Dr. Swapnil. He'll be presenting about pediculotomy in TLD for migrated disc herniation. Yeah or no?
Good morning, everyone. My name is Dr. Swapnil Sanjay Hazare. I am from Nagpur. Today, I'll be discussing about role of pediculotomy in transforaminal surgery for a highly migrated lumbar disc herniation, whether you should do it or not. So, disc herniation beyond the end plate of the involves inbuilt called as a migrated disc herniation. And when the extent of disc herniation is more than posterior marginal disc height measured from the adjacent segment, it is called as a highly migrated disc herniation. And it has been proven to have an unfavorable outcome because of high incidence of the failure. As far as treatment is concerned, we always have an option of interlaminar endoscopic spine surgery, but we know that interlaminar endoscopic spine surgeries are non-targeted approach. We have to remove a lot of bone and the ligamentum flavum to address the migrated disc herniation. It needs a specialized burr. You can't use a mechanical handheld burr, and there is inherent anatomical limitation for the upper lumbar disc herniation. As we know, the success of transforaminal surgery depends on the appropriate placement of the working instrument. Improper trajectory can be a major cause of failure. And in case of migrated disc herniation, osseous perimeter of foramina, passage process, the pedicle and the exiting nerve root can limit the proper trajectory of insertion, mobility of the working cannula, and excision of migrated disc herniation. Therefore, it is challenging to treat the high-grade migrated disc herniation with conventional transforaminal endoscopic spine surgery. If we combine conventional transforaminal endoscopic spine surgery with the pediculotomy, we'll be able to open that osseous perimeter and we can grab the migrated disc herniation. So pediculotomy involves the reduction of pedicle diameter at the craniomedial aspect. Kim called it as a suprapedicle circumferential opening technique, who defined as a transfacet process and the pedicle complex approach. It is the same approach in which we drill the ventral aspect of the SAP, superomedial part of the pedicle and the upper posterior margin of the lower vertebra to increase the width of the foramina and expose the ventral epidural space. So it has all the advantage the transforaminal endoscopy can offer. It is a targeted approach and does not need an electric burr. So I came across this 43-year female. She was having a right lower limb radiculopathy for past 12 weeks, and it was not getting relief with the conservative management. This was her MRI. We can clearly see the huge migrated disc herniation on the right side going below the inferior margin of the lower pedicle. And this is what I had done for this patient. It's a placement of the Tom Shitty, sequential reaming with the side cutting reamer, placement of the cannula and working sheath. So this is the initial view. You can see the pediculotomy defect and foraminotomy defect. So after a while clearing the soft tissue, I have to rotate the endoscope and the tube completely to protect the nerve root, and whatever you are seeing in front, the white structure is a migrated disc herniation. I'm directly landed over the disc herniation and I'll be able to remove it nicely. So 12 o'clock is the ventral aspect, 6 o'clock is dorsal, 3 o'clock is inferior, and then 9 o'clock is the superior aspect, and this is the first fragment coming out. So with the pediculotomy, you directly land over the fragment. It becomes very easier for you to grab the fragment. Sometimes you need to use the kerrison to increase the ventral approach to grab the more fragment. So always check for the residual fragment. At the end of the procedure, I give 10 minutes to check for the residual fragment. You will be able to find at least, like out of 10 cases, in 2 cases you will be able to find the residual remaining fragment. So give it time and search for the fragment. And this is a huge fragment coming from the inferior and the ventral aspect. And you can see the nicely decompressed nerve root at the end. So patient was very happy after the procedure, but is it a safe procedure? Because there are a feared complications associated with this procedure, which are facet injury, pedicle fracture, and the nerve root injury. There are not many cases reported about these complications except for this one, in which the Wu Dong Nam did the L5S1 endoscopic transforaminal foraminoplasty for the patient with L5S1 lytic listhesis. The patient was having only the radicular symptoms and some back pain. So at 6-week follow-up, patient had a recurrence of the symptoms, and he diagnosed to have a pedicle fracture. But is this complication related to the endoscopic spine surgery? So we have to look up this article published by the Calec, where they did the reduction of the pedicle, 10%, 25, and 50%, and they compared with the intact native side. And they also assessed the influence of bone quality on the resistance of the pedicle after the reduction. So this is how they did the study, pediculotomy, CT evaluation, and then applied the uniaxial compression loading to the pedicle. And they found that with increasing reduction of the pedicle area, axial load to resistance was reduced significantly. Also, while comparing the Hounsfield unit, they found that at 10% and 20% pedicle reduction, there was a positive correlation with the Hounsfield unit with the resistance force. And they advised to avoid the resection of the facet joint and the craniomedial pedicle, particularly in a case with the pre-existing spondylolisthesis. Assess the bone quality before deciding on the pediculotomy, and if the extensive reduction is necessary, avoid lordotic motions and the activity that increases the axial loading postoperatively to minimize the risk of pedicle stress fracture. Then should we do this procedure or not? Yes, we still can. We have to look at this article published by the Q, where he present the case series of the three patients, and you can clearly see in patients, first 2 patients, he gave the follow-up of the 10 months. You can see that there is a complete healing of the pediculotomy defect. This is a pre-op, immediate post-op, and that is like 10-month follow-up. In another case, there is like at the 12-month, there was a near complete or the partial healing of the pedicle. So yes, we can safely do the pediculotomy in a transforaminal endoscopic procedure with proper indication and the precautions. The proper indication can be a high-grade lumbar disc herniation for the young individual with a good bone mass. definitely for the upper lumbar disc herniation. For the recurrent disc prolapse with previous laminotomy defect, as we know, if we go from posterior, we have to remove the some more bone and we can injure the pars fracture. So pediculotomy can be a safe procedure for such a patient. So how can we avoid the complication? By limiting the area of pedicle relaxation, avoiding the using the oversight refine, avoiding the lordotic motion and activities that increases the axial loading postoperatively, we can minimize the risk of pedicle stress fracture by doing the slow rotation of the trifine with the moderate patient using the side cutting reamer. We can minimize the risk of the nerve root injury. Also, we have to understand that we should limit this procedure to the fragmentotomy and avoid the discectomy, as discectomy will further accentuate the instability. So take-home message can be a pediculotomy in transforaminal surgery can be done safely in patients with young individual and with good bone mass. Always assess the bone quality before planning for the pediculotomy. And along with the concept of pain generator, we need to understand the concept of stability and the bone quality in a spine endoscopy. Thank you.
Thank you, Dr. Swapnil, for sticking to time. We have Dr. Siddharth Verma. Okay. So it's going to be a talk on PSLD, contralateral approach for foraminal stenosis.
उधर से आ जाओ। Sound is on. So thank you for the kind introduction. I'll just move on quickly with this very simple talk. A lot of much complicated stuff has been displayed already. So this is about the PSLD for contralateral approach in a patient with foraminal stenosis. So greetings from our hospital, Diva Patil Medical College, and this is our team with all the fellows. So I will be covering the indications, technique, experience, and pitfalls. Anybody knows this guy? Yeah. Who said that? Yeah, okay. So this guy, okay, today we'll know what he does. He does something which I'm going to show. It's quite simple. So I'm going to play this short video. On है. It's okay, नहीं भी आएगा चलेगा. So his videos are quite popular on all shorts and TikTok and Instagram and other stuff. So we can go on and on, but you get the idea that there are very complicated ways to do a very clear and simple thing. So this is what we're going to do today. I can go with like, there are at least 1,000 videos with like billion followers and all that. So what I'm going to do is just tell you the indications which we use this for. So this is a foraminal pathology, bilateral pathology, of course a little bit of vertebral rotation, or if the width of the laminar space is narrow. And since I was taught this technique by Dr. Lim, so I replaced Cabby with him, and then we go on from there. So this is a picture from one of the publications where they have tried to portray what it started with. So this is how it started with, and they kind of realized that rather than going from the same side, it is easier to go from the other side because the path is quite straighter. So the entry point is important, and MRIs and CT will guide you for the preoperative trajectory estimation. So usually we rely on the MRI. And once a dilator is inserted, we penetrate and resect the ligamentum flavum, then put in the endoscope. This is the usual method. And we advance the endoscope with beveled working sleeve between the posterior dura and the flavum under direct endoscopic vision to reach the working zone. It's a bare area, so and more advancing into the lesion neural foramen. So when you are starting, you should check the AP in C-arm. That will give you a good idea of where you are. So this is a picture which is from a paper. I'll just reference later on, but I'll just make it other way around so that it becomes more clearer. So you are seeing the trajectory, how we are going and how we are going to approach. And I think this has been demonstrated by a few of the previous speakers using the surgical videos. So I will skip this part. But the key here is to understand that you can address all these pathologies right from the same side to the other side using this same monoportal technique. And in this picture they have shown these are the pedicles signified with the blue color. The green signifies the area of the flavum, and the red is the area of the lamina. And while there can be many methods to achieve the same thing, this is one of the proposed method where they have used exclusively the drill to achieve what they want to achieve. In my practice, I use if I can get my kerrison in, I use mostly the kerrison to do this. And in my limited experience, maybe I have done this way around 20-22 cases, and I found that kerrison, if you are careful with your sleeve, it is very good, and you can easily do it with kerrison as well. Initial drill systems which I had were not very good as well, so probably that was a necessity rather than a choice. So it's useful, in my experience, it's useful because of the large interlaminar space and large space between dura and laminar arch in the midline, and I use it to my advantage. And then I take precautions to avoid neural structural damage and just keep a tab on my sleeve. If I am going too harsh with my sleeve, I may injure the neural structures. And of course, it's a super time saver. Once I'm done with the same side, I have realized the opposite side is just quite time saving. So on same lines like Cabby, I also make my Instagram reels, but my reels are slightly different. And this is how I show this. I had sound also, but for some reason it's not coming. So after the same side work, I can see the clearance on the same side, and then see the axillary and the ipsilateral clearance. After that, can show the other side, and the other side actually is quite important in some cases, and the patient may turn up later on with problems sometime later. So it's important to achieve the clearance on both the sides. So this is it from my side. I have kept the talk simple. These are the references. One of the book which I initially referenced. Now there are many books available, but when I started, there were like quite a few which were there. So I have put the picture of that. And thank you very much. Do join us for some of our workshops in future as well in Mumbai. Thank you.
Thank you, Dr. Verma. I would now invite Dr. Sambhav Shah, who's going to be speaking on full interlaminar endoscopic discectomy for migrated disc. In the meantime, do we have any questions for the speakers?
So you already heard a few talks on migrated discs. One was by Dr. Swapnil about pediculotomies and targeting the migrated discs. We've heard a lot of endoscopy, and for everyone's reason for doing an endoscopic surgery is very different. They get excited about it or they venture into it because of some reason. Our Prime Minister, Mr. Modi, uh, had done the surgical strike. And surgical strike is basically a military attack which is targeted to damage only a legitimate military target with no or minimal collateral damage. And in fact, some say that he won an election because of this. So I also feel that any surgery targeting only the pathology without causing damage to surrounding structures and leaving no proof behind, I think that's one of the best surgeries you can offer to a patient. And I feel that interlaminar endoscopy does do this job, and it's I feel it's a surgical strike on the disc. A few people mentioned earlier that for migrated discs, interlaminar surgery, you cannot target. It's a non-targeted approach. You have to remove a lot of bone. I agree. For a higher level, L3-4, L2-3, even any surgery, it will require removing bone if you're going from the back. So my approach transforaminally, if I can get that migrated disc out without causing the least damage, that would be my approach, but not at the lower levels, because at the lower levels, because of the anatomy, the huge windows, we have easy ways of managing and getting that by doing a targeted approach. So, you see a normal MRI where patients have, I just mentioned some disc here, some disc there, mild arthropathy. But when you see a post-operative MRI, and this is not a post-UB MRI, it is someone with a post-micro MRI, that you see that there is a L5 defect. So usually majority of our post-operative MRIs, we see L5 defect, fibrosis, etc. But honestly, the MRI which I showed you before, this is a post-interlaminar discectomy MRI, where even the radiologist could not make out that this patient was operated. So that, I believe, is a surgical strike on the disc. So if I have a patient like this coming with a huge, sequestrated fragment which has migrated superiorly, yes, a lot of people will say that you have to remove a lot of bone for this, but use the interlaminar window. There are various ways to get this disc without causing much damage to the spine. So read the MRI, see the X-ray, how wide the interlaminar area is, how the L5-S1 region, is it big enough, the L45 region, is there space for your camera to go in? Mark your entry points well, plan the steps well, target the disc, and obviously it has to have the a la carte approach. So if you see this patient with the axial scan, the disc has migrated superiorly almost near the L5 pedicle. So if I want to do something, I have to make sure that I'm reaching near the L5 pedicle, because here I want to see my L5 exiting nerve. The S1 traversing nerve is not very important. It's the L5 exiting nerve which is important. So when I see an X-ray like this, I'm seeing that there is a wide interlaminar window in up, down, and as well as medial to lateral. So I would want to target this here. Now you may decide, okay, I have to do a L5 laminotomy and go inside to get that disc to be medial to the pedicle. But at the same time, if I go into the interlaminar space, and if I just go down, I will not be able to target that disc. I will miss it. I will not be able to find that disc. But in fact, I have to go superiorly. So using the flexibility of the interlaminar approach, I think that's what the advantage is. Because of the flexibility, you can go into areas where you are not compromising on the vision and you are targeting the pathology. So if you see in this slide also, I'm in my interlaminar zone, in my AP, I'm taking my entry point a bit inferiorly so I can target superiorly. I go in, I remove the flavum, and then I go in superiorly to target that area. So my nerve hook, you see, after removing that piece of disc, is at the L5 exiting nerve. So just showing you the video of the same case. Now, normally I just make a slit in the flavum when I just want to go to the disc. Now here, I'm going to go a bit superiorly so that I can go towards my target. Similarly, if it's an inferiorly migrated disc, usually in the interlaminar region, you are just down because you are already inferior to the disc majority of the cases. So I'm just going to remove a little bit more flavum here because I want to target up. Once I am at the shoulder of the traversing nerve, you can obviously have to dissect that nerve, make sure that there are no adhesions over there, and you see that there is a portion of the disc which is already coming out. Now, once this portion of the disc is coming out, obviously I'm not seeing the nerve. And even if I remove this piece of disc, my end point is that I want to see that nerve. So I'm using a nerve hook here to try and scoop out further fragments. forward this. Is there a way I can forward this? Okay, anyways. So there are a couple of fragments. So now you can see that's the annular defect which was there. So right now, I'm now going to start go superiorly. This is from where the disc had come out and it has gone superiorly. So that's where you see that the white fragment that's the disc fragment. Above that is the L5 exiting nerve. So mind you, I have not done any laminotomy here. There is no medial facet resection. There is no L5 laminotomy done. It is just going down and then going superiorly. So we're removing further fragments. As previous speakers mentioned, always keep on looking for more fragments. You don't want to leave out any fragments behind. So still the top, you see from 12 to 11, that's the exiting nerve which is going, and below that still there are some fragments. And after removing those multiple fragments, finally you want to see that the axilla of the nerve is completely free. Then you see your traversing nerve as well, and then your surgery is over. So the same patient, another patient now, which is with the inferiorly migrated disc. So this is the L5S1. As you can see in the last two images, the disc has gone inferiorly. If you see the axial images, the disc has gone inferiorly again significantly. Now reading the MRI is very important. Now when I see this MRI scan, you see in the second image from the bottom, that's my interlaminar area. That's where just my ligamentum flavum is. There is a huge piece of disc. I see my S1 traversing nerve next to it. So I know that this disc is going to be in the axilla. So yes, I want to see the lateral part of the nerve, but my whole surgery is going to be in the axilla of the disc. So I'm targeting also that way where I want to start laterally, but then eventually I want to go down inferiorly. Now, in L5S1 inferiorly migrated disc, when you go into the interlaminar region, you are actually going to be in the axilla. The axilla is going to be right there. So again, you don't need to do any kind of laminectomy here. You straight away start with the surgery, where again, you go onto the ligamentum flavum directly, make a rent, go in. Now here my aim is going to be in the axilla. So what I'm going to do is I'm going to make a rent laterally as much as possible. Mind you, I only remove the amount of ligamentum flavum required for me to target my disc and nothing else. So here I will not remove any flavum superiorly. I will not remove any flavum inferiorly. Just in the center. Now I can already see the nerve and some epidural fat over there. So I know that I've gone with my ligamentum flavum resection laterally. I've touched the bone over there, so I know I'm at my lateral extent. So I should be on the lateral border of the nerve. Now in these situations also, when there is a disc in the axilla, you see how the nerve is pushed laterally. So again, if you start medially, you might not realize where the nerve is. Now I'm in the axilla directly over here. I'm taking advantage of the fact that the nerve was pushed laterally by the disc. And the minute you go into the axilla, and the fragments will just come out. So again, this is a completely targeted approach. You are without doing any major normal natural anatomy resection. Over here also, my end point of the surgery would be that I want to see my axilla clearly, I want to see the shoulder of the nerve clearly, and I want to see the nerve in complete totality. Always, all these migrated discs, they have a lot of remnant fragments. So be careful, keep on assessing, spend time towards the end. Don't look at the clock. It could be 20 minutes, it could be 1 hour, doesn't matter over here. It's a lumbar spine, because you will keep on getting fragments. So you have to even go underneath the dura and try and see that there are no remnant fragments left. And now this is what I like. So I'm seeing the dura, I'm seeing the whole nerve, I'm in the axilla, I'm able to see the medial border of the nerve, the lateral border of the nerve, the shoulder of the nerve, and the axilla of the nerve. And then I know that this surgery is now complete. So if you see now this patient, we had also done a post-operative MRI scan. Obviously here, because I had to resect a little bit of the flavum almost laterally, you can see that there is a slight flavum resection, but inferiorly again, you see that the flavum is completely intact and that fragment has been beautifully resected. So even the lowest fragment, which was medial to the pedicle, even that has been beautifully resected. Another case where there was inferiorly migrated fragment, here I just want to make out a point again that this was not that inferiorly migrated. So I have just made a small rent. So this is the pre-operative MRI, post-operative MRI scan inferiorly, where on the right image, just near the ligamentum flavum, which is completely intact yet, but you see a small white rent. So that's the flavum rent which we've made. You make current in the phlegm. The phlegm is elastic. You can actually spread the phlegm across and go in, and you don't need to resect the whole phlegm. So again, even if there are inferiorly migrated, superiorly migrated discs, if you plan well, you can save the patient's natural anatomy and you can execute the surgery beautifully. Thank you.
Thank you, Dr. Shah. I invite the next chairperson, Dr. Imjung, and Dr. Pestonji for chairing the next session.
Yeah.
Yeah.
Can I ask a question?
Thank you,
Well, thank you for a nice presentation, but I agree, we can remove the migrated and fragmented disk. We can remove almost all cases, but sometimes we don't know. How do you make sure you remove the small particle inside upward migrated disk? How do you know?
I remove?
So there is a remnant disk or no? How can you make sure? But you mentioned about the nerve root pulsation is okay, and you make sure. But with monoportal endoscope, we cannot use a bigger nerve hook or like that, okay? So we cannot reach the area. Sometimes there is some small particle is there. How can you make sure?
So the first thing is, as I said about reading about the MRI, if I have seen that there is a disc which has gone into the axilla, I am going to go and make sure I see the axilla completely. Number two, we have these flexible nerve hooks as well, which are much bigger. So they go down straight and then you can open them and they become flexible, so which are much longer. So you can actually go almost till the midline underneath the dura to go and get the fragment. Number three, as I said, that especially with this migrated disc, you always have some fragments lying around. So even if you get a big fragment to start with, I think we should not get very excited and we should always keep on trying and explore. But eventually my end point is that if I'm seeing the nerve completely, the patient is S1 radiculopathy, I'm seeing the nerve completely, the medial border, lateral border, shoulder, and it going underneath. And based on the MRI scan, I'm in majority of the case pretty confident that I have not left behind any fragment if you have seen all these areas. So with monobottle also, I feel that's why with transforaminal, sometimes I'm a bit iffy yet because you cannot see the whole nerve in totality. But with interlaminar, you can see the shoulder, axilla, and where I'm more confident that I have not left anything behind. So I always prefer interlaminar over transforaminal for these cases. Thank you.
Dr. Imjun and Dr. Shah, Seshav Shah, to chair the next session. I invite Dr. Chalali. He'll be speaking on difficult cases in UB surgery.
Because of time schedule, let's invite the next speaker and Dr. Maxime from France. The topic is difficult cases in UBE surgery. Please.
Of France. My topic today will be the difficult case in UBE surgery. So today, I'm Dr. Chali from France. Today we will speak about the difficult case in UBE surgery. What can you do in UBE surgery and what you can do, it's not possible to do. So UBE surgery is not only two-scar surgery. If you start UBE surgery, you must forget that it's not only two scar, one scar monoportal. It's a technique. When you go to do a difficult case, it's like a battle. When you do a battle, you need to have good weapons. You need to have a good strategy. If you don't have a weapon or strategy, don't go to do a difficult case. So when you do a stenosis, what you need to have to do this case? The first thing, you need to have a good visibility. It's very important in UBE surgery to have a good water flow, to have a good visibility. If you use a pump, you need to masterize it, to do it very effectively. You see, if you have this water flow, you can do all cases, but you need to have this. The second thing, you need to control bleeding in difficult case. You need to have bone wax, RF, but you need to have bone wax and RF. If you have only one, you will be in trouble. You need to have a good scope, the grid scope or 30-degree scope. You need to have all these things. And when you go to do difficult case, you need to have abrasive burr, diamond burr, high-speed burr. You need to have these three things, not only one. When you go to operating room, most of the time you have only one, and you have a problem. And before to start, you need to have your strategy, how you will do your case. If you must know one thing about UBE, in UBE, you work forward you. You not work like this, you work forward you. So it's easier to go to opposite side. This is the main concept of UBE, or you need to know this when you do your case. So this is a case of stenosis. This is the huge stenosis. You see, in this case, they decide to do LBD. When you do this, you need to be ready for everything. So when you do this case, all time you will go to opposite side, or you need to work to go to lateral side. You need to know this. The first step is you do an superficial arthrectomy, and after you need to work to your side, to try to work always to your side. After you go to opposite side. So the main thing, you need to know that you need to work maximum on your side. So in this case, I decide to use a diamond burr, and I want to show you that you need to have all this stuff. If you use aggressive burr in this, you have a lot of bleeding, you have a lot of problems. And you need to have all things, diamond, aggressive burr, high-speed burr, and decide in which case you need to use it. So when you do stenosis, please do X-ray at the end. You don't resect enough bone. All the time you think you did enough, you need to check it. And in this case, you have a high risk to do a dural tear. So if you do dual tear, in this case, in this patient, nothing will happen. There is another concept in UBE, it's the combined approach. Sometimes, to decompress the excessive route, you need to go inside the canal and to do para-UBE too. This is this concept. You need to, in some case, sometimes you need to do combined approach. You need to know this possibility. A case like this, if it's a right side pathology, if you go in the canal, if you go maybe opposite side, maybe you wish it. But you need to know that this is possibility to do combined approach. You need to know that sometimes you need to do it. About contralateral arthrectomy, when you do when you decompress the patient, you need to know if you need to remove contralateral facet or not. If you're fighting too much with Kerrison or with stotum, you can have a nerve deficit of opposite side. You need to know if you need to do a big arthrectomy or if you don't need to do arthrectomy. It depends if you have anatomy of sagittal of your facet joint. So when you have degenerative spondy, almost time, the facet joint is vertical. So you don't need to do too much arthrectomy to opposite side. You don't need to fight to do your arthrectomy. When you do your surgery, you need to know what you will do before to do the surgery. Is it possible to do revision of open surgery VB? This is the case of patients, she had a discectomy with a big scar, open surgery. I decide to do this with VB. So when you do this case, you need to do it like open surgery. So you work on bone, and you need to remove more bone to find the non-normal structure. Now you see there is a normal ligament, and there is fibrosis. So in this case, you do like open surgery, you go to normal anatomy, and after you go to operated anatomy. So now you see this is the fibrosis, I push the nerve root, and I can do my discectomy. So the strategy in revision UBE, when you have open surgery, when you go to UBE, is to find the landmarks, the bony landmark, and to try to find the normal anatomy. When you do a facet cyst, you need to do contralateral approach. With this, you can make a very clear dissection of your cyst. So at the end, what you can do with UBE surgery, you can do all posterior surgery. If you don't do deformity, you can do all cases with UBE. If you have good strategy, if you have good tools, if you have good birth, if you have everything in your arm. And UBE is not only to scar, it's a strategy. You need to have a strategy before you start your surgery. So you need to know the strategy. You need to know what you will do before to start. So this is a small topic to introduce this. Thanks for invitation. And we invite you all to next year. I think we will do the third French spine course in France. Thanks for the invitation.
So thank you for Dr. Maxime and nice presentation. Is there any questions in the audience? Oh, questions. Oh, okay. In the end. And next speaker will be Masato. Yeah. Siam-free UBE, please.
Notice. Siam-free UBE is siam-free UBE. I put this one. That's why I should use mine. It's not. Okay. It's okay. My presentation is a little bit different from previous one. So I would like to concentrate on the dark side of endoscopic technique. If you look at this beautiful lady, so it needs about 150 years to become like this. So as you know, it needs a lot of time to change MI strength. Some guys say, very similar to you, so it's not you. So the presentation and a lady's skirt are very similar because the shorter, the better, if only it covers important part. That's why my presentation is very, very simple, very short. So from microscopic technique to endoscopic technique, as you know, just less than 50 years history. This is the contents of my talk. I would like to mention about light and dark side of endoscopic technique. As you know, this trend, endoscopic technique, is becoming very popular all over the world, especially you, because of minimally invasiveness and less infection rate, better visualization, of course. But there are several problems. Number one, for this technique, you have to use C-arm, like this. Some doctors say just one shot. Actually, it's not one shot. At least 4 or 5 shots. You look at this. Some paper said, so average 5 times. Some paper says more than 29 times. This is the review article, even for the specialist. Of course, operation time is about 1 hour. However, the average flow time is, some report says more than 2 minutes. You should remember this. This is a famous report. So I'm also do a lot of deformity surgery. Adolescent idiopathic scoliosis patient, we have to take a lot of X-ray because of the follow-up radiogram. So this cohort study, AIS patients have 4.3% of cancer. So this is 5 times higher than control group, especially endometrial and breast cancer. If you look at all staff, they also have a cancer risk. So upper limb, lower limb, it's okay because it's not so high radiation dose. However, for body, we need more than 50 millirem. It's a high dose, and 10 times greater than the other non-spine surgeon. You remember Chernobyl disaster. So this disaster, more than 30 people died directly. However, more than 4,000 cases of thyroid cancer reported. We also have this kind of disaster, Fukushima Daiichi nuclear power disaster. After this, we have more than 100 times thyroid cancer. So this is more than 1/3 of our total children have thyroid cancer. That's why we should think about radiation exposure seriously. Problem number 2 is a disorientation. Sometimes we are lost during surgery. That's why you have to remove a lot of bone. Our solution is O-arm and navigation, and navigated high-speed ball. This CAT scan only 23 seconds. The problem number 3 is steep learning curve. That's why we need this kind of cadaveric seminar. So let's move on the tubular endoscopic assisted tubular surgery. This is L5S1 extraforaminal disc herniation. For you, this is very easy. Now you can see the disc material there. We perform CM-free technique with tubular retractor. Let me show you the video. So I'm afraid of radiation exposure, so always navigation without CM. Now I'm removing the disc like this. Now you can see that the nerve root is beautifully decompressed. This foraminal stenosis case, sometimes very difficult to remove the bone, and sometimes you remove a lot of bone. However, if you use navigation, minimal bone reduction is performed. Next will be a CM-free UBE. This is a simple L4-5 big disc herniation, central one. We use CM-free UBE. Let me show you the video. So skin incision is made by navigation. Now I'm marking the pedicule, L4 and L5 pedicule. And then decide the skin incision under navigation guidance. Exactly same technique, but I never use CR. And then this dilator is also navigated, and high-speed bar is also navigated. You don't have to use any CR. If you approach this, so exactly same technique you use, but usually you need CM to confirm the location. Now I'm removing the discarnation. The same technique of yours. The final one is a fully endoscopic technique without CM. This is foraminal discarnation. We use CM-free technique. And leave the disc like this. Another case, I'll show you the video. Entry point is very simple. If you use navigation, just pinpoint. There is no one shot, two shot, AP lateral, we don't need. And high-speed bar is navigated, so foraminoplasty is very easy. After that, the technique is the same, as you know. We already published this paper about CM-free UBE and also CM-free TELD. Take-home message is CM-free technique is beneficial for patient, not only patient, but also the operation staff. And navigated high-speed bar is available to perform foraminoplasty for transforaminal approach. Navigated CM-free discectomy is a very useful technique with minimum radiation hazard. Thank you for your attention.
So thank you for brilliant and short lecture. Thank you. Let's move on next topic. So Lufti, so okay, question answer is we are at the end of session. We can. Yeah, very good lecture.
Very good lecture, Dr. Masato. Because it's very hard to have a C-arm because radiation exposures. But the problem is patient get the radiation exposure more than that. It's not? Okay. Let us discuss that later. So, thank you, Dr. Prestanji, for inviting me. Today, my topic is debate between uniportal and biportal. So, a lot of people say that uniportal better than biportal, but some say that biportal better than uniportal. Which one is preferred? That's very good issue that we can discuss it in this situation, in this event. So as we know, full endoscopic widely used in spine surgery. As we know nowadays, we really know that people like to do the endoscopic procedures for this spinal pathology. And as you know, the advantages, disadvantages. But the problem is all those procedures need special tools for the procedures, such as tower, the endoscopic one, the camera, the lens. So all those tools is not that cheap. So for us, it's very expensive. So that's why we have to compare which one is the more benefit for us. So as we know, we have a uniportal, PLD, PSLD, transforaminal, interlaminar, biportal. Then we try to study comparing between uniportal and biportal, and we want to know from the Indonesian spine surgeon perspective which one is better between uniportal or biportal, or which one is be preferred. So it is actually the survey among these Indonesian spine surgeon, and because there is a lot of questions, especially from the beginner, which one of the procedures we have to start, the uniportal one or biportal first. So that's a lot of question about it. So this is the basic instrument that's already mentioned from the previous speaker. If you look, there is a lot of lines that we have to have for the uniportal, but if we compare with the biportal, we just need one instruments. So this is from transforaminal for uniportal. So this is uniportal. If you look at the procedures, it's very simple. You can do local anesthesia, and you can do also the general anesthesia. This is also biportal procedures, and if you look at this, it's very easy. So I'm sure everybody knows these procedures. Then it is not that that, like Dr. Masato said, that radiation exposure for the uniportal is quite big rather than the biportal. So I just want to show you several questions. A lot of our surgeons say that uniportal more radiation exposure rather than the biportal. So among 113 spine surgeons, member of our community of spine surgeon in Indonesia, 33 filled the survey, and so this is the result. So one of the questions, training, formal training, and the type of the training. So how many cases that you have already done? Most of them usually more than 20 cases a year. So what kind of the pathology that you do? So all those questions. So I've already asked to them. So I just want to show you the result. So this is the result of our survey in our spine surgeons. So only 30% filled the survey from the all spine surgeons in Indonesia, and mostly they do for the lumbar degeneration such as spinal stenosis, and 59% only do biportal, and 29% do the uniportals, and only 14% do both uni and biportal. And if you look at the costs and the tools, uniportals is more expensive than the biportal. And if you look at the learning curve, uniportal more steep than the biportal. So again, the uniportal more radiation exposures rather than the biportal. So there is a lot of studies talking about comparisons between the uni and biportal. And if you look at the VAS after surgery, uniportal have significant early post-operative back pain rather than the biportal. So if you look at the other technique, other procedures caused by the muscles destructions between uni and biportal, So uniportal, less muscle destruction rather than the biportal. So if you look at the fusion rate between biportal and uniportal, so biportal has a advantages rather than the uniportal regarding the operative time, higher fusion rate. But the other benefit is a wider surgical field, greater maneuverability of instrument, feasibility during case implantations, and transverse orientation of the case. So a lot of papers said that the biportal more advantageous rather than the uniportal. So as a summary, both uniportal and biportal are safe procedures, and based on our survey, biportal is more preferred than the uniportal. And look at the total cost paid by patients, is the same, both procedures. And this is my note that as a beginner, you can start with the biportal rather than the uniportal. Thank you very much for your kind attention.
Thank you, Dr. Gatam. I think we can take the questions later on. I will call upon the next speaker because of the short of time. Dr. Pao, he'll be talking upon update for no punch decompression technique in UBE surgery.
Last year, I have presented my no punch decompression technique in this meeting. And this year, I will want to update my technique and the experience I learned in this year. So I want to talk about the update of my no punch decompression technique in the UBE surgery. The first is that the UBE, the Carrison punch is developed in the 18th century, about 200 years ago, by the Dr. Carrison. And the most important surgical instrument in the modern spine surgery. But why I don't like to use the Carrison punch, there are three major reasons. One is to avoid the occupation hazard. And the second is to avoid the dural tear. And the third is to have a better facet preservation. I will tell you why. The first reason is occupation hazard. When I use the punch, I have a lot of problems, such as the trigger finger, carpal tunnel syndrome, decubus disease, tennis elbow, golf elbow, subacromial impingement, frozen shoulder, anything you like, I have to have a steroid injection for about 5 or 6 times. But when I use the no punch technique, I never have such problems, and I don't need a steroid injection anymore. I will show you 2 hands. The one hand, the left side, is my hand, the biportal no punch hand. The other side is the extreme of the end, the uniportal punch hand by Dr. Kim. You know that Dr. Kim use the punch very, very often, and he doesn't like to use the burr. So the UB, the complication is the most common is still the dural tear, about 4.5%. And we try to make this risk down to 0%. That's our vision. And we realized that dural tear really has some adverse events and a long-term sequel. In our patients, we have one permanent sensory deficit, one permanent motor weakness, and one patient had a delayed recovery from general anesthesia. So we realized that neural injury or the dural tear will never be a complications with no sequel. It does have some adverse effects after the complications. And if we look back at our case series, we have a decompression case, fusion case, revision case, and the cervical cases. We know that the dural tear is, the incidence of a dural tear is the highest in the revision surgery. That is reasonable. And the overall incidence in my series is 5.3%. So the revision surgery has the highest risk. Why is that? Because when when we do the open surgery, we never realized that what is under the ligamentum flavum. But in the severe case, in the case with the severe stenosis, there will be a severe adhesion and inflammation underneath the ligamentum flavum. So when you perform you insert the Carrison punch under the ligamentum flavum without explore it, it may accidentally puncture the dural matter. So in our review, we know that 91% of the dural tear was caused by the Carrison punch. So it is the most dangerous surgical instrument in the UBE surgery to cause dural tear. So we try to avoid use such kind of instruments to reduce the dural tear incidence. Instead, we use the high-speed drill as the major decompression technique. And we also develop a specialized curved osteotome or chisel to accomplish our goals. The curve, the Carrison, the osteotome is about 4 millimeter wide with 0, 10, 20 degrees curve. And I will show you how to use this technique. The first step is to try to find the cranial attachment of the ligamentum flavum, like you usually do. Use the burr. Then I go to the caudal side to detach the superficial ligamentum flavum from the caudal vertebral lamina. Then leave it and remove it using the pituitary ruptures. And use the burr to trim out the margin and to find the caudal attachment of the ligamentum flavum. Then we go to the contralateral side, detach the ligamentum flavum from the spinous process and the contralateral lamina using an elevator, and advance our diamond burr into the lateral recess. You can advance the diamond burr as deep as to the contralateral side, very, very deep. It is safe. And this picture shows you that after the drill work is done, you can see two ligamentum flavum there. Then you go to the ipsilateral side, from caudal to cranial side, use the curved osteotome to undercut the facet joint to preserve the facet joint as much as possible. Then you can use the curved curette to elevate the ligamentum flavum from its periphery, not going to the epidural space from the central slit. Then that way you can remove the ligamentum flavum as a whole piece. Then go to the contralateral side. You also use the osteotome to undercut the contralateral facet joint, and use the curette and to separate the ligamentum flavum, and then take it out as a whole piece. That is a very important video, so I want to show you the whole video. Then you can use the osteotome also to check the residual stenosis at the lateral recess. I will show you that after the drill work is done, and after we remove the ipsilateral ligamentum flavum, and then complete the decompression. And use the technique, you can remove the ligamentum flavum as a whole piece, en bloc removal. And you can get a very beautiful butterfly ligamentum flavum. But my butterfly is different from the others because we have a bone chips around the peripheral. You can do very good decompression with minimal soft tissue injury and very good facet preservation for 2-level decompression, and also for 3-level decompression. You can have the very good result. And how do we if we compare it with our punch technique, we see that the dural tear, the incidence of dural tear was reduced to almost 0. The one nerve injury was caused by the coagulation, plasma coagulation, not the Carrison punch, because we don't use the Carrison punch anymore. So the no punch decompression technique significantly reduced the risk of a dural tear to 0. Actually, we have more than 1,000 consecutive cases without dural tear. So in our surgery, we never prepared the dural repair anymore. It is not an issue in our series. So if we evaluate the decompression effect and the facet preservation, if we compare with the punch technique and the no punch technique, we see that the dural expansion has no significant difference. The facet joint preservation, there is no significant differences. So these two methods are equally effective in dural expansion and facet joint preservation. But in our concept, when we perform ULOBD for spinal stenosis, in our original concept or classical concept, we always think contralateral side is preserved better than the ipsilateral side. We have the same experience. So we have a comparison. Compare the conventional punch technique and no punch technique. We found that the contralateral side and the ipsilateral side facet joints were preserved equally good for the punch and the no punch technique. But if you further evaluate these two series, you found that in the no punch technique, 61% of the ipsilateral facet joint is preserved better than the contralateral facet joint. That is a conflict to our classical concept. Why? Because we use the curved osteotome to do the facet undercutting. So we can preserve the ipsilateral facet joint as well as good as the contralateral one. So what would you do the approach from left side or right side when you consider to do the surgery? There are several points that you should consider. The one is the patient's major symptom side and the decompression effects. And the patient also have some anatomical considerations such as spinous process hypertrophy, facet joint hypertrophy, degenerative scoliosis. And you have to consider the surgeon's handedness. I am a right-handed surgeon. And you have to consider how to preserve the facet joint and your preference. So for the novice surgeon, the treatment effect is the most important. So the most important consideration is the patient's symptom side. If the patient has right side symptoms, you should approach from the right side to guarantee the treatment result. For the anatomical consideration, if the patient had deviation of a spinous process or hypertrophy of the facet joint, such like this case, if you approach from left side, it will be very difficult because the spinous process deviated to the left side. But if you approach from the right side, it will be easier. So for this patient, right side approach is better. For me, I am a right-handed surgeon, so left side approach is more convenient and much more easier for me because the cranial lamina is always higher than the caudal lamina. So I can approach from the left side is easier. And for the facet joint preservation, if you use the punch technique, the contralateral side is preserved better. Just several. If you do no punch technique, the either side is preserved as good. So which side would you go? If you are a novice surgeon, your consideration will be the patient's major symptom and the decompression effect. If you are an experienced surgeon, your consideration will be the facet joint preservation and anatomical consideration. But if you are a no-punch surgeon, your consideration is your preference and the patient's anatomical consideration. Thank you. This is my update for the no-punch technique. Thank you.
Thank you for the wonderful video that you gave.
Thank you.
So I'll call upon the next speaker. He's Dr. Henry DiMano. He'll be talking on UBE decompression for POTS disease. Is Dr. Henry available? Yeah, he's coming.
Good morning. Thank you, Dr. Pistonji, for inviting me again. I'm glad to have made it this time. I'm Dr. Henry Dimana. I'm from the Philippines. And as you've seen, I actually trained under Dr. Parkway back in 2019. Just a few disclosures. I practice out of several private hospitals in the Philippines, and quite recently, one government hospital. So since 2019, I actually haven't needed to open patients up. And before this, I was doing T-lifts left and right, but now I hardly do any T-lifts. I have this advocacy. The reason why I adopted UBE was mainly because of what I learned from my orthopedic mentor for the orthopods in the room, Dr. Ramon Gustillo, V. Gustillo. He's still alive. He's 94 years old. And he basically taught us residents that the idea is to bring new innovation, bring it to people who cannot afford new innovation, bring it to people who have no access to new innovation, or people who normally would get some other treatment that would not be as good. So I follow this dictum in my practice. Okay, so a word on Pott's disease. I come from the Philippines. TB is very endemic in our country, and it's endemic in several other countries. Usually the idea about TB is that it's a lung disease, true, but sometimes it's extrapulmonary, and for a majority of the manifestations, extrapulmonary TB can be osseous or orthopedic. Most of them, half of them at least, are going to be spine TB infections. And as we know, the risk factors for developing tuberculosis are largely socioeconomic, poor health, poor nutrition conditions, which is present in my country, being third world. Some genetic predisposition is also being cited. Okay, up to now, we basically treat it medically, your 4-drug, 5-drug treatment protocol. But whenever there is compromise, there's neurologic compromise or compromise of stability of the spine, we of course tend to look to surgery, which to a large part is still being done open, whether it's done as an approach, anterolateral, which do, or nowadays posterior approach using hardware. These are big approaches, they're very morbid. So in my setting, the biggest problem is always going to be cost of treatment. Can the patient afford it? Even with government help, even with the charity hospitals in my country, that's usually always a cost because the implants are basically shouldered by the patient. Okay, I'm going to give 2 examples. This is a first teenage boy who basically was already diagnosed with active pulmonary TB, had neurologic symptoms, had mechanical symptom of the spine, could not walk properly, but his main symptoms were neurologic. He was admitted in a government hospital where I serve, and unfortunately, we don't have an MRI scan, so I did not have the luxury of ordering MRI scan. And at this point, we also did not have UBE surgery or endoscopic spine surgery or arthroscopy of any sort. I had to bring in a portable scope. I apologize, I don't have the footage for the endoscopy, but basically we did the surgery. Okay, no MRI scans. And this is the pre-UBE, post-UBE. I decided to do UBE. One of the main reasons was that the fact that the medical condition of the patient was not quite optimal to do any kind of open surgery. And even if I could do open surgery, they could not afford the implants anyway. Okay, side note, there's no retropulse or any bony fragments entering the canal on the CT. So as you can see here, I did a right-sided approach. I'm a left-handed surgeon, so I prefer the right side. But also, technical consideration here, the right side of the patient was a lot more spacious than the left because as you can see, the collapse is on the left side. The L2 is being lysed by the infection, and the right side had a cleaner area, so I decided to approach it from the right side. Okay, this is the patient the day after I removed the drain. Patient's symptoms basically started resolving from that point on. Okay, I'll go back to that patient later. Next patient, a middle-aged man, businessman. Now this guy can afford, luckily. He saw me basically 3 months after he was diagnosed with Pott's disease, but he was already having symptoms for 6 months. His main complaint is mechanical back pain. But when he started having neurologic pain, that's the time that he was referred to a neurologist, got an MRI scan, and was eventually 3 months later referred to me. So I saw him 6 months in. This was his MRI scan, lytic lesion of the L5. And this is his CT scan showing the same lytic lesion. You can see a significant collapse of the L5 vertebra. Okay, not so much of a listhesis on his part. So his main problem was he couldn't really bear walking because it was very painful. This is the operative technique. I did this in a private hospital, so we had a better endoscopy equipment. I was able to record it. So basic ULBD, detachment of the ligamentum flavum, also did a bit of decompression on the contralateral side. At this time, I was already trying out the no K-punch approach. Thank you, Dr. Pao, for that. And so basically, I was able to do this no K-punch for the phlebectomy. So one note here, what I wanted to show here was if you go at the epidural space, and this is an inflammatory process, there are a lot of adhesions and a lot of bleeders. And actually, a large amount of time when I was doing this was spent on how to dissect that area before I attempted to even remove the ligamentum flavum. So you have to like cauterize, you have to tease out, let the water dissect, and then bring in your freer or curette. This is contralateral side. The ligamentum flavum is on top. It's still intact. Ligamentum flavum. Ligamentum flavum. So I'm basically doing the over-the-top maneuver. And then eventually, when I was confident enough that it was free, I pulled it out and managed to deliver the flavum shredded as it is. The beauty of having done this was that you can see the dural sac expanding. So at least I'm happy that, okay, I have good decompression for this patient. Okay, next day, remove the drain. And then I made the patient walk. I added the fixation, of course. Since the patient could afford fixation, I said, let's go for the fixation so that your instability is treated. He managed to be able to walk the next day, minimal pain. And later on, I'll show you, I'm going to make him bend forward because he couldn't do that preoperatively. And when I asked him to do it this time, is there still pain? He said, no more pain. I can bend forward. So we were both happy with the result of this patient. No added grafts or anything, just the hardware for fusion. Okay. So just comparing them side by side, this is the teenage patient done in a government hospital. Just decompression, no fusion. This is the second patient with your fusion hardware. 1 month after the surgery of the teenage patient, he started developing radiculopathy symptoms on the L4, L5, S1 dermatomes. So I really convinced them, you really have to go to the next province and go to this faraway hospital to get an MRI scan. That was one of the main limitations. They couldn't do that initially. So he gets the MRI scan. I basically inspect the ULBD site. It's okay. But lo and behold, on the lower lumbar area, you have abscesses. So I was not able to pick that up on the CT scan initially. But he's there already. I said, okay, I'll readmit you. And then I end up doing an ultrasound-guided aspiration of the abscess, clear it out, send some for specimen. His symptoms actually start resolving when I evacuated the abscess. So right now, they're both undergoing medical treatment, continuing medical treatment for the TB. And they're doing much better. So a few insights, I'm about to close. Of course, our goal is save the neurologic status of the patient, save neurologic tissue, stabilize whatever can be stabilized if they're manifesting with mechanical pain. And if you can contribute to controlling the infection by doing a debridement, do that. Traditionally, we did the debridement by open approaches where we would take out lots of bone, lots of abscess, lots of caseated material. But with the change in thinking, maybe we can do minimally invasive surgery, evacuate what we can, don't touch the rest of it, and keep stability, keep the integrity of soft tissue. Okay, as much as possible, don't add to the morbidity or instability of the patient. Okay. If fixation is possible for your patient, thankfully, you can still avoid doing a big surgery, an open surgery, and go percutaneous or endoscopic. But in some cases, like in my practice, if fixation is not possible for whatever reason, then I try to decompress and still preserve as much of the stability as much as possible. Luckily, there were no bony fragments that I needed to go after. But should there have been bony fragments or if the kyphosis was really bad, ideally you do fixation. This is still a dilemma where I'm from because not all patients, even with that need, not all patients will be able to afford the fixation. Expect a lot of bleeding and a lot of adhesions being inflammatory. The dissection is so different than when you do degenerative ULBD or degenerative cases of spine because, of course, the epidural soft tissue, the small vessels, they are all engorged, are all screaming at you when you come in. Okay, some of my references, I can share them with you after that. So basically, the time to move from our older open techniques to newer techniques of endoscopy is now. Thank you very much, Dr. Pestonji, again for inviting me. And I hope you enjoyed the presentation.
Thank you, Dr. Henry. I'll call upon the next speaker, Dr. Abdul Hadar. He will be talking on challenges and complications in unilateral biportal endoscopy. I think meanwhile, if they are setting up, we can have few questions on. Till they're setting up. Yes. Dr. Pau.
Yeah, that's a difficult to tell you how much to remove, but you can. The endpoint is to check the lateral recess free from any stenosis, because the dural tear is under water pressure, so the decompression effect is overestimated. So you should do more space for the bilateral lateral recess, and you should see the nerve root clearly decompressed. Then that's the end point.
So it's the lateral margin of the root, traversing root. If we see, that's the end point.
Yeah.
Okay. Or we need to feel the pedicle. There is no need to feel.
Yeah, if you feel the pedicle, that's even better. Okay. Especially the contralateral side, it is easy. But for the ipsilateral side, you should use the nerve hook.
And sir, your set of osteotomes are available here, or where to order?
It's very easy. You can make it.
Okay. Thank you.
It's just a curve.
Sir. Dr. Pau.
Dr. Pau. One more question, I think.
You told about the no punch technique. Yes. The punches are causing the dural tear. That is one of the concept you have said. Whether the depth appreciation with the endoscopy, because it's a 2D image, that is also one of the factor while using the Kerrison punch, which leads to dural tear or puncture, or only it is the Kerrison punch. Got my point?
Not really.
In endoscopy, we are using a 2D image.
Yes.
There is no depth perception. Surgeon has to learn how to appreciate the depth in that 2D image. Correct?
Yeah.
When we are using Kerrison punch in microscope, we have depth appreciation.
Yes.
Here there is no depth appreciation. So along with the Kerrison punch, the appreciation of the depth, which is not there, you have to imagine tip of the Kerrison punch, the lamina, and so many structures, and then you have to appreciate the depth. Whether that 2D image where there is no depth appreciation is one of the reasons for the dural punctures with the use of Kerrison punch.
Yeah. When the 2D image or loss of the tactile sensation is the most important, I think. So you have a learning curve.
Yes.
You have learning curve. So that is not easy for a novice surgeon to do the no punch decompression technique. It's not easy. And also for the neurosurgeon, they are not familiar with the use of the chisel or osteotome. But for our orthopedic surgeon, we are very familiar with the chisel and osteotome. So the learning curve for the orthopedic surgeon may be a little bit shorter. But for the 3D tactile sensation, you need a very long learning curve. And I think because we use osteotome, not directly into the epidural space, it is outside of the epidural space. So it is safer. It is safer, even if you don't have the 3D
No, I'm just trying to shift that 100% the Kerrison punch is not the culprit. The depth appreciation which is not there in the 2D is also one of the culprit. This is what I'm trying to explain you. Because I am using 3D endoscope, where there is a depth
You're
appreciation.
using the 3D endoscope.
Since 2017, I'm using 3D endoscope. Your surgery becomes fast, it is a depth appreciation, just like microscope. It is mobile microscope.
Yes, thank you.
2D versus 3D. A guy who has learned depth perception on 2D, there is no need that he has to upgrade to 3D to have that depth perception. But a guy who is just starting endoscopy and straightway started 3D, for that, that is the advantage. But a guy who has learned endoscopy or arthroscopy or 2D, it doesn't really make a difference. I have tried both. I think I'm more comfortable with 2D.
The company sent me samples to try the 3D endoscope. I can see any differences as compared to the 2D for me. But for my students, for my fellow, I said there's a huge difference. You know?
Okay. Thank you.
Generation gap.
Sorry,
Let us continue.
I think
please,
the problem has been fixed.
Shouldn't please speak.
Dr. Pao, just I want to tell my colleagues. I have my friend to endoscopic surgeon, and he has one case nerve damage after osteotomy. So if surgeon thinks to use osteotomy, they should do very carefully, because you told us as neurosurgeon not familiar to use osteotomy, so be careful.
Yes. Every instrument has risk.
Yeah,
you should remember that every surgical instrument. My point is, if you use the osteotome to do the osteotome or remove the ligament from the peripheral, it's better than from the central slit. I think that's the point.
Yeah.
Not the osteotome. No, it's just the instrument.
Okay, I think we can continue with Dr. Abdul.
Thank you. Plus, thank you to Dr. Malcolm for the invite us to make a lecture about challenge and complication in unilateral biportal endoscopic. It is in my experience. The recent year, biportal endoscopic surgery has gained popularity now, and an advantage of the unilateral biportal endoscopic technique is can employ various types of conventional instruments like curettes, Kerrison punch, osteotome, high-speed drill, and conventional forceps. The learning curve of this technique, the relatively shorter than uniportal full endoscopic surgery, with another advantage of UBE techniques. I searched about the complication of UBA in many journals. So like you look in here, there's so many complications of the unilateral biportal endoscopic. But I make a red box in the 3 and 5. It is incomplete decompression and instability. The complication is higher in the early learning curve. Yeah. And the second journal said that the efficacy complication in UBA, and he said that epidural hematome, nerve root injury, inadequate decompression, and post-operative. We can see in here there was inadequate decompression too in this journal. The other journal said that 1.29% inadequate decompression too, and less than 1% transient nerve root injury, infection, and iatrogenic instability. So the last journal that I read, that indication and contraindication, we can see in here that incomplete decompression and post-operative instability still are there in here in this journal. So that's why my topic is complication, challenge and complication in make the UBA. The complication, I think, we make much balance. Inadequate decompression, in the other hand, because our window, maybe window or our technique to decompress, and instability if we have a wide window to make the decompress. So we must balance. Learning curve that the journal said before, we must try from the lumbar disc herniation, lumbar canal stenosis, lumbar foraminal stenosis, thoracic disc herniation, thoracic canal stenosis, cervical disc herniation, cervical canal stenosis, and then we can go to the fusion after this. And then how to avoid complication in adequate decompression in lumbar canal stenosis. First, we must know about the anatomy of the ligamentum flavum. That in the degenerative process, this is the point. How to remove the ligamentum flavum. When one journal said it is the ligamentum flavum anatomy in lumbar canal stenosis, we can look in here that not only the central of the ligamentum flavum thickness, but we can see in here in the recess area or in the foraminal area was thickening too. So in the lumbar canal stenosis, if we just decompress in the central or recess area, I think is inadequate decompression will be happen in our patient. Like you can look in the slide before, the ligamentum flavum from L4, L5. The ligamentum flavum not in the L5, but in the L4 foramen. So we must make the compressed area too. It is. The inner of ligamentum flavum distribution and interlaminar window contour are critical anatomical structure in the interlaminar endoscopic lumbar surgery. We found change in future correlated with age and level endoscopic decompression. The present study result might have the endoscopic surgeon decided endoscopic docking. So the bone drilling and medial facet part and approach angle contralateral foraminotomy. So how to remove the ligamentum flavum? So many techniques like Dr. Pao said before. It is my technique. I think, yeah, not different. It is my technique after we perform the bone window enough in the upper edge of the ligamentum flavum. Don't forget to go to the foraminal area in this level. So using the root dissector, we can separate bone and ligamentum flavum very easily. And I using piecemeal technique. I didn't use an en bloc technique to remove the ligamentum flavum to know in which to not make the lot of the bone window, so stability is still good in our patient. In open surgery, in very easy to decompress and removal ligamentum flavum clearly, like this video. Yeah. It is my patient, 58 years old, lumbar canal stenosis L4-5. I performed it in 2017, before I know about endoscopic. In this case, you can look in here, the patient was already decompressed because I performed stabilization in here. So we can look in here, the exiting root L4. Yeah. Yes. And we can see exiting root L4, transferring root L4, L5, and transferring L5 and exiting L4 in the ipsi then contralateral. It is the good decompression that we want in our endoscopic decompression. Okay. So knowing about the second step is knowing about principal endoscopic decompression surgery interlaminar procedure. Yeah, we have many procedure steps. First is dissection muscle superficially, remove lamina insertion ligamentum flavum. Don't forget to preserve the interarticularis, and then exiting node root decompression after that. Yeah, and then descending nerve root decompression, and then lateral recess decompression. And after that, you must make sure that this herniation is need to discectomy or not. It is the example that I usually perform before in 2019. In that time, I didn't release. I just performed the transferring route. We can look in here. It is the final result. The final result, we concern only the transferring route. Yeah, not concern in the exiting route. The patient still have pain after that. And then it is the other case, female 59 years old lumbar canal stenosis, right side radiculopathy, neurogenic claudication. We can look in here, in L4-5 lumbar canal stenosis, we can look the foraminal in the L4, L5, and L4, L5 already narrowing too. So that's why we must decompress too. Tip and trick to prevent adequate decompression and prevent instability. First, which side we enter perform decompression, we must think about this because not all patient is in the good strike like this. We can look in here, it is the midline, but not like this, but it is the midline. So if we enter from this side, we'll make more larger of facet removal. So it may be unstable. If we go from this side, I think it will be much stable for this patient. We must think about facet tropism like this. If we enter from this side, I think a good idea. But if we go from this side, the facet were more vertical like this, we make unstable in our patient. So the second step is how much bone window you need to get adequate decompression. Yeah, we can look in here. Yeah, after bone drilling, not only central stenosis but recess and foraminal stenosis we must remove. Removal of the contralateral, yeah, contralateral side until we got exiting root, and then you can look in the second video. It is the exiting root that we already decompress. Yeah. Exiting root, and we can look to the transferring root in the contralateral side. We can easily to remove and we decompress, yeah, yeah. And then we can look in in the second video. We can easy to ipsilateral side of the transferring root, but we cannot find the ipsilateral of the ipsilateral in the exiting root. It is the problem in the biportal endoscopics. So like this, we cannot perform more larger window in the ipsilateral because it make unstable. Like in here, it is that video that I performed. It is the transferring root, exiting root. It is the transferring root. It is the transferring root, and then it is the ipsilateral exiting root we cannot find because it's not like this open surgery. So I think any difficulty to perform the ipsilateral exiting root decompression, so we must make many surgeons using the curve of the curette or curve of the Carrison. Maybe it's more make decompress, but not we can not see too. Okay. And then, so the complication in adequate decompression and instability. Lumbar kinesis, I think we go to the other side. Chronic lumbar instability is mechanical lumbar instability, yes. Then it is the point, X-ray, the most widely used method, diagnosis instability. So if you perform the decompression in your patient, so please, you must check send this diagnosis of instability. Vacuum phenomenon, emplate sclerosis, traction osteophyte, claw osteophyte, disc degradation, facetal osteoarthritis. So you must know that many of these signs is unstable in our patient. Several risk factors, obesity, osteoporosis, severe stenosis, de novo, routinely corticosteroid, many kindness like kidney failure, hormonal problem is the problem too. So take home message is there is 3 factors can make instability after endoscopic decompression. To last bone window, the must 100% understand about anatomy, flavum, and cause decompression according of MRI and CT scan. The central gravity sagittal balance is fluent special L4, L5 in highest load. So be careful in our patient, obese patient. And the other is other disease, we can make poor bone quality like osteoporosis, chronic kidney disease. Thank you.
Okay. Thank you, Dr. Abdul. Nice talk. So the house is open for questions. If anyone is having any question.
Abdul, I have only one question. He spoke so fast. Good lung power, good vital capacity. But a fantastic talk, because you put out certain very vital issues regarding decompression. Whether you over decompress, you go into the zone of instability. If you under decompress, obviously you're in the zone of an incomplete decompression. So excellently put. Thank you.
So I think I'll call upon no questions.
I think we'll proceed with the next session.
Dr. Maxim?
Yeah.
Okay, so I have one question. And Maxim, and so in your professional opinion, so how many cases do you need to overcome simple decompression with UBE surgery, in your experience?
Boss, here's the mic.
I've trained a lot of surgeons. The first thing is you do arthroscopy or not. If you are a neurosurgeon, almost of time it's more difficult. But from my point of view, you have not one learning curve in UB, you have 5, 6 learning curve. You have one learning curve for disc herniation, one learning curve for stenosis, one learning curve for fusions. I think to do a stenosis, you need to do 20, 30 cases. But it depends of if you know arthroscopy or not.
If I can answer for Maxim, I'm still learning, sir. I'm still learning. Endoscopy throws surprises every time. So the learning never stops.
Dr. Masato?
We'll start with our next session. Yeah, you have a question for Dr. Masato.
So I'm curious, what kind of brand name of we're using navigation?
It's a stealth station, S8, the newest one, Mesonic.
Thank you so. Very nice.
It's okay? Okay.
Patient doesn't have any radiation exposure using navigation, right? Because as far as I know, before the navigation, patient should have a CT, and the CT will be brought to the navigation, right?
I'm not saying that. So patient got surgery once or twice, but the surgeon, there are a lot of surgery, sometimes more than 200 times in a year. So radiation dose for O-arm and C-arm is, if you use O-arm, 4 times higher than C-arm. But as I said, just 20 seconds. But C-arm, according to the report, sometimes you use more than 1 minute. So this is the same amount. And for the surgeon, we are always escape from the operation room, no radiation for the operating staff. That's a big difference. Thank you.
Sorry, just I wonder.
Sajot, please wait patiently for the questions to get over.
How long does it take? Yes. Just I wonder, how long does it take with navigation system, this UB surgery? How long?
It's surgical time?
Yes, surgical time.
It's about 1 hour.
1 hour.
1 hour.
Mm-hmm.
It's too long. Good night.
Thank you.
Hello. Good afternoon, everyone. I'll be presenting few cases on spondylolisthesis, which is our session right now, and then we'll look ahead and see from our other 2 lectures that how to proceed about it. So case 1 is the first case, which is a 68-year-old male. He's got low back pain since 1 year. He's got bilateral lower limb radiculopathy. He's got claudication distance of 5 minutes. His activity of daily living is severely affected, but he has got no neuro deficit. We went on and did an X-ray for this patient. We saw in an flexion and extension X-ray, we saw that the patient has L4, L5 listhesis on extension and flexion, which is Also, this instability can be seen in the dynamic X-ray. We went on and saw ahead that a patient MRI was done. Patient MRI also saw L4, L5 canal stenosis with listhesis on both the sagittal and axial cuts. So we'll see what treatment options we have, because patient had already done a conservative trial, medications, exercise, everything was tried. And for surgical options, what options we have? Do we have only decompression as an option, endoscopic or open or tubular, or with decompression we have fusion? With fusion also we have a lot of options. Going ahead with case number 2, we have a 62-year-old male with low back pain since 1 year. He's got back pain which is more troubling him than leg pain. He again has claudication and distance of 10 to 15 minutes of walking. His activity of daily living is again affected. Let's go and see what his X-ray says. So on an X-ray of a dynamic X-ray, we see in the L4 and L5, there is some translation and angulatory changes in the X-ray. We went and did an MRI. The MRI of this patient shows bilateral foraminal narrowing, and also we see some facetal arthritis also in this case, and also in a sagittal cut. In such cases where we have more back pain and less of leg pain with such picture of arthritis and a dynamic X-ray, again we have this dilemma of only to decompress or do a fusion with it, and when fusion, what kind of fusion, with interbody or without interbody. With this, we come to the third case, which is a 56-year-old female who's got a bilateral lower limb radicular pain. Her left lower limb pain is more than the right lower limb pain. She's got more of leg pain. Her back pain is not troubling her, but leg pain is more. She's got claudication and walking distance of 10 minutes. So in this case, we did an X-ray which shows a subtle listhesis grade 1 L4-5, which we saw on flexion and extension X-rays, which is not, it looks like a stable, it does not have a translation. MRI again shows a canal stenosis with such facets and this sagittal and axial image. In such cases with stable listhesis of grade 1, only more of a leg pain. What dilemma we have? Can we only decompress this patient? And with decompress, if we decide to fuse, what kind of fusion to be done? So let's find out with this when to fuse, when not to fuse, and when to use an interbody. I would like to call our next speaker for this. Thank you so much.
I think I will introduce to you Dr. Arvind Kulkarni. Most of you all know him. He is India's most prolific spine surgeon, and he's a beacon of light as far as minimally invasive spine surgery, tubular spine surgery goes. And it's a privilege and honor to have you here, sir. Thank you.
So that was the Super Bowl. So thank you very much for inviting me. So that is the beauty of degenerative spondylolisthesis. It is one particular pathology, one singular pathology in spine which can elicit various responses. It is totally heterogeneous. All three cases that Sayajit showed are totally different, and you need different weapons for these three cases. And it needs a lot of thinking. So this particular condition of degenerative spondylosis arouses a lot of controversy, a lot of heat and debate in every meeting that where this particular topic comes up. We have had a very hot and ferocious election season in the last 1 month, and similarly we have this basically two polarized groups fighting against one another, whether you should fuse these cases all the time or we can just get away with decompression. So there are soldiers, there are armies on both sides. The reason being we don't have any guidelines. So some time back, we tried to factor in all this and come to a particular scoring system. So this particular condition, as I said, it's a unique condition that can present in very different ways. So the age of presentation could be different. The activity level of the person may be different. That would come in in decision making. That has to be considered in decision making. Some patients have back pain, some don't have. Some have leg pain, some don't have. Some have a combination of both. Again, the radiological factors are totally different. You can have a listhesis which is absolutely stable in flexion extension, supine standing. You can have a facet orientation is totally, protective, defensive in terms of a coronal facet. It could be a pure sagittal facet. There would be effusion in the facet joints. And again, the disc height makes a big contribution to decision making. Again, the morphology of these patients, the anatomy of these patients may be totally different in terms of feasibility of just doing a decompression, or whether you're forced to do a fusion just considering the morphometry of the anatomical structures. So when we compare one degenerative listhesis with another, so if you compare two cases which Saijit showed just now, it's like comparing oranges versus apples, and that is what is happening in the literature till about 15-20 years back. So all cases of degenerative spondylolisthesis were considered in one basket. So to solve this particular problem, we came out with this particular scoring system. It's not that just one day we sat down and came out with this mathematics. This template basically consists of clinical factors, radiological factors, and technical factors. So it is a result of a longitudinal study where in the first few years, we got back. So when I started my practice, I followed a middle path regime when it came to degenerative spondylolisthesis management. So I would fuse a few cases, I would decompress a few cases, but I never had a formula. So there were a set of features I would think of and put them together in my mind, and I would go ahead with the procedure I wanted to do. Till we reached a point wherein we thought we should make a scoring system. We should have some algorithm to to decide how and why we do this. So the jigsaw puzzle we could solve. So we came out with a particular scoring system and a score number, which came out of a retrospective study, as I said, and then we applied it to the next following years, next 2 to 3 years, to see how it works. And in both the situations, it worked very well, with only about 2 to 3% of them coming back for fusion as a result of progressive instability following decompression. So that is, in short, the story. So these are all the factors that we took into consideration. These are clinical factors. So the presence of mechanical pain, a young age, less than 70, high activity level, angulation, more of angulation than translation. That means it's an empty disc, a sagittal facet, a situation where there is facet effusion. So these all scored higher. On the opposite side were situations where there was coronal facet, no effusion, a short disc, a collapsed disc which has less potential to slip. Again, feasibility, here you have very small facets. So in such a situation, if you want to decompress, you'll probably have to go to midline. Otherwise, one bite of your kerison, the facet, inferior facet will come in your hand. So in such a situation, when you cut the midline structures, you already lost 33% of stability in flexion extension. So that adds significantly to your instability. So the magic figure that we came to was 5.5. And this we applied in the next series of patients, and we got very good outcomes. So this particular technique is not something new. This is just reignited by us in various platforms and podia in terms of textbooks, presentations, etc. So it is, unlike UB, it is a uniportal. I'm not arguing it. So it's just through one port that you decompress ipsilateral and contralateral sides. This was the mother of invention of all other techniques that followed this in terms of minimal access pathway. And I still follow this because I am absolutely comfortable and confident about this particular technique, having been doing this for last 17 years, and I can do 2 levels, 3 levels, 4 levels. So this is one of the cases. We can see there's a pre-op stenosis. It's very well decompressed. There's hardly any sign of soft tissue or bony trauma. Just this particular tract through which this severe stenosis was decompressed. Not only was it decompressed, the integrity of the facet joint complex on both sides is very well preserved. So going from which side is very, very important. I just witnessed in one of the presentations in the last session. So this is very, very important. You need to take a lot of factors. I'll not go through this table. It is published in Spine. You need to go to a lot of factors before deciding which side you're going to embark in order to insert your tube in. Most of the time it is opposite side to the side of maximum decompression. It's not universal. This is to maintain stability of both sides. So if I would go on the pathological side, I would eat up more of the facet joint. So I would go from the contralateral side. This way I would maintain the stability of both sides. This is the philosophy that most of us follow. Again, the facet which is, which facet, if there is facet tropism, whether you go from the coronal side or sagittal side, this is stable, and if you go from this side, you don't want to destabilize it. So you go from the sagittal side itself so that this, this maintains the stability later on. Again, go from the opposite side. If you can have situations where there is a spinous process coming in the way, so don't break it to maintain midline stability. Again, this is just a comparison of a wide canal versus a narrow canal, comparing L4-5 versus L5-S1. Most important issue is the docking. So we are always criticized by the open surgeons that when you insert the tube or a scope, we keep terrorizing the soft tissue, but there is a way to it. So one is, don't dock superficially. If you dock it superficially, you're going to kill the muscles. You need to take multiple incisions, keep going, dilating the soft tissue all the way. You can come and witness in my OT. Till we reach the bone, there's hardly any soft tissue that is damaged. So keep going in with dilators again and again, again and again, again and again, till you reach bone. So again, coming back to listhesis. So, a patient comes like this, just has an X-ray. You put up the X-ray in your clinic, your mouth starts watering. All you can think of is, screws, cages, and rods. But that is not the way we surgeons think. We are, holistic surgeons. We need to analyze the patient in 360 degrees, clinical, radiological, and within radiological, different types of radiology. So if this patient, after seeing this stable listhesis in flexion extension, you look at this joint, it is a fortress. All that you need to remove is this particular V here, which can be easily done without, destabilizing this particular patient. If you really score this patient, it's very far away from the benchmark. Again, it applies for situations where you need to fuse. So this is very high. So, significant mobility in flexion extension, facet effusion, sagittal facets, young patient, back pain. So it scores beyond 5.5. So the issue of degenerative listhesis as a diagnosis and management comes with history. So all patients with stenotic complaints were put in the same basket as lumbar canal stenosis. There was myelogram which was done, and everyone underwent a decompression laminectomy procedure. It was very, very, so there was a Christmas was celebrated on every patient with stenosis. So this is called Christmas tree surgery. And none of these patients got out of the bed. Because of disability. And then came this landmark paper where Herkovich suggested that we should fuse all these patients. This won a Volvo award in Issels. Then they started getting good results, and he was like a Pied Piper. Everyone followed him. Then came the boom of pedicle screw, and once implants hit the market, there is no one to stop you. So fusion became a universal concept for for degenerative listhesis. But again, now if you really sit down and think, we now know that it is a homogeneous entity. You don't have to put screws and rods in every patient. So we should, as I said, as it is heterogeneous, we should customize treatment for each individual patient. Of course, some of them might progress to instability later on in their life, but the percentage is not very high. Again, if I do a flexion extension of all of you sitting here, about 42% of you may be having some degree of mild listhesis. So that doesn't mean, I catch hold of you and keep putting screws. As we know, when you compare it with lytic listhesis, these hardly progress. Degenerative listhesis, you hardly go beyond grade 1, and majority of times, because of the pathology itself, it's a micro instability. It restabilizes, osteophytes form, the disc becomes hard, the annulus becomes tight, so they restabilize. And radiological progression, many a times in your clinic, you will see, the significant oof. You sigh at the image, but the patient is absolutely asymptomatic. So only 85 to 90% of, only 10 to 15% of these patients come to a clinic. Actually, rest of them are all stable. They're saved. And again, you see, when you see the old papers, there's nothing mentioned about minimal access decompression. Now we have data pulling up where it says that because of the intrinsic stability provided by minimal access surgeries, the rate of progression is very slow. It's about 2.6%. And the incidence of a second surgery, the requirement of second surgery is just less than 1%. And if you can't just compare the cost of a TLIF versus a decompression. It's huge, especially in Western countries, it's huge. Again, we shouldn't forget that as we age, as you enter the third stage of Kirkcaldy-Willis, our discs become hard, the annulus becomes tight, the annulus can become calcified. It gives abundant stability to the segment, and that is the time degenerative listhesis usually knocks the door. And so this disc itself gives intrinsic stability. So we don't need to really fuse all these cases. And this one, paper published long back, maybe about 10 years back, where we showed that you don't need to fuse all cases of synovial cysts. And out of these 30 patients, 8 of them had degenerative listhesis, where we just went ahead and did a decompression. So this is a case illustration of a lady with degenerative listhesis, an obese lady. This X-rays in 2019. So she had this listhesis with stenosis at L4-5. Look at the coronal arrangement of her facets. It's like a fortress. So we just did a tubular decompression. This is 4 years later. She's absolutely stable. There's hardly any pain. So this is a post-op MRI. You can see the difference in the degree of stenosis pre-op and post-op. Then another patient, so if that was mild listhesis, this is quite severe listhesis, young patient with multiple comorbidities. So he just had a unilateral leg pain on one side, coronal facets, stable listhesis, a score which is 5.5, a 5 which is very close to the benchmark. He's doing extremely well. I mean, he just operated on one of his relatives 2 weeks back. So 20 plus another 4, 24. So he's about 8 years follow-up now with me. Absolutely comfortable. And this is the longest follow-up that I have done long back, must be 15 years now. And this fellow refuses to do any kind of investigation, though I request him. He's absolutely pain-free. Just did a decompression in this particular patient. So our paper has been highlighted. The same template has been applied by this NAS, which came out with a similar scoring system, and we have been quoted at least 3 or 4 times in this particular paper. The template of features that were taken, they're similar to what we have chosen. Again, a recent review in European Spine Journal gave a good amount of credit to our scoring system. And it says it is the most comprehensive scoring system, includes all factors that need to be considered. Why do we do this technique? Because it is stable technique, it maintains the stability, it maintains the posterior tension band, it maintains the soft tissue integrity of the opposite side. So current literature fails to systematically subclassify degenerative listhesis. It is a heterogeneous condition. You need to tailor-make surgeries, procedures for each patient. You should personalize the treatment. And again, just like fusion, decompression has a central place in management of degenerative listhesis. Thank you.
Questions?
Yes, I totally agree with you. Your very good presentation. To you, which is the most important point that you will decide, help you decide fuse or not fuse for us degenerative spondylolisthesis? Which point is the most important in your opinion?
I've done all this, a combination of everything. I use a combination of all this, but most important it is the facet anatomy.
Facet anatomy? In my opinion, I will think the patient's symptom is the most important. If the patient had no low back pain at all, even he has unstable spondylolisthesis on the X-ray, for severe facet hypertrophy or facet arthrosis, if the patient has no low back pain, I will not fuse the patient. How about your opinion?
Yeah, similar. But I take into consideration all these factors. So I've seen patients who had no back pain also coming back with instability later on if I've exceeded a point or operated elsewhere. All other features, but they don't have back pain. They're failing later on and developing neurological symptoms. So I usually factor in everything before I decide what to do. And in my practice, the percentage of patients where a fuse is 2/3. The percentage of patients where I decompress is 1/3. So still the majority is fusion.
The first thing, when you do a fusion, the patient will be evaporate in 37. When you do fusions, the patient will have new surgery 36% during slide. If you make TELIF, 1/3 of patients will have new surgery in 2, 3, 4 years. So I will agree with you. When you think to do fusion, you must be clear about it.
Yeah. So you're talking about adjacent segment degeneration, right?
The second thing that when we see now the literature, last 5 years, literature says that we don't need to fuse degenerative spondy. We have New England Journal of Medicine, we have big impact factor journals saying now that we don't need to fuse this kind of patients. I think when you operate this kind of patients, you need to see him, you will be reoperated in 36%.
Yeah, so the chances of reoperating on a patient where you decompress alone, that's what you're asking, right?
No, when you fuse a patient, when you fuse it, you fuse him, you will have new surgery, PGK.
ASD you're talking about, adjacent segment degeneration.
The other thing, when you, degenerative spondy, do you think it's adaptation of patient of sagittal balance? A lot of surgeons think that degenerative spondy is adaptation of...
Yeah, so as I said, the degree of listhesis here is hardly 1 grade, That will not account to your sagittal imbalance.
We don't have 3-4 degenerative spondy, but when you fuse a patient, you have high grade of PGK on this kind of patient. It's why
so the PGK, the incidence of PGK and ASD, in my experience, is overrated. It's not my patients. In my practice, in a year, I may be doing about 3 or 4 surgeries for ASD, not more than that. Not more than 3 or 4 extension of fusions in my entire year. So I think it is overrated.
One question. This classification is going to help you whether you want to do fusion or decompression. Whether this classification is going to help the patient also when he wants to choose whether to fuse or decompress. Because nowadays patients are demanding whether they want to get a fusion.
Yeah, so the kind of counseling that we do in such cases, it's huge. My counseling for scoliosis may be about 5 minutes. I'm just
single
5
level
minutes.
decompression fusion, no scoliosis.
No, the patient. My counseling for adolescent idiopathic scoliosis may only last for 5 minutes, but for conditions like this, it might go on for half an hour.
So whether this helps the patients also.
Yeah. So as long as they can comprehend and understand. So it also gives them I never tell them a 100% successful surgeon. I tell them nor the procedure is. I tell them there is a certain percentage of patients who will come back with instability, and at that point of time you need. See, we should not forget that a large percent of these patients are elderly, and they come with a baggage of comorbidities. They are very bad. They're obese, they have diabetes, they have end-stage renal conditions, they have multiple drug allergies, and you need to take all these into
Arvind, here I 100% agree with you. One has to take a call on deciding which patient where to cut off.
Correct.
Sometimes with these kind of comorbidities and other problems, even I choose a decompression, a very rapid surgery in and out of the theater, And I warn them that if you progress over 2, 3 years, 5 years, you are going to need a fixation. You need good monitoring of these patients. So sometimes you need to take a borderline call on both sides.
One more
Thoroughly
thing,
agree with
I'll
that.
take another minute. So this is regards to the back pain component here. It has to be mechanical back pain. Two things. One is if the patient complains of diffuse back pain, that is very important. You need to evaluate well. They have back pain as a result of various causes, osteoporosis, sarcopenia, they have the entire back, tilted. So back pain, which is extending all the way from, including of neck, inclusive of neck pain, pain everywhere. This is not mechanical back pain. Don't promise the patient that he'll get better with fusion. This pain everywhere. It has to be typically mechanical back pain. One. Second is, don't confuse buttock pain for back pain. Buttock pain is radicular pain. So when they say back pain, when you take this scoring into consideration, don't consider buttock pain as back pain. Many of them, they say buttock pain, and with decompression, the buttock pain goes away. Don't factor in as a contributor for your scoring to help you fuse, to aid you fuse. Conservative. So the ones who are scared of surgery, the ones who come initially with symptoms, a very short duration, the ones who don't have a neurological deficit, which is very unusual. So these are the patients.
Perfect, perfect, sir. Thank you.
So the second last lecture of the session number 5, Dr. Ketan Badani, interbody or not interbody.
Good afternoon,
May
everybody.
I call Dr. Cyril to come on the first row.
So the
We'll
debate
shift
is
the session number 6 post lunch. Session number 6 will shift post lunch. Dr. Ketan, please carry on. Thank you.
so the discussion and debate is going on about the need or no need for fusion in lumbar canal stenosis surgery. So we are trying to identify those patients who need fusion, who don't need fusion, and Dr. Arvind Kulkarni rightly demonstrated which patients can do without fusion and who need fusion. So let's say if the patient needs fusion, then what kind of fusion should we offer to that patient? This is in addition, of course, to the actual direct decompression. Now, in this Kirkcaldy-Willis cascade, the instability component is the dynamic component of stenosis. It has to be very well understood that it is a dynamic component and there is a static component and this is a dynamic component. You can have a sagittal plane instability in the form of displacement, angulation, retrolisthesis, or you can have a coronal plane instability form of a lateral tilting, which is a harbinger of future scoliosis or a lateral listhesis. Instability can be in a single plane like an anterolisthesis or retrolisthesis or a lateral tilt. You could have a multi-level instability in different forms, and the grandfather of all this is the multi-level instability leading to a scoliosis. So as we are hotly discussing which patient to select for stenosis, so the clinical suspicion is very important. The clinical sign and symptoms that change of motion, change of position and morning pain are one of the two important symptoms that we should look for. Obvious radiological signs. A routine which I follow is to take a standing AP view and lateral flexion extension view. The purpose of the standing view is it will detect any scoliotic or a coronal plane instability, whereas the lateral flexion extension not only detects the instability at the index level, but it tells you about additional levels. So that can affect your decision to whether to fuse or not. Subtle signs like facet effusion or a facet cyst can be harbingers of instability. So while doing surgery, what we need to do is the stable segments need to undergo a non-destabilizing decompression along with stabilization to enhance fusion rates and to correct the deformity, if any, and a fusion to give lifelong biological stability. Now, how many levels to fuse? In a uniplanar instability, all the unstable levels I fuse normally. But in a scoliosis or a multiplanar, I choose depending on the situation or how much decompression I am doing. The choices of fusion are posterior lateral fusion and interbody fusion, or a combination of these fusions depending on the situation. So there are some important considerations that in degenerative spondylolisthesis, the disc height is usually reduced and it gives a good amount of stability to the situation. The slip grade is low. In the elderly, the demand on the spine is low, and you have to keep in mind that these patients are going to have various degrees of osteoporosis. So you could do a posterior lateral fusion or an interbody fusion. In the interbody fusion, the advantage is you can do distraction of the disc space for placement of graft, and that gives some foraminal enlargement. Whereas the posterior lateral fusion is a simple technique where there is not much time consumption. You decorticate the transverse processes and put in graft and do a facetal fusion. Whereas an interbody fusion will require more time, more blood loss, transgressing the spinal canal, and risk of neural injury. Which is superior? You know, posterior lateral apparently appears to be superior because it is in the weight-bearing axis. It has compressive forces helping it to fuse. It gives some distraction, which enlarges the foramen. These are not available in the posterior lateral fusion, but do these advantages of interbody translate into better results? If you look at across studies in literature, on the clinical front, there is not much difference between posterior lateral and interbody fusion, and only one of the studies showed superior results with interbody. On the radiological front, fusion rates are no different. Only few studies show higher fusion rate in the posterior lateral fusion, most of the in the interbody fusion, whereas most of the studies show that the fusion rates are very much similar across both the techniques. Blood loss, time of surgery, post-op radiculitis, cost of implant, these are all higher in the interbody group. Reoperation rates also are higher at a 8-year follow-up compared to interbody. The posterior lateral fusion had 6% and interbody has almost more than 5 times the reoperation rates. There is a risk of cage subsidence migration in the interbody group due to low BMD. There is a high rate of cage migration, cage retropulsion as showed in literature. There is an interesting study. We studied the fusion at the primary point and the facet fusion. Now you can see that whenever facet fusion had occurred, the fusion rate increased, the number of patients who fused increased. So this shows that the facet joint fusion is an important and integral component of the fusion. And if you destroy the facet as an approach for an transforaminal fusion, you are losing out on a good opportunity to get a higher fusion rate. So the overall verdict, as I showed, is in favor of the posterior lateral fusion because the clinical results are same. There are less negatives than interbody fusion, and there is a high risk benefit and cost benefit ratio in the posterior lateral group. The discectomy in interbody adds to the instability. This distraction can be avoided by doing a good foraminal decompression for the roots and try to preserve the facets, which as I showed can really add to the number of fusion. So my preference is to do a posterior lateral fusion in most of the situations, but there are some situations where I use interbody fusion, and that is if there is a lateral instability or there is a large disc prolapse with good disc height requiring discectomy. As in this case, you can see that there is a L23 lateral instability with stenosis, where I've used the interbody technique for fusion to get the correction of the tilt and the deformity. This is a case of an adjacent segment disease along with a large disc prolapse, as you can see, and a good disc height. So here I had to do a discectomy in order to do the complete decompression, and here I've used interbody fusion in order to counter the discectomy procedure. Scoliosis is a very complex situation. I'm just going to touch upon a few things. It is a chapter in itself, subject in itself. So in scoliosis, it is very difficult to determine what to do, whether to fuse, whether to not to fuse, or how much to fuse. So what I follow is that I try to decide whether the patient has more leg component or back component. And I try to see if I can define a particular route or a particular level which requires decompression, and the patient is not having much back pain. Then I do only a decompression. But if the patient has significant back pain and you need to do a fusion, in that case, the decision about the fusion depends on number of segments you need to decompress and overall sagittal and coronal imbalance. So there are 3 surgical possibilities. One is decompression alone, or decompression with limited fixation and limited fusion, limited to those levels where you are doing the decompression, or decompression with extensive fixation to correct the coronal and sagittal deformities. But you have to remember that scoliosis has been defined as a harbinger of bad results. Patients are old, ability to withstand long surgeries is questionable, bone quality is poor, fixation and hold is going to be poor, deformities are quite rigid, posing additional challenge. and there is always a possibility of proximal junctional kyphosis. So this is a case of L2 to S1 stenosis, where I have left the L5 S1 and fused up to L5 in order to reduce the stress. Here is the case of stenosis from L34 to S1, where sacrum is included in the fusion. So the take-home message is that prior to surgery for lumbar stenosis, confirm stability or identify instability by dynamic radiology, prepare for appropriate instrumentation and fusion, always keep instrumentation available in case of any iatrogenic instability intraoperatively, and evidence suggests that posterolateral fusion is preferred in degenerative spondylolisthesis. Facet fusion is an important integral part of the technique which should be very well attended to. You can see a 6-year and 8-year follow-up of a posterolateral fusion, where you can see solid bone formation in the intertransverse between the transverse processes, and a well-applied technique gives a good results as equal to an interbody fusion. Interbody fusion offers no extra benefits for the risks taken, and in special situations, yes, it is helpful and should be used. Thank you.
Dr. Tanaka. Yeah.
Hello. Any question?
Yeah.
Yeah,
Yeah.
Dr.
Meanwhile,
Tanaka.
Dr. Cyril, please join your laptop. Please help.
Yeah, Dr. Tanaka.
Thank you for your nice presentation. I am from Japan. So sometimes doctor can make evidence, but if you look at a lot of paper, interbody fusion is better than posterolateral fusion. And nowadays, I see your X-ray. So nowadays, we put a huge cage from lateral approach. And alignment is very important if you choose posterolateral fusion. Even though the fusion percent is similar, but mal-alignment. So maybe you shouldn't choose evidence on your accord. So how about that?
I know you can prove one way or the other by getting good evidence, but I have been doing this posterolateral fusion for years, and the technique is, what I am trying to say, the technique is very important. You know, adequate amount of graft, adequate amount of decortication, inclusion of facets in the fusion will give rise to a good result. And if you are having a good technique with interbody, that also will give a good result. But then if you compare the extent of surgery, in posterolateral, the time and blood loss and everything in the surgery is much less as compared to an interbody.
Yes, for your information, in Japan, nobody perform posterolateral fusion. Thank you.
Thank you.
Thank you, Dr. Badani.
Thank you.
Friends, as orthopedic surgeons and spine specialists, when you have a spine patient, you tend to spend a lot of time knowing whether this pain originates from the spine or elsewhere. And sometimes you feel that this patient requires some counseling. So for this, we need a psychiatrist, and today we have Dr. Cheryl Sentinathan, eminent psychiatrist, who will talk to us on the unraveling the body-brain connection, exploring psychiatric dimension of spine disorders. She is an eminent psychiatrist, but very human, involved in the community education at all levels, right from the schools to the elderly to the aged, and also helps in teaching the course at the Biomedical Ethics Center of Mental Health. Over to Dr. Cheryl Sentinel.
Thank you for that warm introduction, Dr. Antau. And I know that I'm the only one standing in way of you and your lunch. So I'm not going to kind of bore you with a lot of data, but it's very, very important to understand. And the title says about unraveling the brain and the body connection. And specifically why I mentioned the word brain and not the word mind as a lot of us are used to seeing, is we're not dealing in psychiatry with the mind. That's a very philosophical component. We are talking about the brain with the neurotransmitters and the neural connections, and which have an immense connection with the spine and the symptoms that your patients come up with. So I'll just talk about 35-year-old Mr. S. He had sustained a fracture over his D8, and he had retropulse fragment, focal kyphosis, and needed surgical intervention. Now, he was under treatment for bipolar mood disorder, doing very well with his medications for the last 5 years. No manic episodes, no depressive episodes. He got admitted for his surgery. He was doing very well on 1000 milligram of divalproex and 5 milligram of olanzapine. Usually what happens is when a patient with a psychiatric diagnosis comes to a surgeon or to a hospital, we are very apprehensive, and even the anesthetists are very apprehensive. Oh, let's stop all medications. Maybe they'll intervene, or they will interfere with the anesthetic medications, they'll interfere with the surgery. So the medications were stopped, and within 5 days, he had a full-blown manic episode in the hospital. Caused him to become aggressive, agitated, violent, and there was a major setback in his surgery. It prolonged his hospital stay. So just to understand, what is the summary of preoperative recommendations to stopping medications? This is a little bit older data, 2021. So that's why it mentions that lithium should be discontinued 72 hours before. But the recent data says no medications to be discontinued before surgery. So whatever is the NBM that the patient is 12 hours or 8 hours or 4 hours, depending on the intervention that you're going to do, the medications continue as usual. The only little bit controversy about lithium is because sometimes it causes ECG changes, sometimes if the patient is not hydrated enough, it can cause renal toxicity, but even that's very, very unlikely. So if your patient on any kind of medication comes to you for surgery, please do not stop the psychiatric medications. Continue that even post-surgery, because it's going to make a huge impact in the patient outcome. Your surgery may be excellent. You may have, doing whatever that you do with, but the outcome of the surgery is going to be bad because the patient is going to be agitated or restless. A lot of times it's important to ask for this history. Now, this patient with bipolar mood disorder had a very robust history with medications, but a lot of patients are on benzodiazepines. Your patient would be on alprazolam 0.25 taken for the last 15 years. We'll choose not to mention about that prior to surgery, and in the hospital post-surgery we'll go into delirium. And we are thinking about electrolyte imbalance, we're thinking about post-surgery psychosis, ICU psychosis, without understanding that 0.25 alprazolam has caused benzodiazepine withdrawal and confusion. This is 42-year-old Mrs. H. She came to her orthopedician with acute pain in her back. Detailed investigation showed nerve compression, required bed rest, given gabapentin, no relief, pregabalin and nortriptyline combination given, very mild reduction in her pain symptoms. Any suggestions what else can be given to this patient? I'm sure this is a very common feature in most of your spine OPDs. So anything else that you on a routine way give? Anti-inflammatory drugs, NSAIDs, tramadol, anything that would help in easing the pain on a little more long-term basis. Oxcarbamazepine.
Possible to call anesthesiologist.
Without surgical intervention, without palliative care. We also have to understand, I remember Dr. Kulkarni was speaking before, and he was talking about when you probably need to do your procedures, and you don't do it when there is diffuse pain or when there is pain all over the back, or even in this case, acute pain. And most of orthopedicians will call it functional pain, right? We get a lot of references that this is not organic and this is functional, so can a psychiatrist please intervene and see? There's nothing known as functional pain. The pain is very, very genuine, and it's probably because of the serotonin and norepinephrine dysregulation that's happening in the brain. It interferes with the inhibitory noradrenaline pathway. So that's why patients with vague symptoms, unexplained, headache, the entire back's hurting, or even in that previous case, acute pain. Usually what you give is amitriptyline or tryptomer. There is a lot of data now and a lot of recent advances. And what you could try as orthopedicians is duloxetine and desvenlafaxine. These are SNRIs, lesser side effects as compared to tricyclides. So you're not concerned about conduction issues with ECG, you're not concerned about urinary retention in your elderly patients, you're not concerned about dry mouth. As compared to SSRIs, a lot of times you give escitalopram or fluoxetine. It really doesn't help in pain because the pain pathway that's usually impacted is a noradrenaline, norepinephrine pathway. So when you give a serotonin norepinephrine reuptake inhibitor, it really brings about a lot of change without unnecessary side effects. So the dose of duloxetine could start from 20 and you go up to 60 milligram. Similarly with desvenlafaxine, you can start with 25 and go up to 200 with completely safe safety profile. This is 37-year-old Mrs. M. Again, visited her orthopedician with back pain. She had pain symptoms for a few months now. She had sleep issues also along with the pain. Very common, right? They're not able to sleep. The medications given by you had reduced her pain, but her sleep didn't get better. So her orthopedician gave her 0.25 milligram of alprazolam, no change, increased to 0.5, but the sleep disturbance did not get better. Do you think that sleep disturbances or insomnia as an independent or a comorbid issue with back symptoms or pain symptoms contribute to recovery? How, sir? How do they contribute? I mean, what is the contributing factor when we say, okay, let's fix the sleep? Sir?
Ma'am, sleep disturbances do not allow a patient to undergo the normal period of time that it would require for the patient's back, nucleus, nuclear material or her disc to expand, rehydrate. All those issues eventually affect the patient's outcome. As a matter of fact, I do not prefer alprazolam, I prefer clonazepam. I prefer to use a better drug, olanzapine, or it's slightly bordering on acting upon also the, along with SSRIs, to regulate the sleep cycle of the patient, and then they do much better. Along with that, sometimes they also add evabrad as a cardiac rate controller so that their panic attacks prior to surgery, post-surgery, all go down. They do much better.
Excellent, because you have to understand that when sir is talking about adding a beta blocker also, right? Anxiety causes autonomic hyperactivity, and that in itself kind of looks at unfavorable surgical outcome. As surgeons, you want good surgical outcome, right? You may be excellent in the OT, but if the patient's not feeling the relief, it's not going to help. And we know that sleep is essential for daily function and survival. Sleep disturbances for more than 2 weeks actually reduce the gray matter in your brain cells. So like sir was explaining about how it's going to impact recovery, because it's going to cause oxidative stress, inflammation is not going to get better. And insomnia is associated with a variety of psychiatric disorders. I'm not going to get into the studies. Insomnia is also a warning sign of depression. So if you, like you said, like sir said that he uses olanzapine or uses SSRI for a patient with sleep disturbances because it's not primary insomnia. The patient has an underlying depression, anxiety, not talking about the mood, but predominantly presenting to you as a clinician with sleep disturbance. So we need to fix the sleep, and what can you give? And I completely agree, alprazolam should not be the drug of choice. We see a lot of side effects, a lot of dependence potential with alprazolam, and that's why I had mentioned that the alprazolam was given. You have patients who have taken alprazolam and have gone up to 2 milligram. It causes a lot of cognitive dulling. It brings about neurodegeneration and early signs of dementia in your patient. What can you give? The safer options for you is to start on melatonin. You can give up to 10 to 15 milligram of melatonin. And even in patients who don't have issues, especially in an ICU setup, there's a lot of data and study which says that if you start melatonin prophylactically, the outcome post-surgery is better because you've slept better and surgical outcome is better. Clonazepam 0.5 mg, zolpidem, there's a newer molecule known as lambroxetin now. It works on the orexin system. Excellent with no early morning sedation. Patient is able to get back to work without feeling drowsy. This 65-year-old Mr. M was suffering from back issues for many years. He also had hypertension, diabetes mellitus, hypothyroidism. His family noticed that he was remaining aloof and did not wish to interact with his friends. He would remain in his room. He would constantly visit his doctor for his back pain. After a few weeks, his son visited the doctor saying that, I really wanted to thank you for the good care that you gave my father, but I wanted to inform you that my father hung himself and he passed away a few weeks back when the family members were away. Now, in patients with chronic pain and comorbid medical issues, it's very, very imperative to assess for depression. So any change in behavior must be evaluated. If someone expresses death wish, it's a red flag. It can be, doctor, what's the point of life? Kya kare zindagi mein? There's nothing left. I've seen everything. I've done everything. These are red flags for you as clinicians to maybe spend that extra 5 minutes and evaluate that patient for depression. I've had a good life so far. I'm looking forward to the next life. The family members observe that he's kind of Googling or become very philosophical, asking a lot of existential questions. What should we not say to these patients? Oh, you're just seeking attention. You'll get over it, it's just a phase. Think about how this will impact your family and friends. And we feel that when we say this to them, it'll kind of help them not to act on their thoughts and they'll think about their family, but they're depressed and they're not going to think about all these things. Snap out of it. Just be positive. You have so much to live for. Others have got it worse. Suicide is very selfish. You're being irrational. You're not the only one who feels this way. You should be grateful for what you have. I know exactly how you feel. You're too strong to let this get to you. Have you tried this before? You're being dramatic. This is all in your head. What should you say? Express concern and care. It's not that every patient in your busy OPD is going to talk about these things or bring about the change in behavior. So like for a particular procedure, when you require counseling, you need 5 minutes, and when some patients require 20, this is that patient who requires a little bit more of your time. So express concern, ask about open-ended questions, ask them about their mood, ask them about feelings of hopelessness, ask them about the symptoms of depression. Listen actively and non-judgmentally. It's very, very easy for us to say, okay, don't think like that. Because I have a lot of youngsters sometimes who come who have attempted suicide, and as part of the protocol in the hospital, we have to see them. And that person would have expressed it to somebody. It could be a general physician, it could be another doctor, it could be a family member. And we have just brushed it aside saying, oh, you're not going to do it. You have so much to look forward to in life. So listen, no, or we give advice, a lot of judgment. So non-judgmental. Validate their feelings. And please, this is a red flag. Do not try to treat a patient with suicidal ideations by yourself. You need to take the help of the psychiatrist, not even the counselor in the hospital. Because this is a medical or psychiatric emergency. Offer reassurance and stay with them and make sure that they are safe. So we have to identify, is there a problem? How can you do that in your busy OPDs? This is a very, very simple scale. It's called the PHQ-9. It's downloadable, free. It has only 9 parameters. Anybody can use this scale. Your receptionist can hand it over to your patient to just do it. And when the patient comes to you, you can just evaluate and tally up 9 points. And this is the score. And if you see that your patient has got scores of either mild to moderate to severe depression, then you must ask them to take professional help. So at the end of my talk, very important is collaborative work between you and us. to continue medications prescribed by the psychiatrist during hospital admission or surgery. Pain can be treated with SNRIs. You have to treat the insomnia. You look for signs of depression and anxiety and refer accordingly. Always look for suicidal thoughts in patients with chronic illness. You can use the PHQ-9 scale as a screening tool. Thank you very much for listening to me.
Amazing talk. I think it is gone straight. No, it's gone here. Because we come across these kinds of patients. Dr. Cheryl, thank you so much. It's been so nice of you. We'll break for lunch and we'll come back in about 15 minutes. We have an inauguration function to carry out. Please join us for lunch. You can leave your bags here. I'm going to run away with all of them. Hello, good afternoon, everybody. We are starting with our inauguration function. I please request all faculty and delegates to take their place in the auditorium. Can I please have everybody in within a minute's time? Thank you very much for your cooperation, please. All trade people, please stop all trade work. And all faculty and delegates, please come. Dr. Masato, 2 minutes. I'll call you. His name is I will be calling them later, no, on international faculty. Call him on behalf of Japan. Must do that much. एक लिख लो Japan करके. He is so keen on coming up, बुला लेना. ये दो इसमें क्या होने वाला है? Dr. Yumjinwa.
A very good afternoon. Um, we are about to start the inauguration ceremony of a traditional ceremony that we all Indians like to do, and light the lamp to invoke the good Lord to bless all those who took part in this conference and bless this activity and keep us in his guidance and blessings. So, friends, I welcome you for this 5th Endospine Conference and 3rd conference at the Holy Spirit Hospital, and the organizers are very indebted to the admin, Sister Lizzie, Dr. Susan, Dr. Anuja, for giving us this hall and allowing us to have this conference here. We appreciate their generosity. So what is new about this conference? This time we thought we'll have a conference with a difference where besides the hands-on, we'll talk about the technical difficulties that come when you do this procedure, the learning curve, the complications and the aftermath, and what do you learn and how do you make the break path. Besides this, we are happy that we have faculty from all over the world, starting with Argentina, Mexico. From Europe, we have in France and Spain, Middle East, Iraq, Syria, Algeria, Egypt, Saudi Arabia. In Asia Pacific, we have Nepal, Bangladesh, Thailand, Taiwan, Philippines, Singapore, Japan, South Korea, and Indonesia, and lot of Indian faculty, plus South Africa and Nepal. Plus this, we have Japanese faculty, Japanese professors, and Indonesian professors representing us, this conference. Most importantly, our Indian faculty and all the delegates who are here. We are very thankful to you for coming, and we appreciate your coming all the way. Last meeting, we had more candidates and delegates and faculty, but this time there was a lot of last minute cancellations and we had to alter the program. And another new addition to this program was the psychiatric talk. This was which we felt was very important for us when we deal with spine patient, and we call our eminent psychiatrist who Dr. Senthil Cheryl Nathan, who gave us the talk, Dr. Cheryl Senthil Nathan. But the show of this program is the planning, the plan, the program, the play, the people involved, inspiring them, getting them together and performing well. There's one person, and one and the only is Dr. Malcolm Pestonji. We give him a big hand. We are very thankful to you for coming all the way. And then now I will call upon our Executive Director, Sister Lissy on the dais, Dr. Susan, our Medical Director on the dais. Dr. Sam, President of the World Federation of Spine Endoscopy, Egyptian Neurosurgery Society, Dr. Gautam from Indonesian Endoscopic Society, Dr. Masata from Japan, Dr. Yoon Jun Wah from Korea, from the UB Spine Society Turkish, Dr. Sigden, from the Spain, Dr. Ricardo, from Argentina, Dr. Maria Perez, from the Maharashtra Orthopedic Society, Orthopedic Association, Dr. Sailesh Hadgaonkar, Dr. Rohidas is there. Please come. As a World Endoscopic Spine Society, Dr. Kidan Badani, Bombay Spine Society. Dr. Kidan Badani was working here in the early 90s and was part of the heading the spine team. And Dr. Shaishav Shah, South Gujarat Orthopedic Association. Dr. Shaishav Shah. Anybody else? Dr. Bhupesh, our treasurer, Dr. Amit, our secretary. I see Dr. Anand Kavi is not there. Anyway, with this dignitaries. With this small introduction and getting the faculty and dignitaries on place on the board. Dr. Pau. I will request our Sister Lizzie to say a few words. Sister Lizzie is a dynamic leader of the hospital, well respected and called again and again. Every time she is here, she comes up with the trademark project. Last time she was here, she did the cardiac center, the ICUs, the cancer center. Now she is here for a much more bigger project, the Golden Jubilee wing. And she has a religious sister. She has been from all positions to Superior General here. And I think the last position is to become the Superior General of all the sisters at Rome. We wish her good luck. Over to you, Sister Lizzie.
Thank you, Dr. Andau, for your good, kind words. Respected dignitaries, faculty, and the delegates, I wish, on behalf of Holy Spirit Hospital, a very warm welcome to each one of you to Holy Spirit Hospital. It is indeed a proud privilege for us to partner with the Endoscopic Spine Foundation, India, for a third time to host the 5th World Congress on Endoscopic Spine Surgery in this campus. Holy Spirit Hospital always had a strong and competent orthopedic department with service and expertise, which of course included endoscopic surgeries. The endoscopic spine surgery was introduced in this hospital by Dr. Malcolm Pestonji, a well-known endoscopic spine surgeon, joining this hospital in 2021. He definitely takes a lot of interest in teaching and motivating the resident doctors in this unique art and skill, initiating them to the endoscopic spine surgery. Along with him is Dr. Nicholas Andao, a renowned orthopedic surgeon and HOD of orthopedic department at our hospital. And I must say, both of these determined and committed stalwarts with their unfailing enthusiasm have been great pillars of strength and support to each other, along with the team in organizing this mega event of 5th World Congress on Endoscopic Spine Surgery, for sharing your experience and expertise with each other. I'm certain that this modern method of minimally invasive surgery will benefit the delegates who have come from far and wide to attend it, and many more patients will gain from this cutting-edge surgical modality. Please feel at home at Holy Spirit Hospital. This is a charitable trust hospital owned and managed by the missionary sisters, servants of the Holy Spirit, hence the name Holy Spirit Hospital. It's an international organization across 56 countries. In many of the representatives from many of those countries which we called out, we are there in all 5 continents. Holy Spirit Hospital is a 57-year-old hospital, started as an outpatient clinic and developed into a 65-bed hospital in 1967 with the motto of service in love. From that humble beginning, Today, we are a 300-bed multi-speciality tertiary care hospital providing comprehensive health care to all. And as you can see, we are fortunate to have a large campus in the city of Mumbai. It is spread over 11 acres of land with greenery, allowing harmony with nature, which is conducive for healing, offering specialties, the latest in various specialties. And I wish this 5th World Conference all the success. May the purpose of benefiting many by this skillful technology be fulfilled, and may God's blessings be on all of you in all your initiatives and efforts in providing safe and quality care to the patients. All the very best, and God bless you.
Thank you, Sister Lisi, for a wonderful words. I now call upon our medical director, Dr. Susan Soda, who needs no introduction, but I must tell you some few words about her. She is a very lovable, respected person who is loved right from the administration to the lowest worker in the hospital. She is a great academician, and she brought a rise of academics in the hospital. And her department most of the time wins awards in all the conferences. She is very humanitarian and compassionate doctor, and is followed by not only people from Bombay but all over the world are our patients. And she always finds time for friends and those who are in need. Over to Dr. Susan Swader.
Good afternoon to everyone. Such kind words, Dr. Nicholas. I would have thought this was my eulogy. I welcome everyone here, the delegates, distinguished delegates on the stage, the faculty who've come in from all over India, the international candidates, the delegates and faculty. Welcome to Holy Spirit Hospital. Spine is such an important organ of the body, and it connects, the brain to the periphery. And on the 30th of July, 1967, a young girl learned that lesson. Joni Erickson was goofing around with her siblings in a creek, and she was a good athlete. She was a star student, and she took a dive in the pond, which was a relatively shallow part. That dive cost her a lot. She broke her cervical spine between C4, C5, and she remained a quadriplegic for the rest of her life. Gentlemen, all of you are experts in spine, and you all do know the whole gamut. There may be dramatic incidences of quadriplegia, paraplegia, but by far, you all see neurological deficits, you all see chronic pains, you all see people who suffer for so many years with back problems, and you all make a tangible difference in those lives. So you all keep on doing, innovating, improving, and we have to be thankful for all the new advances you all make in this field. It is an ever increasing aspect of progress in medicine, because with increasing longevity, people becoming more and more obese, sedentary lifestyles, we call sitting now the new smoking. You are going to get more and more patients who are going to have spinal disorders, and you all will be the people treating this ever-growing population who require this specialty. We are happy to know that India is one of the ones on the leaderboard as far as spine surgery goes. Germany, South Korea, countries like all the gentlemen represent and the ladies represent over here. But India, I believe Google puts us at number 3, and I'm happy to say that we are also a force to reckon with the type of surgeries that are performed in India. People over here, you'll also probably are very happy to know you're all in the billion-dollar league, because it is estimated that the expenditure on spine surgery is about $11 billion in 2022. You're in the big business. And with a compounded annual growth rate of a moderate 4.5%, you all will be about $30 billion by 2030. So you all are in the big league, gentlemen and ladies. So ever-growing business for you all, as well as the people in the industry behind over there. We would have to say that everyone benefits from this. And given the fact that you all are always innovating, I know the success rates now reach almost 80 to 90%. And I have to be saying this because one of our sisters who went through endoscopic spine surgery just 5 days ago is recovering today, and she's almost back to her regular job. So a big applause to the orthopedic team over here who has been instrumental in her recovery. The tangible difference you'll make in people's lives are beneficial to society in terms of the number of work days spent away from the workplace. Now people are getting back to work, having productive lives at the earliest compared to open spine surgery. I say a big thank you to everyone who has come here today, and especially to Dr. Nicholas Antau, Dr. Malcolm Pestonji, and I have to mention people who have grown the orthopedic department in the past. Dr. Joshipura was a very noteworthy national as international orthopedic surgeon. Dr. N.M. Shah, who was very well known for his pediatric orthopedic work. And now I am so grateful to both these gentlemen who have put Holy Spirit on the international map of endoscopic spine surgery. Welcome to Holy Spirit Hospital. Welcome to Mumbai in India. Thank you for coming here today. Thank you.
Friends, we have former past president of the Bombay Spine Society here, Dr. Ketan Badani. The good thing is he was with us in the early 90s and helped us in developing the spine surgery. I will request him to say a few words.
Thank you, Dr. Antau. Good afternoon, dignitaries on the stage, Dr. Susan, Sister Lizzie, and all the leading spine and endoscopic surgeons from across the world who have come as a faculty, to all the delegates who have come from different countries to attend this conference. On behalf of the Bombay Spine Society, we are happy to say that we are collaborating with the Endoscopic Spine Foundation to hold this a very nice conference on endoscopic spine surgery. I welcome all the delegates who have come here to learn the techniques in endoscopic and minimally invasive spine surgery, which are obviously the newer avenues in the treatment of spine problems. These are difficult techniques and there's a huge learning curve, but I'm sure by attending this conference, you're going to gain a lot from all the faculties from India and abroad, and here you are going to have very interesting debates on the different techniques, the advantages, disadvantages, and I'm sure you will have a lot of new learning to take and apply it in your learning process of endoscopic spine surgery. The Bombay Spine Society is a young society, and as it goes, Bombay is at the forefront of academics in India, and so is the case in spine surgery. Our association is just about 8 to 9 years old, and it has been formalized only in the last 2 to 3 years. So this platform of spine surgeons of Mumbai is a great place to associate the different spine surgeons coming together for academic as well as on social fronts. Any spine surgeon who is practicing within the greater Mumbai limits is welcome to join our association, and please do so because it will help the association grow, the academics grow. Thank you, and I welcome all the delegates and faculty to this August gathering. Thank you.
Now we start the lamp lighting ceremony. Could I call upon Sister Lizzie and Dr. Susan? Dr. Same. Dr. Masata. Dr. Sigan. Dr. Vedas. Dr. Ketan. Dr. Pao. You don't smoke, but you are very good in lighting the sticks. Huh? Dr. Marisa. Can we stand for the national anthem, please?
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Can I request all of you all to come near the stage and everybody else to come on the stage for a group photograph, please. Everyone, please. All of you all, please. Lena, even you. I would want my wife with me tonight, with me now. Come on, all the young crowd in front, please. Front of the stage. Let the world know that we are all one. I'm up.
Special guest appearance. Special guest appearance. Youngsters can come here. Come on, some people up also. Yeah, come Andrea.
Come here. Andrea, come here. This place.
Come, ma'am.
Come.
We are not orthopedic, so you don't have to be up front. All the ladies in the center, you see.
Lisa, what are you doing down? Come up. Anuja, ma'am, please. Smile, everybody. Thank you. Thank you, everybody. So much, no problem with you. Wherever you are, you'll be safe.
Yeah. Exactly.
Ma'am? It looks like. Kiran, mic on. Kiran, can you please organize the next session to start, please? Let's get the chairs down. Can I ask the support staff from outside to come in and help me get the chairs down, please? We have to start the next session in a minute. We have a very interesting session with all our international priceless speakers lined up. So let's get going.
लेके और डायरेक्ट कर देंगे हाँ लेके आओ तो हो जाएगा अभी आपका है मेरा नहीं है आपका लैपटॉप रहेगा तो HDMI है ना अपना नेक्स्ट सेशन की स्टार्ट है जरा शीट हाँ हो जाएगा आपका कनेक्ट
May I invite Dr. Yumjanwa to start with the next session, please? May I invite Dr. Pau and Dr. Maximi and Dr. Luftigatam to please chair the session. Dr. Pau, Dr. Luftigatam, and Dr. Maximi, please come and chair the session, please.
आया
So good afternoon, everybody. It's my pleasure and thank you for Dr. Malcolm. So I don't want to talk about which approach is better or no. Okay. You can do, sometimes we can do posterolateral approach and we can do posterolateral fusion and we can choose fusion, interbody fusion surgery. But I want to like to focus about endoscopic lumbar interbody fusion surgery. So why do you recommend
Dr. Son.
Okay. Endoscopic lumbar fusion surgery? So I came from South Korea, and now I'm working in Al Khalij Hospital in Abu Dhabi, UAE. Can I start? Okay. No disclosure. So what do you think? What do you think? Goals of spine fusion surgery. Number one, neural decompression, and we have to get stability, and we have to get bony fusion, and if possible, we have to get alignment reconcile coronal sagittal balance. But most doctors concerns about for endoscopic spine fusion surgery because incomplete decompression and postoperative dysesthesia, and how can you control bleeding? So fusion surgery is possible with endoscope. How about the fusion rate? Fusion rate is same, or we worry about fusion rate? What about the reproducibility and expensive instrument and steep learning curve and more other things? So which approach is the best for fusion surgery? There are several approaches for fusion surgery, lip surgery, and O-lip surgery, X-lip surgery, and T-lip surgery, P-lip surgery. Which approach is best, do you think? Maybe all approaches has advantages and disadvantages. But fortunately, 82% of pathology L4-5, L5-SN level. Or unfortunately, L4-5, L5-SN level. I want to focus about this level only. Multi-level fusion surgery, maybe not my concern, okay? Endoscopic surgeon, just I want to do 1 or 2 level only. Why do you do endoscopic surgery, 3 level, 4 level, 5 level? We are not deformity surgeon, okay? So, which is the best approach for L4-5, L5-SN level? What do you think? So some American doctors are now in prone single position, X-lip cage, they can put X-lip cage, they like single position. Prone single position. Why do you like prone single position? Because the lateral approach is not good for fusion surgery. So prone position is best for the fusion surgery, I think. Do you agree? Some doctors don't agree. But what do you think of pros of endoscopic fusion surgery? So vision is very nice, and no or less retraction. So we can decrease the soft tissue damage. Also, high BMI patient have many advantages. Also, we can do possible with local anesthesia and one of the factor of ERAS. Obesity is pandemic. But fortunately, with endoscopic surgery, we can solve this problem. So cons of endoscopic fusion surgery, learning curve. It's not easy. Also, it's difficult. More than, we have to correct 15 degree more lordosis correction. It's not easy. I don't recommend. Let them do this kind of job to deformity surgeon. I'm not deformity surgeon. Okay? So multiple levels. I don't like multiple levels because it takes too long time. I don't like. And also normal cell line based surgery. So for better spine fusion surgery, what do you think? Precise and gentle endo preparation is necessary. Why do you think for better spine fusion surgery, you need endo preparation should be good? Why? Do you know what's the reason? I don't think it's not important. But large footprint between apophyseal ring is very important, I think. So also, cage position is very important for balance. And we can use osteobiologic materials. So fusion rate and approaches, there are some relations. So PLIP surgery is better than endoscopic fusion surgery. Lip surgery has a fusion rate is higher than other surgery. Do you think? I think there is no relation, fusion rate and approaches. So if you're doing a liver or lip surgery, if you put a small cage, not a bigger cage, the fusion rate will be high? I don't think so. Footprint is very important. So Dr. Ho published postoperative endoscopic fusion surgery. Fusion rate is 87.5. So what do you think affecting factors for fusion rate? Bigger cages. bigger will be better. And the preparation, also good point. Then we have to do spine, we have to get spine balance and materials of cage. And we can use bone materials too. So for good end preparation, what should we do? We have to get a good surgical view of end plate. And we have to use a large instrument for good end preparation. If you use a small instrument, we cannot get a good end preparation. Just the only footprint is very small. If you are doing under endoscopic control, we can see the end preparation where. We can see the where, but we can get a large area of end preparation we don't know. It's very limited. So actually, this is my personal opinion, okay? So open surgery and MIS tubular surgery, we can use a large instrument. But unfortunately, uniportal endoscopy, we cannot use a large instrument. That's the problem. It takes a long time. Also, cage size and cage position is very important. So let's look at the cage size. Tilly cage is width is 18 and length is 28. Exley cage is 18 and 40, 45, 50. Large footprint. Let's look at the cage position. Unfortunately, the center of end plate is the weakest part. The example of this is what I did, endoscopic TLIP surgery. Look at the cage size, okay? And the cage is the center of end plate. I used the banana cage, but still center of end plate. I used the X-TILI cage, Oli cage, but still center on the end plate, but better, not 100% perfect. But if you use X-TILI cage, very big X-TILI cage, we can support apophyseal ring. Very nice. We cannot deny. So this is an example of a good cage position. So I think TLIP surgery, because TLIP surgery is familiar to spine surgeon, if you use bigger, larger cage, is better procedure. So with the biportal endoscopic surgery, I can use a TLIP cage and Oli cage, and Yuri developed DualX expandable cage, but it's very expensive. I made these X-TILI cages. So I used sometimes expandable cages, but despite the greater surface contact area, but high rate is subsidence, over-promising, because the cages, if can expand, the contact area is getting bigger, but the only center of end plate, the cage is center of end plate. That's the problem. We cannot support apophyseal ring. So this is a DualX expandable case, but subsidence, we have to worry about that. We analyzed many cases, and what I'm doing is like this. And post-operative wound is not big problem, but patient feel happy after surgery. Let's look at the cases. Number one, 65-year-old patient, 6 months before endoscopic compressed surgery was done, but still there is L5S reverse stenosis and lateral stenosis. So we can see the end preparation, okay? Very nice, looks very nice. Just we can see the end preparation. How large this area is, we don't know. And we can get enough autobone. Already I removed the facet joint totally, L5S level. This is transforaminal approach. We can see the exiting the root and medially. We cannot see the traversing the root, but there is transversing the root. So we can use a conventional instrument without limitation. And as you see, surgical view is very nice. Because of normal cell line, we can prevent tiny bleeding. We can control bleeding without use any kind of bipolar or electrocortical like that. But if you stop the normal cell line, as you experienced already, small tiny bleedings are coming out. We cannot control that kind of tiny bleeding without the normal cell line. So surgical procedure, same as minimally invasive fusion surgery. This is olive cage. Width is 18 and length is 40 or 45. So we can put an olive cage without novel retraction. This is post-op X-ray. And second case, post-op MRI, looks good. The next case is a 75-year-old patient, grade 1 spondylolisthesis patient. I did the paramedian approach, and procedure same as minimally invasive spine surgery. We can do total prostatectomy with calcium rongers, and sometimes I can use osteotome, and you can use a drill. Any kind of conventional instrument you can use without limitation. And also, I exposed the entire Cambion triangle. You have to see, especially L4 fiber level, the Cambion triangle, the space is...
The time is limited.
Oh, yeah. Yes, okay. I have to go. Okay. And this case is, I use the Durex expander cage, but it looks very nice, but it's very expensive, okay. $3,000, okay. Okay, too expensive, but looks very nice. So this case, I removed the previous cage and screws. In comparison, with bipolar endoscopic surgery, I can do it better, but significant individual learning curve, but mid to long-term investment needed. Okay, 2001, I met Dr. Arthur Gappa from Bahrain. He's my teacher, and now I can do fusion surgery. And my recommendations for beginners, we have to try open surgery first, and next MISS, and we can do hybrid surgery. And I recommend UBE, and next step will be monoportal endoscopic surgery. And next version will be come out, I think, next month. Okay? I'll be presenting a third EOC MIS Dubai conference. You can mark calendar, October 25th, okay. I will show my new endoscope. Bigger cases would be better, okay. I would recommend endoscopic TLIP surgery. Thank you very much for your attention.
Thank you. Shall we have the discussion after all the section? Yeah, the next speaker will be Dr. John from Korea. Please. Because of time for preparation, any question from the audience for Dr. On? Yeah, there is one question. Chidam, yeah. Please make it quick.
Sorry, I wonder, when you insert big cage, is it causes any nerve traction or nerve damage? What kind of, do you have complication?
Yes, good point. So actually, I worry about how can I put a large only cage into the small Cambridge triangle, okay? So L5SN usually no problem. If you review an article, L5SN's space is almost 20 millimeter like that. We have enough space. If you do a total prostatectomy, we can do it. But L4 level, the Cambridge triangle, the space is 16 or 17 sometimes, okay. But if you're going upper level, smaller. So I don't recommend the Cambridge triangle spaces. We can measure before surgery. Cambridge triangle, the length is less than 16. I don't recommend. But we can retract the nerve root, okay. Use the nerve root retractor. Also, I invented a special nerve root guide, okay. You can use that also, you know.
What kind of, do you have any complication?
What?
What kind of?
Yeah, complications. So actually, at first time, I recommend we need the euro monitoring. But one or two cases, the space is too small. So after surgery, transient transient neural damage happens. But almost 100%, there's no problem. Indication is very important.
Okay, thank you, Dr. On.
I think Dr. Yumjin in his last Congress had shown us the dimensions of the Kambin triangle in his last year's talk. So I would genuinely recommend all of you to see Dr. Yumjinwa's last Congress talk, where he had described the relationship and the size of the Kambin's triangle to decide on the size of the cage that you're supposed to put in. So there's a very wonderful talk. Please refer to it. So he wants to know the skin entry point for your XT leaf.
Same. You can use, but I recommend you have to make another entry point. So in Korea, we are using just entry point is the same, but we have to retract too much. But I recommend if you use want to use a large cage, you have to make another incision. I recommend, especially L5 vessel level, high lordosis patient, you have to make another incision. But it was 30 centimeter only, no problem. One more incision is no problem. You can make it biportal, 3-portal, 4-portal, no problem.
Well, thank you very much.
I personally prefer to go 1 centimeter outside the tip of the transverse process. So I take a very lateral XT leaf corridor all the time. Almost.
Okay, Dr. Juan, please.
Thank you. Thank you. Thank you for introducing me. I am Seokbong Jung, orthopedic surgeon in Jinjubon Hospital in South Korea. Nowadays, bipolar endoscopic surgery is becoming more popular all over the world. In our country too, especially for young spine surgeon. So my talk is bipolar endoscopic challenges in spine disease. I'm Professor Spine Korea delegate and Space Board member, ISS Academic Committee. I work at Jinjubon Hospital. Last October, I got a temporary medical license. So I demonstrated the 3 live surgery at Gangaram Hospital in New Delhi, stenosis 1, cervical 2, and the interbody fusion 3. It was a very meaningful time. I also took a video for your better understanding. Right region, digital portal, we grip the digital portal with the left hand. Advantage of bipolar endoscopic surgery, both use hand freely and independently. There is no need for additional equipment versus I always use arthroscopic equipment, shortening the operation time and less restriction on indications. To be expert in bipolar endoscopic spine surgery, I always emphasizing becoming ambidextrous and use a 30-degree scope. When using a 30-degree scope, the location of right source position in left region, 2 o'clock direction, and right region, 10 o'clock direction. These are bipolar endoscopic spine surgeries indication, lumbar, thoracic discectomy. Since 3 years ago, I have been expanding the indication as follows: multi-level fusion, OIL, myelopathy, and benign intradural extramedullary tumor. My experience since 2015 about 3,900 cases, among fusion 332, cervical 265. Now I will show you my paper first and show you related challenge cases. This is about treatment of multi-level spontaneous lumbar epidural hematoma. This paper was published in 2019 in Journal of Orthopedic Science. This patient is after playing soccer. They have bilateral low extremity and he had Coda equina syndrome, bilateral low extremity. On the MRI, you can see the hematoma signal in epidural space. Middle one is in enhanced MRI. You can see the high signal. At that time, we will be hematoma. I make four incisions for 3-level decompression. This is clip, video clip. Upper one is epidural fat. You can see the hematoma under the fat. Middle one is post-op 3 weeks post-operative MRI. The patient is work very well. Right one is post-operative scar. Ligamentum flavum, remove the ligamentum flavum, add fat. Remove the fat, you can see the hematoma. Okay. Next. This paper is published in 2019 in clinical spine surgery. It is about spinal stenosis, severe spinal stenosis with 30-degree oscilloscope. Left one is, this case is posterior epidural migration of lumbar disc fragment. Left one is mesh-like lesion on the, you can see the mesh-like lesion on the MRI. Right one is limb enhancement. Limb enhancement is characterized in the enhanced MRI. It is a very specific character in posterior epidural migration of lumbar disc fragment. This is a video clip. Right one is post-operative MRI, evacuation very well. Ligamentum flavum, remove the ligamentum flavum. This is posterior migrated disc fragment. I always use the probe to examine the nerve and dura. This is the decompression state. This paper, two papers is about cervical. First is cervical foraminotomy. Second is comparison of cervical foraminotomy and ACDF. Second paper, Dr. Ishant was named as a co-author. This case is a cervical myelopathy. 36-year-old male patient. He has a severe myelopathy with cervical severe spinal stenosis, and at C5 or 6. Right hand is post-operative MRI. You can see the sufficient decompression. This is a video clip. Upper lamina, upper marginal lower lamina, facetectomy with VO, remove the ligamentum flavum. Contralateral side, the base of spinous process. Contralateral side decompression at C5 or 6. We can do sufficient decompression. Right hand is a post-operative CT scan. We called it hemilaminectomy, cervical spine. This case is meningioma on C23. 83-year-old female patient. You can see on the intradural extramedullary tumor. Enhanced MRI, you can see the intradural tumor. CT scan is calcified intradural mass. I suspect intradural meningioma. This is a video clip. Cut the dural mater, longitudinal cut, remove the mass. Next is post-operative MRI. The picture below is post-operative CT scan. Another portal is needed. Two portal is working. Another portal is viewing. This biopsy is calcified meningioma. This patient is covered, all covered, work well. Post-operative 1.5 years, this MRI is evacuation is very well done. Thoracic OIL case is 59 male patient. You can see the big size OIL at T910. This video is OIL case. We always have to dissect the circumferential. So we need to find the normal dural matter. From that we dissect the mass. Right one is post-operative 2 months MRI. Normal dural matter and dissect the OIL mass. We are removing the OIL. This is a CT scan. Right one is the mass is well removed very well. Next case is multi-level lumbar fusion. This paper is published in 2022 in JNSA. 3-level degenerative spondylosis and spinal stenosis and foraminal stenosis. We 3-level fusion with pivotal technique. Right one is post-operative scar.
Dr. Chu?
Yes.
The time is
Using a 30-degree scope, you can the cage can be inserted under the direct visualization. 3-level vision also. Right spondylolisthesis is right one is complete reduction and decompression, and the revision also to with this technique. My opinion, once the surgeon becomes skilled in bipolar endoscopic surgery, there aren't many limitations for spinal surgery. Challenges we persist to make it commonplace. Thank you.
Thank you. We'll leave the discussion after the session. The next speaker will be Popesh, Dr. Popesh. Please.
Good afternoon, everyone. So today, my topic is cervical myelopathy, posterior endoscopic decompression, step-by-step videos presentation. So again, as we know, endoscopic surgery in lumbar spine is a common nowadays. Almost everybody is now started picking up this surgery, and everybody doing nicely. Even many centers are doing cervical endoscopy, but for foraminal and paracentral disc. But doing cervical endoscopy for cervical and thoracic myelopathy relatively new because related complications. In this presentation, I'll elaborate the step-by-step video of cervical myelopathy. What are the indications of posterior surgery? Sky is the limit. Whatever the amount of the skill you have, you can do endoscopy. But generally, we don't prefer C1, C2. Rest of the level, we can do endoscopic. Preferably, lordosis should be preserved so we can see the posterior fallback of cord. Disease should be preferably more or posterior than anterior. And initial, we start with a single level and then progress to the multi-level. So we can see like this. Here, the disease is more on anterior side. So here, I don't recommend to do posterior discectomy, posterior decompression. So I'll start with one case. Is a 43-year-old male with bilateral tingling numbness, upper limb grip weakness, and walking instability. You can see on MRI, there is significant C3, C4 myelopathy, preferably on a posterior, and very good lordosis preservation. And there is no instability on dynamic X-ray. So when we initially start with the spinolaminar V junction. We call it the lamino and lateral mass junction or spinolaminar junction. Start drilling with that junction. Playing over there, but not here. So you can see we started with the spinolaminar junction and now we are drilling upper lamina. So first we drill the upper lamina tills midline, then we drill, then we start drilling on the contralateral side. So upper part of lamina we drill till we reach the junction and we just see the whether ligamentum flavum is ending. So we can see this is pinkish epidural tissue or cord tissue. And second part, now you can see we have finished drilling on the upper lamina. So now we are drilling on the contralateral side. So you drill, you can see the angulation relation of the scope. So you are almost sliding on around 30 to 45 degree, and you drill the contralateral lamina, the base of contralateral lamina. Here we don't disturb the spinous process. So posterior muscle, spinal ligament, interspinous muscle are preserved. So there is less chances of muscle atrophy postoperatively. So once you finish the contralateral drilling, then you drill the ipsilateral lower lamina and contralateral lower lamina. So the purpose is to detach the ligamentum flavum from all the side and remove the ligamentum flavum and block. So when you drill on the contralateral side, just be very careful because here cervical cord is already compromised because of stenosis, and your even slightest of movement transmitted the cord and patient might end up with the weakness. So once you finish the bony work, you can see now all four corners we have completely free the ligamentum flavum from all four bony corners, even contralateral side also. And then you remove the ligamentum flavum and block. So once you remove the ligamentum flavum, this is the final picture. So pedicle to pedicle decompression, ipsilateral as well as on contralateral side. So there is complete decompression on ipsilateral side as well as contralateral side. So cord is free from all the side. And this is one more case. You can see there's a C4, C5 myelopathy. Again, good preserved lordosis. So we choose to prefer posterior surgery. And this is again end picture of this thing. You can see the ipsilateral, we see the root on the ipsilateral side because he has a symptom on the left side. And then we go to the contralateral side. So contralateral side, this complete cord is free from all the stenosis and all the compressive element on the contralateral side also. So nowadays we can also start doing endoscopy in cervical pathology also. So posterior endoscopic cervical decompression for cardiomyopathy can be done safely. Start from ipsilateral spinolaminar junction, upper lamina, contralateral upper lamina, ipsilateral and contralateral lower lamina. Adequate decompression can be achieved with a single as well as multi-level. So I have tried till that I have tried almost three level posterior cervical endoscopic decompression with a single incision. So if you have stenosis at C3-4, 4-5, 5-1, so dock on the 4-5. So you can go to the 3-4 also and 5-6 also, because your cervical spine is a lordosis and lamina is not that large what we find in the lumbar spine. So you can adequately decompression 3 level with single incision. And again, learn from your master, which will shorten your learning curve. Okay, thank you.
Bhupesh, while we wait for the next speaker, maybe you can just tell me your C5 nerve root decompression in this manner. Are you having any worries about a fallout in that specific nerve root?
Yeah, even we suppose patient has symptom on the right side, so we start doing decompression from the right side. Or bilateral patient has stenosis symptoms on a bilateral upper limb symptoms, then we also see the contralateral nerve root also, adequately decompress the contralateral nerve root also, both sides. So whichever the side the symptom is more, we start from that side.
Yeah, I mean, I'm just wondering, you know, you find that C5 is often very precarious when you decompress it, whether it be anterior or posterior.
Okay.
Sean, the C5.
Yeah, transient C5.
Yeah, you get it. C5 fallacy is a very common thing. But what at least the protocol I follow is I put my patients on riluzole, topiramate, a little steroid a day before. And I've seen that in cervical spine, as you start exposing the root, there's a tectorial membrane above the root. Only if it is very thick and very compressive should you touch that membrane. Otherwise, don't touch the membrane on the root. Many surgeons have the habit of playing around with the root, freeing it completely. Don't do that. You want to prevent the fallback of the root, correct? So if you want to prevent the fallback of the root, do not play with the root. Only if the membrane on the root is very, very thick and compressive, should you partially release it. Now, after following that protocol, believe me, I have not had a C5 palsy at all. Because I suffered this twice. One patient took almost 30 months to recover. So it's a very valid point.
What I suggest, C5 palsy, I think in all the audience, nobody knows how it occurs and why it occurs. Many times, even severe stenosis, it doesn't happen. And even mild stenosis, you do only 2-level laminectomy, C5 palsy occurs. So it's very debatable topic. Why it occurs, nobody exactly knows. Sorry? Yeah, we can remove the disc. If disc is only part, the central part of the disc we cannot remove, but paracentral, foraminal disc we can easily remove from posterior only. You don't need to go anterior. Central disc, yes, we can. We should not attempt to remove the central disc because chances of worsening neurological weakness is high.
Okay, the next speaker will be the Dr. Santosh. Santosh, is that okay? Can we start? Yes, please.
Speaking about the cervical posterior approaches, as Dr. Patel has already told about the use of posterior decompression for the myelopathy, on the use of posterior approaches for the foraminotomy and the endosectomy, actually. So when we compare, definitely the vision is far better as compared to any microscopic or any open procedure in the endoscopy. So definitely this technique is going to stay, and it's the future of the spine surgery. And when we talk about the full endoscopic foraminotomy, is the best indication for the posterior approaches. Even the large herniation with the major component of the paracentral can also be treated with this. And so it's good for both the indications, stenosis as well as foraminal stenosis, as well as for paracentral disc. But central disc cannot be approached. That's the contraindication for the posterior approach. And for that matter, you should use anterior approaches. So this is regarding the positioning. The patient has to be kept in the reverse tenderward position just to keep the head a little higher, just to avoid the complications of the intracerebral pressure. And next thing is to mark the skin markings. The important thing is to be in the proper AP view, where the pedicles are equidistant and the spinous process is midline, and then we mark the spinous process line, and second line is the measurement of mid-pedicular line or medial pedicular line. In the lateral view, we have two slight craniocaudal angulation in the line of the disc. And maybe we can use the third line as facet line, and the ideal trajectory is lying between the facet line and disc line. And working sleeve has to be on the medial pedicular line on the articular pillar, right on the articular pillar. So you should always feel the bone while putting the dilator and of your obturator. Or maybe you can use initially the LP needle just to have a idea of the right trajectory, because in the it's very easy to get lost or miss the level in the cervical spine, because the angulation of spine is the spaces between the adjacent level is not very much. So maybe you can end up in the wrong level. So it's better to initially start with the LP needle just to see whether the approach we are making or the skin incision you're making is right in the direction of the intended disc. So the clear identification of landmarks is very important before the start of the drilling. And for example, in this case, 667 lamina, you need to identify first the cranial lamina, caudal lamina, and the facet joint. And this is the ideal picture where you can see the facet joint and starting of the V point. The V point is the trajectory between where the cranial lamina meets the caudal lamina. And from here, we can start the drilling cranially, caudally, and medially even, and depending upon the pathology. So first is the hemilometry and the identification of index level and the finding out the nerve root. So in cases of spinal stenosis, we talk about like the procedure almost same, the landing is almost same, but in cases of central stenosis or for the dorsal decompression of the cord, we need to sacrifice a little bit of the base of the spinous process just to go contralateral. So the drilling has to be very liberal at the base of the spinous process so that we can go to the contralateral side without putting much pressure on the dura. So it has to be like this. And otherwise, the angulation will be very steep and you can press the cord. So better to drill a lot of base of the spinous process just to reach contralateral. So this is a very important step to just go contralateral and decompress. I will play video. Maybe we can do multiple levels with this. This is a case of the C6, C7 discectomy. So first landing on the facet and try to clean the soft tissue. Once the soft tissue is cleared, you need to identify the V point and start maybe using the punch or 2 millimeter or 1 millimeter and do the cranial laminectomy initially. Just try to keep the ligamentum flavum last layer intact and come medially to the facet and expose the SAP as well as IAP and the caudal lamina. And here we can expose the nerve root. And even we can do a little bit of pedicle resection just to create a space in the axilla because most of the time the disc is either in the axilla or below the root. And maybe you can use nerve retractor just to retract the nerve root a little bit. And maybe you can use an end cut refine just to make a hole or in case of contained disc. And with the help of the forceps, you can take out the herniation. It's a big piece there. And you can see the free nerve root. And maybe you can check cranially as well caudally, just and mobilize the nerve root just to see any fragment is remaining there. And beside this, this is another video, just a short video. Here are two levels, C5, C4, C5, and C5, C6 from the single incision. The same technique, clearance of soft tissue. and start drilling. And sometimes you have to be very careful because sometimes ligamentum flammum is thin, so better you start drilling on the bone rather than toward the canal side. This is the cranial lamina. And use the hook just to break the adhesions, because sometimes in the chronic cases, there are a lot of adhesions between the nerve root. And it's very important to identify both the cranial and the caudal aspect of the nerve root. So in this case, sometimes the disc osteophyte can be removed with the help of trephine because the space is narrow. And this is the same technique. I just slide it across and came to the second level from the same incision just by the sliding technique. Just palpating the lamina, I just came across to the next level. So here the next level, and I removed the soft tissue here and did the second level from the same incision. And third indication is, one video is from the anterior cervical, where I did endoscopic ACDF. This is for the central pathology or for the compressive myelopathy. Needle placement, guide wire placement, obturator placement. And I'm using, this is the anterior surface of the disc. Started drilling the disc after finding out the proper trajectory. So it's the superior and the inferior vertebral body margins. And this is the disc. I stained it with the endocarmine. And this is the end plate preparation. Here also I'm using the 7.1 millimeter scope with a diameter of 10. The idea is to drill both the end plates, prepare both the end plates, and go as posterior possible, and just to remove the posterior osteophytes. And this I reach the posterior border and drilling the posterior osteophytes. Here the space becomes narrow. Sometimes you need to put traction on the head just to create a little bit of space, and use a little 1 millimeter Carrison. And now you can see the neural tissue, the last flimsy layer of the annulus. When I use this technique for sometimes for even simple central disc, calcified disc. So maybe pulsations are visible here. And with the help of retractors, I put the cage here. Not fully endoscopically, but just after using the retractor, I put the cage. That's it. So that's the end. So these are the indications for the anterior and the posterior endoscopic discectomy, and this is the work which I am doing. Thank you.
Thank you very much. Our next speaker, Dr.
Hello, dear dear audience. Thank you very much to the chairman. Thank you to Malcolm Pestoni for inviting me, and mostly for what he is doing, and for the money is mostly. Yesterday, Sean Venter already talked a lot about hybrid fusion surgery. Why doing such a thing, and what is it? So hybrid fusion is the addition of two techniques, actually, endoscopic posterior decompression and anterior or lateral interbody fusion. But why doing such a thing? As we show very beautiful presentation of posterior endoscopic interbody fusion with very good outcomes, good fusion rates, and etc. So why doing that? I'm a deep lover of anterior approaches, A-leaf, X-leaf, O-leaf, etc. And when I learned them, I wanted to apply to all of my patients who needed fusion. When then I learned endoscopy, I start my journey with Sean. I wanted to apply endoscopy to everybody. And as Sean saw yesterday, there is a point in which the two techniques can meet in a very good way, in the best way. So the anterior approaches are better respected to open surgery or microscopic surgery, and we saw it in many topics before, in terms of aggression of the posterior column, the end plate preparation, the disc space preparation, etc., with high fusion rates. But until endoscopy arrived, of course, these parameters have been reached by posterior endoscopy. But what about the disc 8, the lordoris, and the spinopelvic parameters, the sagittal balance we can restore by anterior approaches with very big footprints, cage, putting also in standalone situations. So, and it decreases because we can see very nice fusion of our patient, good outcome in the immediate one, but we still have to think about the long-term outcome and the adjacent segment disease. It has been showed in literature that it decreased with anterior approaches with correction of the spinopelvic parameters. So anterior, everything cannot be done anteriorly, of course, mostly indirect decompression or immediate decompression, but patient with stenosis will be impossible to do everything by anterior. So why not mixing the benefit of the two techniques to take the best of each one of them? So doing anterior or lateral interbody fusion in addition to a posterior UBE or monoportal endoscopy, decompression, and potentially putting screws as well, but you can still leave a standalone cage. So I have selected the patient I have operating from chronic radicular claudication and chronic back pain. We had very nice presentation about the indication, and I think clinic is the best one before interpreting the CT scan or the MRI or the dynamic X-rays. Of course, they will confirm your what you want to do, but the feeling of the patient symptoms, I think, is mandatory. And with all of the points of in radiological, so or spondylolisthesis or discopathic with the exclusion of complex deformity, more than 3 livers, and etc. So I have selected 23 patients, a very common European population for spine surgery. Most of the patients had the grade D stenosis, the other had the grade C, and those with a grade B actually were foraminal stenosis. Most of the patients had the spondylolisthesis, grade 1, and for a total number of 32 levels operated without any surprise, L4, F5 as the first step. Most of the patients had the X-leaf plus UBE, 5 patients had the A-leaf plus UBE, and 1 had also a posterior endoscopic T-leaf. All of the patients had a titanium 3D printed cage with no autologous bone, so this is not a bias, but this is a diminution of the impact of the bone graft.
and most of the patients had pedicular screws in addition. Most of the patients were operating in two positions during the same procedure, lateral plus prone, and one patient in supine and prone, and the other in single position, and those one had the best workflow, the best operative time. So the surgery consists into performing an X-leaf, an A-leaf, or lateral A-leaf, the XA-leaf. So this is the example of the XA-leaf, the anterolateral A-leaf for the fusion. And you see that you can do in the single position, the anterior, the lateral, and also the posterior screwing, actually. This is the classic X-leaf interbody fusion for reduction of coronal and sagittal unbalance. This is after the two example after the first step of the procedure. And then I won't show it for a long time because we saw much beautiful presentation of how doing spinal stenosis endoscopic procedure. So it was a very classical posterior decompression for the stenosis or a foraminotomy still in UBE kind of incision. And this is the result of some of the patients, so the anterior part or lateral part and the posterior endoscopic part with screwing. The kind of scares we have. And the result, the procedure duration, this is the main point because of course it's a different time, different positioning of the patient. So you see that if you increase the more than one level, it becomes much longer surgery. So this is the main issue of the technique. The distribution of the hospitalization, 3 to 4 days mostly, and of course the complication. This is we all have complication, and I always prefer to show complication when it occurs, especially in this one because I had one hematoma with immediate revision surgery, and one, I don't know if somebody added it in the audience, iatrogenic arachnoid cyst that I have provoked to my patient. But no infection, no CSF leak or neurological issue, neither transient. Because no retraction of the nerve roots, because the endoscopic was posterior only without disc work, and all of the anterior was done anteriorly, sorry. So you have the example of a dural tear. It was not this patient because I had not the video, but you can see this not related to the fusion, but related to UBE, to my surgery. The arachnoid cyst I have operated again after 3 months. So just the curiosity I wanted to show with good outcome afterward, and a posterior epidural hematoma. So the flow chart, 23 patients at the beginning. I didn't lost any patient, but they're just finishing the follow-up, the 19 that are now at 12 months. In terms of symptoms, a very significant improvement of the leg pain. You can see the outlier, which is the arachnoid cyst, reoperated at 3 months. Very good recuperation in terms of back pain as well, because still significant just after 6 weeks. And here you have also the walking distance, because we were dealing with stenosis actually as well. And here this is the ODI, the Odds vestry, with a very nice improvement after surgery. The Bridwell fusion grades. So I put inside grade 1 and grade 2, but the grade 1, of course, is the best fusion ever. So there is, it's not perfect, of course. It will never be perfect. We saw before a better fusion rate. And for what we are doing this surgery, I mean, we should all do that survey to our patient, because we can do very nice sagittal balance reduction, very nice decompression, a very nice improvement of pain. But if we don't ask to our patient independently, not from ourselves, the satisfaction, and I think it's why we are doing surgery, and spine surgery is pretty tough for that. Like the results are not so good. So 87% of the patient had a satisfied or very satisfying surgery after. For now, no revision rates, but if I am one on the fire, I think it will be reoperated soon. In conclusion, why putting together A-leaf, X-leaf, and endoscopy? Because both of technique are very powerful. Endoscopy here nobody will say the contrary. If not, you can leave the room. So putting them together have a great impact on the patient. I have to improve myself, improve surgical time. I'm switching versus single position for this kind of surgery. Of course, A-leaf and posterior is impossible. Improve fusion rates, probably by doing bone graft, heterologous bone graft. And Sean showed it yesterday with his fantastic technique for the bone grafting. So I think I will adapt it. And of course, I have to improve satisfaction rate. We should all improve satisfaction rate. So I have to be better, always better for the patient. We always learn, as said Malcolm before. So don't get stuck to one technique. I'm not talking about mono, biportal, etc. But all of the spine technique we can apply to the patient and use the right one for each patient, and don't be straightforward for all of them. Thank you very much.
Thank you, Francois. We're going to go to the next speaker, Dr. Sutipat. He's going to be talking on application of uniportal for transoral approach.
I have a question for Dr. Francois. Since the anterior fusion surgery, we usually use the very large cage to get the indirect decompression effect. If you have the very good indirect decompression effect, why do you do the decompression, UB decompression, immediately during the operation? Why don't you put it into the second stage if the patient still have symptoms?
Yes, exactly. But it could have been done also the contrary, because all of the patients had stenosis. I mean, for the foraminal stenosis, yes, it could be a point because of the high potential of indirect decompression of the foramen. But for the central canal stenosis, because all of the patients, almost all of them, had central canal stenosis plus the instability symptoms. So most of them were bony compression, actually. But it's, of course, yes, it's a good point. And I can tell you the verity. In 2 patients, when I open the canal behind, I say, okay, maybe it's already done. But only 2. It was only a feeling more than imaging.
Just a quick question. Post-op, do you have any issues with ileus and feeding the patients, or do you get on and let them eat after? Do you allow the patients to eat full ward diets after the operation? Are you worried about ileus formation having done anterior surgery?
No. Actually, before it was in the protocol, and now we remove it, so they can eat not heavy like we did last night, but they can eat liquids and no, not liquids, but not heavy stuff. Sorry, after.
Yes, good afternoon. I am Dr. Sutipat from Chiang Mai University, Thailand. I would like to say thank you to all faculty, especially Dr. Malcolm, to have me here. Yesterday I talked about the fully endoscopic assist odontoid fixation. Now I will talk about the transoral approach that I try to apply. This is only my journey. Our sniper or thief, right, with endoscope. Actually, I will talk about the transoral approach. They have a unique anatomy from anterior cervicals like this. The important, I will talk about this area, and the retropharyngeal space is very important in this approach. In the past, I do microscope for odontoid, like odontoid pathology from anterior, from transoral approach, and published something. This patient is pseudo gout with high spinal cord compressions and C1-2 instability, and he also have a lower cervical myelopathy too. So we do the transoral approach and microscopic odontoidectomy and remove the tumor like this and fix with pedicle screw and what other bantam. A second case is unusual chordoma from C2 and high spinal cord compression too. The patient cannot breathe themselves, himself, like this. I do the transoral odontoidectomy and remove the tumor as much as I can, and after the compression is like this. Is quite good, and this is a follow-up 2 years. You can see the some newborn formations. Yeah. This is another case of union odontoid fractures and instabilities, and the piece of the odontoid that displays from to posterior and remove the pieces of odontoid and fix from posterior. How can we apply endoscope for transoral approach? I try cadaver first. I try to study the layer and how the problems that we face when do the transoral odontoidectomy is a thick ligament, in my opinion. How to deal with the thick ligament, but the bone is okay. You can burr. This is a good candidate cases, and for transoral odontoid, like you use a uniportal endoscope. Is a boy, 7 years old boy with aneurysmal bone cyst. We try to he present with neck pain. Neck pain is gonna be impending fracture, right? You need to do something. I plan to do the transoral, remove the cyst or something and put the bone graft inside the odontoid, like this, and level checking and open and open and use the endoscope inside and clear the soft tissue. You can see the little pharyngeal space and traction a little bit left and right side of a tissue. And okay, remove this tissue and burr after that. Remove the soft tissue. The important landmark is anterior arch of C1. This case we approach to inferior part, just inferior part of anterior arch of C1. And burr, and you can the yellow tissue inside the bone is a hemosiderin deposit, and remove it. And check again. It's clear, and move up and move down, and use a mini open iliac bone graft and packing inside the odontoid. We can pack with endoscope. Like this. Okay, this is a post-operative X-ray, and this is a 3-month CT scan. There's a newborn formation. That's good. The second case is more complicated. This is the patient with little odontoid pseudotumor, C1 and C1 here, C2, and high spinal cord compression have a little C1-2 instabilities. And he also have thoracic OIL and spinal cord signal change too, and lower cervical compression, but not severe. And we plan do three things. One is endoscopic or microscopic assist transoral odontoidectomy and flip the patient to prone and do the microscopic assist OIL removal of T10 and T11. And third is occipital cervical fusions and PSIS bone graft. First is fiber optic nasal tube and put the position like this. It's like you do the ACDF and open the mouth and this is a Dingman retractor. You can request from ENT doctors and check the level. The good landmark is anterior arch of C1. You can palpate with your fingers or blunt cup or something, and you want the picture like this. And application the endoscope. After you open the retropharyngeal space, and you may see the big the vein. Okay, how to deal with vein is a cautery, proximal and distal, and remove it. That's all. And go inside, clear the soft tissue above the anterior arch of C1, like this. And use a burr, left and right side of the anterior arch of C1 and take it off. Like make a sleeve and take it off. Okay, and we go faster. This is a piece of anterior arch of C1. And after that is a midnight. So I change to microscope and use a burr for this is an odontoid. And cut the base of the odontoid and clear the surround soft tissue. The midnight because I have 3 cases in the evening. Clear the soft tissue left and right. Okay, skip fastly. And the problem is soft tissue, very thick. And after you remove, you may see the PLL. But in this case, we see the thick tissue is made pseudotumor and remove it. And you can see the PLL after that. This, after remove the odontoid, this is a thick tissue. Okay, and remove and can see the PLL and also dura. This. And remove the left and right soft tissue. Okay, this is the last pictures. Okay, this is the pieces of the bone. And after that, flip the patient and use the O-arm navigate. I plan to put the occipital cervical fixation and fusions. Pedicle, this you can see the odontoid is disappear. Okay, after that, put the pedicle, cervical pedicle fixation of C2 and C3. And this is the last construction. Okay, this is my journey. And after that, do the thoracic. Okay, that's its end. May I introduce another meeting next month in Da Nang, Vietnam. It's ASEAN Next in Da Nang, Vietnam. It's gonna be 25th to 27 July, Da Nang in Vietnam. Thank you.
Staying with the cervical theme, Dr.
Your technique is maybe better than me. However, you should know what you can do and what you should do. So that last one is a shoot tumor you said. It's not a real tumor. So there are a lot of paper. Just fuse it. It will disappear. Or just OC fusion and remove C1 lamina. It's a very simple one. It's not necessary to remove odontoid process. Why you do this kind of? There are a lot of paper, as you know. You are so smart. Just fuse it. Sometimes she want to modified Goer technique is enough. And if it's not, so OC2 fusion and remove C1 lamina. That's enough.
See,
Last one.
I not understand clearly. So again, please, why
you remove shoot tumor? It's not necessary to remove.
Yeah, not necessary to remove.
Remove shoot tumor. It's not a real tumor, and and of course, odontoid process you don't have to remove. Just decompress is enough.
Decompression from posterior.
Yes, because
cut
you
out the
also
posterior as of
approach
C1.
from.
Okay. In my case, the first is the patient have high spinal cord like a high spinal cord compression a lot. The second reason is have the C1 to instability.
Of course.
So yeah. So and I am familiar with the transoral odontoids.
Yeah, that's why I said what you can do and what you should do is different.
Yes.
I thank you. Thanks the organizers. I'm from Delhi. I'm very new to UB. I've just started almost 1.5 years. I've been trained into tubular from Urudul, and I left tubular because it was difficult for me to manage in a government sector. So now I have started doing cervical foraminotomies. Why cervical foraminotomy? Because it's just a replication of your microscopic approach. You have unrestricted use of instruments as compared to the uniportal. We use the similar instruments what we use for open surgery. It's a magnified use, and there's a benefit of the continuous line outflow. The results are comparable or not. I'm just 1.5 years down the line. I have just 11, and one case was operated by Dr. Jung at Gangaram. Patients have been doing fine for the last 1.5 years, and just we've incorporated this. I stopped doing tubular because there was patients who used to come with muscle spasm. There is a tuck which is there, and they used to have that. This is a gross looking scar. Even with the tubular, there was loss of lordosis. Recurrence was always an issue. The indications, if you look at cervical foraminotomy, they are basically meant only for brachyalgia, unilateral symptoms. Whether it's an osteophyte or a disc, we'll show you. Avoid it in central lesions. Anything which is more than 2/3 of the occupying the canal, don't do foraminotomies and try to get the disc out from the posterior approach. There are two approaches which have been described. One is the ipsilateral approach and the other is the contralateral approach. In the ipsilateral approach, you go from the same side and you do a foraminotomy. On the contralateral side, you're doing it, you're basically going down the tunnel and you're basically trying to free the nerve root. How do we plan? We basically plan whether if you're doing a discectomy, my current approach would be to do just an ipsilateral approach, whether it's right or left. I started my first case, which was an inclinatory approach, to be frank over here. I would avoid it doing in a short stature female. I would not do a ipsilateral approach because you take down a lot of facet and you are more worried that you might cause instability. For a contralateral side, I would prefer if you have a patient who's a female patient and you're doing at the higher and the levels, you might think about doing a contralateral approach. It allows more lateral work. There is a learning curve which is associated with the contralateral approach. If you look at the steps of foraminotomy, you triangulate at the V point. It's similar to a microscopic approach. I did not have any formal training. I have been looking at videos from Jung and Pao and Dr. Son and Malcolm, and I have replicated into my practice. You start burring at the cranial lamina, mark the pedicle under the C-arm because you don't want to go lateral to it. I always palpate the medial wall. It's always a top pedicle. You feel the top pedicle and the lower pedicle to be sure where you're doing an adequate foraminotomy or not. Do not confuse the motor and the sensory nerve. The motor is the more thicker nerve, and the sensory nerve is the more thicker part, and the motor is the small white part. I always try to add the inferior pediculotomy when I'm doing a foraminotomy. I learned it from Jung that when you're doing a foraminotomy, that use a fine burr. Don't use the arthroscopic burr as we are using in UB. I use a mini RF wand because you need to have adequate control of bleeding, and the bleeding should be controlled initially in the part of your procedure. If you look at the cases, what we're doing, it's a 56-year-old male. He presented with right arm pain for 2 months. He said he was having difficulty in sleeping. Spurlings was positive, biceps and wrist was weak. There was a disc at C5, C6, and there's a big osteophyte. It's a calcified disc at C5, C6. We triangulate on the V point. Just a short video. We make the space, identify the V point. We start burring at the cranial lamina and move to the inferior lamina, taking down the facet joint. You need to have, you burr till you see the silhouette of the, where you have the silhouette, you just see the where your flavum is just coming off the bone. That would be the end of your work for your laminotomy. Then you use the 1 mm kerrison and you start